Good morning, ladies and gentlemen. We might make a start if we can, please. Thank you. Well, again, good morning and welcome. After a fairly amazing day yesterday, there was a brilliant selection of talks with leaders from both sides of Australian politics, from trade, and from our distinguished guests from overseas as well. It was a fantastic day. Today we hope to build on that. We are running a little bit behind time, so I won't keep anyone waiting. I do wish to invite Mr. George Bartoli, the Governor of Attica and President of the Medical Association in Athens and the President of the GDHI, up for his welcome, and then we'll begin on our concepts in cardiology. But first, we'll be hearing from Professor Papyrus, who is, of course, our President of our Medical Society and co-convener of the conference. Thank you, Marinas.
So thank you, George, and welcome. Welcome to everyone. You know, we're fortunate to be in Melbourne. Melbourne is, for those online, the largest Greek-speaking city outside Greece. And we're proud of it because outside Athens and Thessaloniki, the third city is Melbourne. And I'd like to welcome everyone to the scientific component today. I'd like to begin by acknowledging the traditional custodians of the land on which we meet and acknowledge their elders, past, present and emerging. And in Australia, you're good? Oh, good. We value our cultural, religious and linguistic diversity and acknowledge that there are vulnerable communities within our community who require support. I'd like to welcome our guests this morning from Greece. We have a few of them and it's terrific that they could come. There's Dr. Georgios Patoulis, the Governor of the Attica region, President of the Athens Medical Association, President of the Global Doctors Hippocratic Institute, Mayor of the Municipality of Marousi from 2006 to 2019. What an effort. Dr. Marios Themistokleos, the General Secretary of the Ministry of Health and the Hellenic Republic, President of the Central Health Procurement Authority for the Hellenic Republic, and is a consultant neurosurgeon. Dr. Konstantinos Pandos, the Director of Genesis Care in Greece, the first Vice President of the Global Doctors Hippocratic Institute, a member of the New York Academy of Sciences and member of the European Society of Human Embryology and Reproduction. Dr. Antonios Polidorou, the Secretary of the Global Doctors Hippocratic Institute, the Ambassador for Hellenic Tourism. He is a PhD from the University of Athens. He set up the first interventional unit in Greece when it came to cardiology, and we're honoured to have him here. Dr. Nicholas Skipetaris, thank you for making the trip from New York. He's a cardiac electrophysiologist, we'll hear from him soon, and is an assistant professor at Donald and Barbara Zucker School of Medicine and the Horsfall Northwell. It's amazing, when I talk to him, he is one of the largest healthcare organisations in the region. He's the regional director of electrophysiology, and they service 25% of the needs in New York State. So that's an impressive effort. Dr. Dimitrios Skleros. Dr. Dimitrios Skleros is a great doctor, but he's also a Lefkadian and somehow related to many of the doctors here in the room. He graduated from the University of Athens Medical School in Health Sciences, and he works in Philadelphia and he worked in Philadelphia and specialises in cardiovascular disease, internal medicine, and he's returned to Greece, where he's been working in internal medicine for a period of time. And of course, there's Professor Georgios Antonakis. He's the Dean of the Faculty of the School of Medicine, the University of Patra. And for all of you that aren't aware today, it was a very good day yesterday because we signed an agreement on Thursday, actually, an agreement with the University of Melbourne for an intention to collaborate between the University of Melbourne, Patra University, and the Athens Kapodistrian University. And that's the first medical school agreement that's been signed from Melbourne University with a Hellenic institution, or two of them. So well done to everyone involved, and it was a real pleasure helping brokering that deal. The Hellenic Diaspora World Congress is really the brainchild of the Global Doctors Hippocratic Institute and its president, Dr. Georgios Patoulis, and it aims to bring together the best minds from the Hellenic diaspora to share knowledge, network, connect, and really add value not only to their patients, but also the environment. We're proud of the history, we're proud of being linked to the father of Western medicine, Hippocrates, and we're proud of living and practicing by the ideals of the Hippocratic Oath. It's been a privilege to work with the organisation from Greece, to work with all the board members of the Global Doctors Hippocratic Institute in organising this conference. And obviously, I don't want to keep you too long because we have a fantastic dinner tonight, which is the fundraising dinner, the gala dinner, and in the spirit of true philanthropy, we'll be donating the proceeds to Bronya and Frodida, two worthwhile organisational groups here in Melbourne that do a lot of good work in community support. I'd like to thank our sponsors. These events don't happen easily without sponsors, and we have our platinum sponsors, Aritex and the Platform Alliance. We have our premier sponsors, the Accountancy Group, Windsor Management, and the major partners, the Manses Family Trust, Director Technology, and of course Imaging Associates, which is one of the radiology firms here in Melbourne. They've been very helpful and very supportive, and I'd like to thank them for all their support. I'd also like to thank our partner sponsors, our diamond sponsors including Commonwealth Bank, our platinum sponsors of Dorovich Pathology, and our gold sponsors of Zaparis Lawyers. Meetings such as this really affirm the multicultural, diverse and inclusive nature of Australia, and we're happy and proud to be able to bring together doctors who have a Hellenic background, and they may not only freely express their commitment and passion to Hellenism, but they can also share their ideas and help our patients move ahead and help government and government authorities understand that medicine is about people and it's about their own diverse values, and it's not just about the processes and the policies that are also important. So without further ado, I'd like to wish you all a very happy day today, and for those coming to the gala conference, please freshen up, and it'll be good to see you this evening. And for those that are unable to come, there is a link that we've sent out, and there's a silent auction, and if you'd like to contribute and help the two worthwhile organisations, please contribute and bid for the items, and there are some really great items like an AMG driving weekend, there's a weekend at the Crown, and many other things that I'm sure you'll enjoy. So now over to Dr. Georgios Patoulis, the President.
Καλημέρα σε όλους. Όπως έχω πει, μ' αρέσει να μιλάω την πατρική μας γλώσσα και στο συνέδριο, και προφανώς θεωρώ ότι σήμερα εκλεκτοί συνάδελφοι, κύριε Πρόεδρε, αγαπητοί συνδετημόνες στην προσπάθεια του Παγκόσμιου Ιπποκράτειου Ινστιτούτου, σας καλωσορίζω εκ μέρους του Παγκόσμιου Ιπποκράτειου Ινστιτούτου Ιατρών στην τρίτη ημέρα, στη δεύτερη μέρα του συνεδρίου. Και ομολογώ τις προηγούμενες 2 ημέρες κάθε ενότητα της ομιλίας μας είχε συναρπάσει. Σας συγχαίρω, αγαπητέ Πρόεδρε Μαρτίνη Πυρπυρή, για το συγκερασμό των θεμάτων, των απόψεων αλλά και των ανακοινώσεων της σύγχρονης επιστήμης, με θεματολογία της ιπποκρατικής ιατρικής σκέψης και προσέγγισης. Σε αυτό το εξαιρετικό πάντρεμα του Παγκόσμιου Συνεδρίου της Ελληνικής Ιατρικής Διασποράς, του Συνεδρίου της Ελληνικής Ιατρικής Εταιρείας της Αυστραλίας, αλλά και του ετήσιου Συνεδρίου του Παγκόσμιου Ιπποκράτειου Ινστιτούτου Γιατρών. Είναι, κατά την άποψή μου, μια κορυφαία διεθνής διοργάνωση που τιμά ή στόχο έχει να τιμήσει τον απανταχού Έλληνα γιατρό και αναδεικνύει σε υψηλό επίπεδο επιστημονικού διαλόγου τη βαθιά επίδραση του Ιπποκράτη στη σύγχρονη ιατρική. Δράτω της ευκαιρίας να αναφέρω ότι έχουμε ζητήσει επισήμως ως Παγκόσμιο Ιπποκράτειο Ινστιτούτο από το Οργανισμό Ηνωμένων Εθνών να καθιερωθεί η Παγκόσμια ημέρα μνήμης για τον Ιπποκράτη. Και έχουμε σκοπό να επιμείνουμε σε αυτό με όλες μας τις δυνάμεις και με όλους τους φορείς που σχετίζονται με την προσπάθειά μας και ζητούμε μάλιστα την υποστήριξη προς αυτό το στόχο ξένων χωρών και πόλεων με τις οποίες μοιραζόμαστε πρωτοβουλίες για την ανάδειξη του Ιπποκρατικού ιδεώδους. Απευθύνουμε λοιπόν και στη Μελβούρνη στους εκλεκτούς συναδέλφους της Διασποράς και στην ιατρική της κοινότητα, όπως και την ελληνική κοινότητα Μελβούρνης, που τόσο θερμά μας έχουν υποδεχτεί. Και βέβαια σε όλες τις πόλεις και τους ιατρικούς συλλόγους της Αυστραλίας. Ας δώσουμε με αυτές τις λίγες σκέψεις το λόγο στους επόμενους ομιλητές και θα επανέλθουμε μιλώντας και για το κομμάτι της ηθικής και δεοντολογίας της ιατρικής σε λίγο χρόνο αργότερα. Ευχαριστώ πολύ.
While we're waiting for the people to link in, we have a couple of welcomes from overseas. I'd like just to mention to everyone that the Global Doctors Hippocratic Institute, to everyone here and online, has kindly offered that we may all join the institution online. And they've also kindly offered that they are willing to waive the first years of fees for our continued support and also our engagement with their organisation. So please log on and join the Global Doctors Hippocratic Institute. And if you go to the website, you'll be able to find the link at the bottom of the President, Dr. Patula's welcome introduction. Thank you.
Thank you very much, Marinas. We now have a couple of online greetings. I would like to invite and hear from Dr. Kostadino Kuskouki, who is the second Vice President of the GDHI and also the President of National and Thermal Medicine in Greece as well. He's on mute.
Και καθιερώνεται πλέον αυτό το συνέδριο, το πρώτο παγκόσμιο, σαν ένα γεγονός το οποίο θα καταγραφεί στις μνήμες όλων των γιατρών και των επομένων γενεών. Είναι πολύ σημαντικό ότι ο Περιφερειάρχης μας, ο Πρόεδρος του Ιατρικού Συλλόγου Αθηνών, ο κ. Πατούλης, με μια εξαιρετική και επίλεκτη ομάδα επιστημόνων από την Ελλάδα, τον κ. Πάντο, τον κ. Πολυδόρου και πάρα πολλούς, να μην αναφέρω τα ονόματα, ήρθαν στην Αυστραλία γιατί έχουν ένα κοινό σκοπό με εσάς όλους εκεί. Κύριε Πρόεδρε, και συγχαρητήρια για την οργάνωση. Μαζί με τον κύριο Παπαστεριάδη, εκεί τον πρόεδρο της ελληνικής κοινότητας, γίνεται λοιπόν μια σμίξη πνευμάτων, ιδεών και κυρίως το σπουδαιότερο απ' όλα είναι ότι όλοι έχουμε ένα κοινό σκοπό, τον τουρισμό υγείας. Γιατί εκεί αποβλέπουμε στην πνευματική, σωματική και ψυχική υγεία. Και όλοι μας έχουμε σκοπό να μπορέσουμε να δώσουμε δηλαδή στους ανθρώπους μας μακροζωία και ευζωία. Και αναφέρομαι ειδικότερα στον τουρισμό υγείας και ακόμη ειδικότερα στον τουρισμό ευεξίας, που είναι πάρα πολύ καθοριστική δράση, η οποία έχει πολύ μεγάλη δυνατότητα, όχι μόνο επιστημονική, αλλά και επιχειρηματική με προστιθέμενη αξία, αρκεί να ξέρετε όλοι, όπως γνωρίζετε, 4,2-3 εκατομμύρια παγκοσμίως διακινούνται. Άρα λοιπόν είναι μια μεγάλη ευκαιρία να ενώσουμε δυνάμεις για να μπορέσουμε να αξιοποιήσουμε και να αναδείξουμε τον Ιπποκράτη, είτε με την ιαματική ιατρική, που είμαι πρόεδρος της Ακαδημίας, και με αυτό το σκεπτικό είμαι δίπλα σας και χαίρομαι πραγματικά που επικοινωνώ με τόσους εξαιρετικούς συναδέλφους ανά τον κόσμο και ήταν ένα όνειρο του κυρίου Πατούλη, το οποίο πραγματικά εκπληρώνεται, αλλά βάζει και υποδομές. Υπογράφει υποθήκες αυτή τη στιγμή όλη η ελληνική παρουσία εκεί. Γι' αυτό το λόγο σας εύχομαι καλή επιτυχία και είμαι δίπλα σας σε όλα τα επίπεδα να προσφέρω με όλες μου τις δυνάμεις σωματικές, πνευματικές και ψυχικές. Καλή επιτυχία.
Thank you, Dr. Kuskouki. Really appreciate your kind words. We now also have Dr. Gelikiga ready from Canada, I believe, and ready for her welcome.
Καλημέρα και από εμένα. Λέγομαι Αγγελική Γερετέ. Χαίρομαι που μπορώ να μοιράζομαι μαζί σας τη γλώσσα μας. Καλημέρα στην Αυστραλία. Πολλά συγχαρητήρια σε εσάς. Σας μιλώ από το βόρειο-ανατολικό άκρο της Ελλάδος, από την Αλεξανδρούπολη. Είμαι η επίκουρη καθηγήτρια ναυτικής γυναικολογίας έμβριο-μητρικής ιατρικής στο Πανεπιστήμιο της Θράκης και γενική γραμματέας της Ελληνικής Εταιρείας Εμβριομητρικής Ιατρικής. Πέραν αυτού, έζησα το πιο μεγάλο μέρος της ζωής μου στην Κεντρική Ευρώπη, στη Γερμανία. Είμαι μέλος του Διοικητικού Συμβουλίου της Ελληνογερμανικής Εταιρείας Νευτήρων Γυναικολόγων. Χαίρομαι πάρα πολύ για την πρωτοβουλία σας. Πολλά συγχαρητήρια στους ιατρούς, Έλληνες ιατρούς της Αυστραλίας, στον κύριο Πατούλη, στον κύριο Πάντο, στον κύριο Πολυδόρου για την πρωτοβουλία και την προαγωγή των Ελλήνων γιατρών στο εξωτερικό. Θα κάνουμε ό,τι μπορούμε να ενισχύσουμε την προσπάθειά σας και να επαναλάβουμε τέτοιου είδους εκδηλώσεις και σε άλλες πόλεις και χώρες σε αυτόν τον κόσμο. Πολλά συγχαρητήρια, καλή επιτυχία στο συνέδριό σας και σας περιμένουμε σύντομα στην Ελλάδα.
Thank you very much, Dr. Good. I appreciate your kind words as well. We'll now move forward to the more formal part of the program today. Our first session is on current concepts in cardiology. I must apologise on behalf of Associate Professor Arthur Nassis, who's a very close friend of mine and also the Vice President of the HMSA. He unfortunately contracted COVID on Tuesday. I offered to bring him chicken soup on Thursday. It didn't work, so he's unfortunately still not here. So we'll move forward to Dr. Nicholas Yaskibataris with his talk, Making Order Out of the Chaos Ablation Therapy for Atrial Fibrillation. Now, Dr. Skibataris is a practicing board-certified cardiac electrophysiologist. He's based in New York City at Northwell Health at Lenoxville Hospital. He's the Western Regional Director of Cardiac Electrophysiology for the Northwell Health System, which is the largest health system in New York and the Northeast. He's an Associate Professor of Cardiovascular Medicine in the Zucker School of Medicine at Hofstra University, and in addition to his MD degree, he recently completed an MBA at the MIT Sloan School of Management, which is a fantastic effort. He's an expert in the treatment of cardiac arrhythmias and has a particular interest in the treatment of atrial fibrillation. This is the longest trip that he's taken for a 20-minute presentation, but he's thrilled to be here and we're thrilled to have him. Thank you very much, Nicholas.
Good morning, distinguished guests. It's my honor to be here. I'm a very proud Greek American, proud of my heritage, but particularly proud of the contribution that we as Greeks, as Hellenes, have made to the world in so many things. And if you just look at the wealth and breadth of and the depth of contributions, even from today's conferences and the discussions we had yesterday, it fills me with pride. So the 25-hour trip that I made from New York is fulfilled being here. So I'm going to take us to a little bit of a different direction, talk to you today about what I spend the great majority of my day doing, which is taking care of patients with atrial fibrillation, and just show you some exciting things that are happening in terms of the treatment of atrial fibrillation. I'd like to make order out of the chaos and talk to you about ablation therapy for AFib in 2022. For those of you who are not aware of what atrial fibrillation is, it's the most common arrhythmia problem that we treat. Just based upon some demographic information here, it's a disease that increases in its prevalence as we get older with each decade of life. By the time we're in our 80s, approximately 10% of the population, certainly in the Western world, will have atrial fibrillation. So it's a very common arrhythmia problem. Who gets atrial fibrillation? The typical cardiovascular risk factors are associated also with atrial fibrillation: hypertension, ischemic heart disease, hyperlipidemia, valvular disease, diabetes, etc. Obstructive sleep apnea also happens to be one of the illnesses that are associated with atrial fibrillation as well. But what's the big deal about atrial fibrillation? Well, atrial fibrillation is associated with a 5 times increased incidence of stroke. On the right panel here, we see a picture of a cardiac echo. And right here, you see a big thrombus clot that's just waiting to dislodge and cause a massive stroke. The problem with the strokes that are due to atrial fibrillation is that they tend to be significantly more devastating than TIAs or other types of strokes because they're associated with much larger clots and they're associated with a higher mortality, greater disability, longer hospital stays, poorer functional outcomes, and a lower chance of being discharged to home. So what are the therapeutic imperatives? I'm not going to spend a lot of time today talking to you about the importance of reducing the thromboembolic risk, because quite honestly, that's the most important thing to assess in patients who have atrial fibrillation. So everyone who has AFib should, for those of you who are not aware of the CHADS-2 VASC score, it's the best it's the best scoring system we have to assess the risk of someone's risk of having stroke with atrial fibrillation. It stands for congestive heart failure, hypertension, age greater than 65, diabetes, a history of stroke, or vascular disease, coronary or peripheral vascular disease. And there's a scoring system that we use to determine if patients are at higher or lower risk of stroke. But the bottom line is that anyone who is at risk for stroke with atrial fibrillation should be anticoagulated. And unlike when I first started training, when the only and best anticoagulant we had was Coumadin, we now have newer anticoagulants, which aren't so new anymore, which are very easy to take, very safe, and reduce the risk of stroke to as little as we possibly can. Obviously, maintaining sinus rhythm is also important. And I'm not going to talk to you about left atrial appendage occlusion or anything like that. What I will talk to you about today is what we can do to improve the symptoms and hemodynamics of patients with atrial fibrillation, and to talk to you really about rhythm control and restoring the order that the chaos of atrial fibrillation causes. We'll quickly just go over the advantages of these NOACs, again, to reiterate the importance of anticoagulation. These newer agents have a very rapid onset and offset of action. They're very predictable in their anticoagulant effect. There's a decreased need for monitoring. You don't need to check blood tests every 2 weeks or every month, as used to be the case with warfarin. There were fewer interactions with other medications. And suffice it to say that these agents were studied in upwards of 60,000 patients before their introduction into our pharmacy formulary, and with proven safety and proven safety and favorability as compared to warfarin in the treatment of patients with atrial fibrillation. Aspirin, I will remind you, is not an anticoagulant. So sadly, patients who are at risk for stroke, still there's a significant percentage of those patients who should be on an anticoagulant that are not. Multiple randomized trials have shown that Coumadin or warfarin and these novel anticoagulants are superior to aspirin in preventing thromboembolic events, but for whatever reason it's still in the general clinical mindset that aspirin is almost as good, and it's not. So in terms of maintaining a normal rhythm, our options in the past had been pharmacotherapy with antiarrhythmic drugs. Perhaps you've heard of amiodarone or procainamide or disopyramide, flecainide. These agents are limited in their use based upon their toxicities, potential side effects, and also proarrhythmic risk. And the fact is they don't work that well over the longer haul. So after a year or so, the ability to maintain a normal rhythm is really only in the 50 or 60% range. And so they leave a lot to be desired. I'm here to tell you also that in 2022, there is no definitive cure for atrial fibrillation, but we do know that sinus rhythm is better. And what we do have in 2022 as a better and more definitive approach to treating atrial fibrillation is ablation. Ablation literally means to destroy or get rid of something. So let me just give you a brief history of atrial fibrillation. There was a landmark observation in the early 90s by a group in Bordeaux, France, that observed that atrial fibrillation chaotic, disorganized rhythm that comes from the atria of the heart might be triggered by these electrical foci that arise in the pulmonary veins. And this is a cartoon of the left atrium, and these little stars are little electrical foci that are arising from these pulmonary veins, which are the vessels that empty into the left atrium. And Hosseger and his group postulated that, well, if somehow we could ablate or get rid of or somehow destroy these focal triggers of atrial fibrillation, that AFib could be eliminated. And in fact, there was an initial series of 3 patients which showed remarkable success with this approach of going after foci that trigger atrial fibrillation. It turns out that the atrial fibrillation story is a little bit more complicated than this. It's not just about triggers, but triggers are required for the initiation of atrial fibrillation, and I'd like you to remember this, because I'm going to show you some slides in a few moments where that's going to be kind of important. And these triggers can be ectopic atrial beats, can also be changes in autonomic tone or stretch of the atria due to pressure changes, as you might find in patients with heart failure, for instance. But there's also the situation where you need to have the substrate. So the atrial muscle needs to have certain electrophysiology properties that allow the triggers to then cause the atrial fibrillation and then sustain the arrhythmia. So there's a certain real estate, if you will, where the electrical signals and the waves that are formed by these electrical signals need to run around in order for atrial fibrillation to be sustained. So basic electrophysiologic mechanisms of triggers and substrates are what we go after when we talk about ablation. So Hosseger went on to show that the great majority of these triggers, this is a cartoon of the left and right atrium, and this is the septum, that the great majority of these triggers come from these pulmonary veins, from in and around the pulmonary veins. There are fewer, when you look, of these triggers that come from extra pulmonary vein areas, but bottom line is that if you had to make a bet where the triggers are coming from, the pulmonary veins are the right bet, at least as a first attempt. But you also have the left atrial tissue, which is then required to sustain the wavelets that perpetuate atrial fibrillation. There are also some non-pulmonary vein triggers that I mentioned before, which are not necessarily from just the pulmonary veins, but could come from other parts of the heart. And there's also the complexity of the neurologic system that also affects the electrophysiologic milieu of the atrium. And here is an illustration of where these nervous inputs tend to be concentrated outside the left atrium, outside the left superior pulmonary vein, behind the right-sided veins. And here, these are ganglionic plexi of nervous inputs that regulate the nervous system of the heart. So look at where ablations over our history have concentrated. Initially, we used to go after these little foci in and around these pulmonary veins. Then the evolution of the ablation lesion set was to now, instead of just going after individual foci, well, basically we could wall things off and make lines and things like that we could perhaps wall off where these electrical abnormalities existed, and in so doing also create almost a maze-like situation where you would limit the real estate where these irregular wave fronts could circulate. Turns out that this was very challenging with the tools that we had available to us in the early 2000s, but with lots of study, we realized also maybe we were doing too much, and we evolved into a less is more type of approach to atrial fibrillation, where now we're doing what's called an isolation of the pulmonary veins. And if you notice, this type of lesion set actually not only incorporates where the foci come from, these pulmonary veins, but also affects these ganglionic plexi, these yellow, represented here in the yellow, and also does something to the destruction, if you will, of the substrate or the real estate that is necessary for atrial fibrillation to be perpetuated. So I'm going to show you how we achieve this. Here's an intracardiac electrogram, or measurement of electrical signals from inside the heart that we get during an electrophysiology study with catheters placed inside the heart, with electrodes placed in various locations in the heart. And this lasso catheter is a catheter that's placed inside the pulmonary vein. And what you see here, if you look at the top here, this is an EKG. You see a normal rhythm. You see a normal beat, number one, a normal beat, number two, with the typical sequence that we would see from this electrode here. You see a nice organized electrical signal that generates this P wave in sinus rhythm. But then look at this one. This has a different signal. It seems to be earliest in the pulmonary vein, and then it triggers this abnormal rhythm, or this disorganized chaotic rhythm, which is atrial fibrillation. So you have the trigger, and then the sustained rhythm in the left atrium. And this is measuring signals from inside the pulmonary veins. So how does atrial fibrillation ablation actually work? Well, here's an example, again, of intracardiac electrograms, signals measured from within the heart. And here, with this lasso catheter, this type of catheter that we stick in the pulmonary veins, you see this irregular, disorganized, very rapid rhythm in the pulmonary vein, but you see by the EKG that this is a normal sinus rhythm. And you see also by the electrograms that are outside of the pulmonary veins and the rest of the heart that the rhythm is nice and regular. So what we have going on here is we have atrial fibrillation triggers and substrate happening inside the pulmonary vein, but not in the rest of the heart. And in fact, the patient is in normal rhythm at this point. And how does this happen? Well, it happens by isolating, in red, these are the pulmonary veins, isolating those pulmonary veins and not allowing the garbage that's happening in the pulmonary veins to escape into the rest of the heart and cause manifestations of atrial fibrillation. So this is called pulmonary vein isolation, and it's the mainstay of any ablative therapy. So we try to keep the electrical abnormalities inside the pulmonary veins, and the purple here is normal tissue and normal electrical signals, and allow the heart to otherwise remain in a normal rhythm. So let the pulmonary veins do what they need to do. And how do we do that? Well, the atrial anatomy is very complex territory. This is an endoscopic view of what the landscape is that we have to navigate. And fortunately, we have lots of tools which allow us to do this. Early on, we would use a catheter. And this is a navigation system that can track our catheter, which is delivering radio frequency energy, which is used in neurosurgery. It's used in other surgeries to remove tumors, et cetera. Well, we could use it because of its discrete lesion nature in the heart to create a wall, if you will, of dots around the pulmonary veins, and wall off, if you will, or isolate the pulmonary veins in this nature. You can imagine this takes some degree of technique to be able to do this effectively, because any break in the wall will allow a signal that's arising in the pulmonary vein to exit. So there are some newer technologies, also thermal in nature, but instead of using heat to create these lesions, we can use cryothermy or cold energy to do the same thing. And this is an example of a balloon technology, which creates a very cold environment, and any place that balloon touches actually destroys the tissue and creates a pulmonary vein isolation situation based upon contact and freezing in and around the pulmonary vein. So this is, again, a cartoon of these pulmonary veins, and this is what it looks like in real life, where you have this balloon inflated. You see dye in the pulmonary vein that is not leaking back into the left atrium, which means that the balloon is occluding that pulmonary vein. And this balloon gets very cold, down to about -40, or minus 50 degrees Celsius, and that's enough to actually irreversibly damage the tissue that it's touching and create pulmonary vein isolation. The problem with the use of thermal injury or thermal energies to create this pulmonary vein isolation situation is you can have significant inflammation, which can cause pericarditis. You can have paralysis of phrenic nerve, which lives behind or in between, I should say, these pulmonary veins and where we're working with our catheters or with our balloons. And the dreaded, but fortunately very, very, very rare complication of an atrioesophageal fistula, which happens because the left atrium is right up against the esophagus, and if you injure the posterior wall of the left atrium, you could also potentially injure the esophagus and then create a devastating problem where you have a communication between esophageal contents and the left atrium. Fortunately, it happens very, 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 very infrequently, and we have all sorts of techniques to avoid its occurrence. The latest and greatest energy source is something called pulse field ablation, which is basically using not thermal energy, but electrical energy to achieve what's called electroporation. And you can change the parameters of this energy to specifically attack myocardial cells. And the wonderful thing about it is that it creates an electrical field, and any place this electrical field sort of passes through, it specifically addresses the tissue for which it's tuned to destroy. And it creates a lesion. Here's the pulse field ablation lesion on histology, sparing blood vessels, nerves, the phrenic nerve, sparing the esophagus because esophageal muscle is different than cardiac muscle. And compare this lesion to what happens when you use radio frequency energy, where you have a full tissue thickness lesion, but sort of with scarring and with hemorrhage and with fibrosis along the edges, et cetera. And that's as compared to the cryoablation lesion, which also has perhaps a more discrete lesion, but still is not discriminating in terms of what potentially gets damaged in here. PFA is directed at just myocardium. This is how the PFA works. It's similar to a great degree in how we use a balloon. We take the PFA catheter, we deliver it to the ostium or the opening of the pulmonary vein and deliver the pulse field. And in so doing, every place that electrical field touches will destroy the electrical activity of that tissue. And if you recall from the little map I showed you before, everything here in the gray means that there's no electrical activity, or electrical activity that might arise from here can't get out into the rest of the atrium, so we achieve this pulmonary vein isolation. And the beauty of this particular technology, here's just a picture of what this looks like on fluoroscopy. This is that catheter in a basket configuration, and this is the same catheter which can be manipulated to take on a different shape to deliver the same pulse field ablation. But the beauty of this technology, please advance, this is ultrasound showing you the same thing, is this. So what I'd like you to take note of here for a moment is, it'll start again, these signals here are the signals that we achieve inside the pulmonary vein. And what I'd like you to see is at the beginning of this movie, you'll see that there's some sharp signals. These are sharp signals. Here's the PFA, 4 seconds, boom, those sharp signals are gone. So we achieve the pulmonary vein isolation with a single application within 4 seconds, which dramatically improves the time of your procedure. It's improving the safety of our ability to do this pulmonary vein isolation. And as I mentioned, this pulmonary vein isolation, whatever energy source you use, is the mainstay of ablative therapy at this point. And the way that we currently think about ablation for atrial fibrillation is, if you want to give your patient the best therapy for atrial fibrillation, this at the present time is the best therapy out there, ablation. what energy source you use is potentially operator dependent. In closing, this is what the timeline has been of catheter-based procedures for atrial fibrillation. It started out in the 90s with radio frequency energy and various iterations of the types of catheters that we use that can be irrigated and show you how much force that you're exerting at the tip. The first generation balloons were initially introduced in the 2010s to today, where we're using this PFA, which is the sort of the latest and greatest hope for improving upon our procedure. As a final note, this type of ablation procedure, certainly in the States, is probably the most common procedure that's done now for treatment of arrhythmias. And one of the things that we learned during COVID is it's the kind of thing that we could actually do as an outpatient. So the procedure takes about an hour and 20 minutes, an hour and a half. Patients come in the morning, they have their procedure done. Because it's done through vascular access in the groins, when we're done with the procedure, the patient has to lie flat for 2 or 3 hours. We use certain vascular closure devices to achieve hemostasis, and the patient goes home. And it's something that we did of necessity during COVID, because in order to treat patients but not keep them in the hospital, we were sending them home and realized that it could be done very safely. And so now we do 3-4 of these a day, and patients do very, very well. So I thank you for this opportunity. Happy to take any questions at some point whenever you see me around. And again, thrilled to be here. We're not taking questions now, right? We're going to wait till after?
I've got a burning one to ask you myself, actually.
Oh, burning. Okay.
Yeah. Pardon the pun. Good catch. I just wanted to ask you very quickly, as a former cardiothoracic surgery trainee, I wanted to ask, with the PFA, brilliant talk, brilliant presentation, does that have any effect on left atrial pressures afterwards, and as a consequence, left ventricular pressures, and have you seen anything change with ejection fractions afterwards?
So very interestingly, atrial fibrillation is a more complex disease than I was able to present to you in terms of the types of changes that happen in the atrium. So you have fibrosis that happens with longer standing atrial fibrillation, dilation of the atrium. Dilation of the atrium can result in dilation of the valve annuli and worsening mitral valve regurgitation. So we know that if we get patients back into sinus rhythm, a significant percentage of those patients will have reduction in their left atrial sizes, reduction in annular sizes, potentially reduction in their mitral valve regurgitation, and improved in the left-sided pressures.
Fantastic.
So yeah, it's interesting stuff.
Thank you very much, Nicholas.
Thank you.
That's awesome.
Pleasure.
Thank you for tolerating the question. May I please invite a very prominent cardiologist to the podium now, Dr. George Proimos, who's a consultant cardiologist at With Healthcare, who'll be talking about transaortic valves. Now, Dr. Proimos graduated medicine from 1986 from the University of Melbourne. He trained in cardiology at the Austin Repat, obtaining his fellowship at the College of Physicians in 1995. He's then travelled to Boston in the US, where he completed interventional training in Massachusetts General Hospital under Dr. Herman Gold, which I think everyone in this room would know. While training with Dr. Gold, he undertook research in antiplatelet therapy and also the management of acute coronary syndrome. Upon returning to Melbourne in 1999, he became a VMO at both the Austin and also Box Hill hospitals. He has been involved in training young cardiologists for a very long time and also in local research. George has developed quite a large private practice both at Epworth Richmond and Epworth Eastern hospitals, and has an interest in coronary disease with septal closure procedures and aortic valvuloplasty. Please welcome George.
Thank you. Thanks everyone. Thanks Marinas for inviting me and to the Medical Society, and thanks to our international speakers for coming and to the audience here today. I'm going to talk about, my brief is to talk about aortic stenosis and how we can treat it with percutaneous means. Now this is a disease that's been around for a long time and was first described back in the 16th century when this French shoemaker died, and he was he was sort of young, he was in his 50s, and died suddenly without any known reason. And he had a post-mortem performed, and the post-mortem revealed that he had a severely fibrotic and calcified aortic valve with very restricted leaflets, and there was only a little slit-like opening for which the blood could go out of the left ventricle into the aorta. So it was recognised back then, but there wasn't much we could do about this in terms of treatment. The normal aortic valve is a very membranous structure. It's got a trileaflet structure, like a Mercedes-Benz sign. In pigs and cows, they're bicuspid, but pigs and cows only live for about 30 years of age, whereas the human valve can live up until 100 years of age. When it's a disease, it becomes fibrotic, calcified, the leaflets become restricted, they can't open, and you get this slit-like narrowing. And this is a post-mortem appearance of a severely stenotic aortic valve. Now, when the valve is stenotic, it creates a pressure loading of the ventricle becomes very hypertrophied, and the patient wouldn't know it because it copes with this extra pressure loading for a long period. It can be many years, sometimes 20 years before it becomes a problem. So there's this latent period, and then patients start getting symptoms. Once symptoms commence, the decline is very rapid, especially if you've had heart failure. They often will die very shortly afterwards. Now, the disease itself is getting more and more prominent. As you can see in this demographic data, in people over 70 years of age, about 4%, nearly 1 in 20 people over 70 have got aortic stenosis. And given that our population is growing older, and we're getting a lot of people in their 70s and 80s, a lot of people out there with aortic stenosis, and a lot of them asymptomatic, not aware of it. Now, up until recently, from the 60s onwards, the only way we could treat this was surgically. But now that we've got an option which is percutaneous, most people, if you give them half a chance, if you give them an option either percutaneous or surgically, most people don't want to get a scar in their sternum, and if they can take the non-surgical option, they will. And we're getting a lot of patients now demanding or requesting percutaneous treatment. Problem with that is that these valves aren't going to last forever, and so if you get someone under the age of 70, the patient is probably going to outlive the valve, and then you're going to have to do it again 10 or 15 years later. That's becoming a real challenge now. Now, these are the first valves that were approved, and they were the Edwards valve is the one on the left, and that was approved in 2011 by the FDA for treatment percutaneously. Shortly afterwards, the Medtronic valve was approved as well. And ever since these have been approved, we've had a huge upsurge in the number of cases around the world. Now there's been well over 1 million percutaneous valve implants around the world. This is an example of a person with aortic stenosis. Now what you'll see when the dye is out of the, when there's no dye, you'll see the valve leaflets, and they've got the same, so you'll see the black, that black is actually calcification in the valve leaflets, and it's got the same density as bone. You can see the vertebrae behind. So these valves become so dense, they're calcified and they're as dense as bone. This is, if I can get it to, yeah, here we go. This is an implant of a valve. So we do it with a pacemaker, temporary pacemaker device in place. We pace the heart at about 180 beats a minute. When it's at 180 beats a minute, there's no flow of blood across the aortic valve. And you don't want the valve to move at the last minute because you can embolize it. And we inflate a balloon, and once the valve is implanted, we deflate the balloon. We don't stop pacing until the balloon is out of the valve. Otherwise, we can embolize the valve again. And this is what it looks like afterwards. And we've now made a nice, we've got a new pig's valve in position, all done percutaneously with the patient awake. And just like Nicholas's patients, with necessity, people in overseas with low risk TAVIs are now having a same day procedure and going home, which I don't know that we're not at that point yet, but it's been done in some places overseas in Europe where they're having same day TAVIs and going home. The main reason why we keep them in is that there's a small, because the His bundle runs very close to the aortic valve annulus. When we put these valves in, the tissue from the old valve is pushed up against the sides of the annulus. and sometimes you can get conduction disturbance. In some patients, the chance of having a pacemaker is not insignificant, and if it's going to declare itself, it's usually in the first 48 hours. So we tend to keep our patients in, unless they've already got a pacemaker implant already, we tend to keep them in for 48 hours to make sure they're not going to get into trouble. And there's one nice story. One of our fellows came back from America, was working in Mount Sinai Hospital, and there was a very wealthy businessman who had one of these valves put in, and he was meant to go home day 3. He was going to be chauffeured. He had a limo coming to pick him up, and because it's New York traffic, it was delayed. So the limo was delayed, so the guy has to wait. He's getting angry because his chauffeur hasn't rocked up. Whilst he's waiting, he has a cardiac arrest. He went into a ventricular standstill. And obviously he was still in hospital, so they put a pacemaker in and he survived. But if his limo was on time, he would have been dead in the back of the limo. Now we'll move on. So now the evidence that we can do the same as our surgical colleagues comes from this first study called the Partner Study, performed in 2010. And at the time, the patients that they included were high-risk patients with a risk of having a complication with surgery of greater than 8%, and it was the STS scoring system. They were randomised in a 2-to-1 fashion. About 700 were randomised to percutaneous treatment with valves. About 350 had surgery. The percutaneous arm also had some that were done apically, so they went through the chest rather than through the femoral artery. We don't do that anymore because we've quickly have learned that that is not as good as transfemoral. Virtually everyone around the world now does it transfemorally, and no one does apically anymore. But the long and short of it was, when they followed them out, this is the results at the end of 5 years follow-up, and you can see that the survival outcomes are no different if you have a percutaneous treatment compared to our surgical colleagues for high-risk patients with aortic stenosis, such that the FDA then approved it for treatment of high-risk patients. Shortly afterwards, we had approval here in Australia as well. In the study, there was patients that the surgeons deemed too high risk. So when they were screening for patients for the study, there was a few patients that were considered too high risk that they wouldn't. The surgeon said, "No, we can't operate on this guy. Too frail, too many comorbidities. We can't operate." But they were observed. Some of them actually, off-label, had percutaneous treatment of their valves. And I point out to you what happens at the end of 1 year. If you had no treatment at all for severe aortic stenosis, your survival at 1 year, 50%. At 2 years, more than two-thirds were dead. But if you actually had a percutaneous treatment with a TAVI valve, 60% are still alive at 2 years. So even though this wasn't a randomisation, it shows the benefit in these very frail, non-surgical patients. Now this is the equipment that we use. Back then, originally, this was the size of the catheter that we had to put in through the femoral artery, virtually at the size of a garden hose. This is what it's like now. 14 French is about, the clearance you need in the femoral artery to put a 14 French in is about 6 millimetres. So we need about a 6 millimetre artery. So you've got some of these little old ladies that are 40 kilos. That might be a challenge. But it's certainly smaller than the 24 French. The valves have changed as well. This is the pig's valve here stitched into the frame. We now have this Dacron skirt, which is on the outside of the valve. And this allows some, when it's implanted, unfortunately the aortic valve is not, the annulus is not circular. It's actually oval. So you don't get a perfect circular shape. There are gaps around the edges. When you have calcification, you can't abut the valve directly onto the annulus because the calcium prevents it, so you get little gaps. And as a result, you get paravalvular leak. But now what they've done is they put this little skirt in here, which allows some redundant material, it's made out of Dacron, can fill in these gaps so you don't get the paravalvular leak. So this has made a huge difference to the patients. The original trial was done with this device here and with the big bore. The current studies, or the more recent studies, were with the later iteration of the valve, where we prevented this paravalvular leak and had smaller equipment, so we were able to treat more patients. So we've gone from treating high-risk patients and showed that we were not inferior to surgery. They've now gone on and done it in low risk. So low risk means the chance of having a major cardiac event with the surgery is less than 4%. And when they randomised these patients to the newer device models, the results were quite astounding. And I draw your attention, not only was it superior to surgery, if you look at the stroke outcomes and death outcomes, there's significantly an advantage if you did it percutaneously as opposed to having it done surgically. So these are low-risk individuals. The surgeon said, look, this is bread and butter stuff. Now, if I'm over 70 and I've got aortic stenosis, I can tell you what I want to have done. I would rather have a percutaneous approach if I can prevent a stroke or reduce my mortality than having it done surgically. It used to be that the surgeons used to argue, oh, what about durability? Our valves last longer. Well, we now have data. I've got one patient who's had it 12 years ago and he's still going strong. We now have data that these valves will last at least 10 or 12 years, no less than our surgical colleagues. So durability is no longer an argument. They used to argue about all the paravalvular leak because that used to give a worse outcome. We've dealt with that now with the skirts. So now we've got evidence to show that we can treat even low-risk patients. So we started with the high-risk group. We went to intermediate risk group. We've now got evidence to show that low risk can be treated percutaneously. Where are we going now? Now there's trials looking at asymptomatic patients. And just like Nicholas said, if you leave AF for too long, the atrium remodels and makes it harder to treat. When you leave these patients with severe stenosis, they get their LVH, the heart muscle gets fibrotic, it starts changing. If we can get in early, is there an advantage? There's now trials being done for asymptomatic patients before they start getting heart failure, before they start getting problems. And that will probably be in the next couple of years where we will, at the moment, there's no indication to do surgery on asymptomatic patients. But what about with TAVR, if we can show that there's an advantage? I'll just briefly share with you some of the data from our hospital at Epworth in Richmond. Professor Walton started the first case in 2010. In 2018, when we got Medicare rebate for high-risk TAVR, you can see that there was a jump in numbers. And this year, when they allowed low risk, so Medicare now allows us to treat low-risk patients with TAVR, and there's a rebate for that, you can see that the numbers are jumping again. So we're looking at doing about 200 cases a year. We've now clocked over 1,000 TAVR cases at Epworth. And so it's really growing, and with this low risk cohort, it's going to grow it's going to become quite a major treatment that we're offering our patients. In terms of the demographics, the median age is high, and that's because we were treating high risk patients before, which were predominantly elderly, frail patients. We're now treating low risk. So anyone over 70, we now would consider them for TAVR as opposed to surgical intervention. All of ours are virtually femoral. We haven't done an apical one now for maybe 3 years. Occasionally we do left subclavian if the femoral arteries are very severely diseased, but what we now do is get the vascular guys to come and help us out and get access for us if we need to. In terms of outcomes, it's been a very successful program. The chance that you're going to need a pacemaker implant is about 6%, which is slightly higher than the surgical. The surgeon's pacemaker implant rate is probably lower than that. It's probably more like 4%. The chance of having a stroke is about 1.8%. And this is, you have to remember, this includes mostly all the high-risk ones. And the chance that we did something bad to the iliacs or the femorals and needed vascular repair is about 1%. So overall, fairly good data for our patients, and I think we're getting better and better at this, and we're now offering it to our low-risk individuals. So that's my talk. I'm happy to take questions if anyone wants to ask questions. Yep. Yeah, we have done. We haven't done it now. So in some places when it was hard to get access, you used to go up the femoral vein, cross into the aorta. So you'd have to where the aorta and the inferior vena cava came very close to each other, you were able to then cauterize and get across. So you'd get a piece of a stiff end of a wire, and you'd cauterize across the cava into the aorta, introduce a sheath do your procedure, and then on the way out you use an Amplatzer device like you would for a PFO closure, seal that hole, and there wouldn't be any bleeding. But we haven't done one now for 2 years. As I said, we now just get our vascular guys to come. And the big problem with the vascular access is calcification. Calcium is bad for everything in the body. And as you get older, there's lots of calcification. And what we do now is the vascular guys have got access to lithotripsy. So like they used to smash the stones with lithotripsy, we can now do it vascular lithotripsy. So for the peripheral vascular, and so you can crack the calcium in these arteries, and then with a little gentle dilatation, you can open the iliacs and femorals reasonably well. And it's been a long time since we've had to use a subclavian approach because we couldn't get access. Usually the vascular guys can do it for us. We haven't done a caval approach now for a couple of years. One of ours actually went sour, and I think that's coloured our impression about caval approach. Thank you.
So next, may I please call on Dr. Antonios Polidorou, please. He'll be presenting his discussion about the GDHI. Now, Dr. Antonios Polidorou is a graduate of the Medical School of the Kapodistrian University of Athens. He specialised in cardiology at the University Hospital Cardiology Clinic of the Hippocratic Hospital in Athens. In 1978, he was awarded a PhD from the University of Athens, and until 1985, he trained in hemodynamic and invasive cardiology at Guy's Hospital in London, in the intravascular treatment of carotid artery and peripheral vessels at Nancy Clinic in France, at Scripps Clinic in San Diego, and also in the US as well. As of 1985, he worked in the cardiology clinic at the Nimitz Hospital in Athens, where together with his associates, they started the first coronary artery angioplasty surgeries. In 1990, he was appointed Director of Hemodynamic and Invasive Cardiology at the General Hospital of Nikaia in Piraeus, where he took over the management of the respective department at the General Hospital of Evangelismo in Athens until he retired. In June 2001, he successfully performed the first operations in the world of coronary artery bypass grafting at the University of Isai in Romania, where he was named Honorary Professor of Cardiology at the medical school there. During his career, he's received many honours and developed social and cultural works. He's held, for a number of years, the position of the Vice President of the Board of the Narcissus Cardiac Surgery Centre. We warmly welcome Dr. Antonios Polidorou.
Dear colleagues, good morning. I would like to congratulate Professor Pirpiris, which along with our President, George Patoulis, they created the International Congress of Doctors, Hellenic Doctors of Diaspora. And thank him also for having us and for his hospitality here in the beautiful town of city of Melbourne. I will take the opportunity to welcome the great efforts of Dr. George Patoulis, our governor, which in collaboration with the International Hippocratic Foundation of the Island of Kos, with medical schools from Greece and abroad, and other institutions, he set as goal the reconstruction and dissemination of the Hippocratic spirit, the Hippocratic values, and the preservation of the Hippocratic Oath throughout the world. The unveiling of the bust sculpture of Hippocrates at the University of Melbourne, at the medical faculty, carries the symbolic character of this goal. Dear colleagues, I would like to thank our Governor, George Patoulis, because during the COVID period, at December 2020, he invited me to take the position of the General Secretary of the Global Doctors Hippocratic Institute. So, our activities, I may say that it started at December 2020. almost 2021. So this is the board of our institution. The governor is the president of the Global Doctors Hippocratic Institute. Dr. Pantos, who is in the room, is the vice president, the first vice president. Professor Kouskoukis is a vice president, the second vice president. I am, of course, the general secretary, and Patsourakos Fotis is the treasurer. So our activities start from 2021. We began the first activity, which was Hippocrates Unites the 5 Continents. What we did, we invited all the universities throughout the world, and we discussed the problems of doctors, not only the Hellenic doctors, the Greek doctors, but the doctors from all over the world. And we have the participation of 25 universities throughout the world, even the Anhui from China. The second activity was in June, where we created a symposium called Hippocrates Unites the Greek Doctors from all over the world. So we found 18 Hellenic associations, medical associations. We invited all of them. We had 41 participations. From New York, of course, we had Mr. Panayotis Manolas, George Tangas, our friend Mercedes, and many others. And for Melbourne, of course, always we have the Greek Medical Association with Professor Pipiris. And we went on to many other activities. This is on September 2021, where, according to will of our president, George Patoulis, we have to place all over the world 35 statues of Hippocrates, and also to plant the plane tree in which under he was teaching his students. This is a symbolic act anyway, and we started from Larissa, when Hippocrates did the second part of his life, and he created the School of Medicine in this town, and he died in this town. So we went to the University of Larissa, we put the statue, we unveiled the statue there, we planted the tree also, and we did a seminar, a symposium between the Larissa University, the Faculty of Medicine, and our institute. I would like to mention that in that period, the president of the Foundation of Kos, the Hippocratic Foundation of Kos, was Aristotelis Pavlidis, who unfortunately died during these days, and he was always with us. He died in the age of 83, and he was active until the last day of his life. Then again in 2021, we went to Cyprus, where we unveiled the statue at the university, at the European University of Cyprus. We did another symposium there, and we planted again the tree of Hippocrates. I would like to mention that Cyprus is my main land. I was born in Cyprus. That's why we choose to go over there, to start from Cyprus. And then again, we come to the April 2022, when we created at Belgrade, in Serbia, joined with the University of the Faculty of Medicine. We did the Serbian Hellenic Symposium, and then we planted the tree in the yard of the university, and afterwards we unveiled the statue of Hippocrates. And then, in June 2022, we went to Bucharest. In Bucharest, for first time, I was very exciting because with us were about 200 children around us, out of 1,000 children that Dr. Pantos, in collaboration with the university there, they do with the method of IVF, the newborns through, in the most countries in the world. So there we had about 200 children out of 1,000 about children. After that, we moved to Pavia. According again to the president's will, George Patoulis, he wanted to create the OT in Pavia, where is the oldest university in Italy, the oldest faculty of medicine. He wanted to give the oath to the graduate doctors in the same way as they do it in the course. So we brought with us the priest and the 9 Cariatis, and the doctors there, they took the oath according at the way that we do it in the island of Kos. And again, we put the statue at the university and the plane tree also. So, in 17th to 21st of October this year, we went on with the festivity at the island of Kos. We did the second symposium, the Hellenic Serbian Symposium there. We invited 14 countries that the best doctors, the best that they graduated this year, they took the oath along with the 7 medical faculties from Greece. I would like to mention that in the island of Kos every year, the top graduates proclaim the Hippocratic Oath, an oath that is less than 1 page, but for which thousands and thousands of pages have been written, and this is truth. Yesterday, we announced at the University of Melbourne, along with our president, George Patoulis, I think they can hear, can you hear me all? Sorry. Sorry. So, today we're going to announce the first summer school in medical. Thank you. Okay. So, today we want to announce the first summer school for medical students in the island of Kos. This is an idea which came from the cooperation between the Governor of Attica, President of Athens Medical Association, and President of the Global Hippocratic Doctors Institute, Dr. George Patoulis, and the Board of Prestige of our institute, in the cooperation with members from the University of Thessaly, the European University of Nicosia, Cyprus, and the International Foundation of Kos. The summer school will be 1-week program for Greek and foreign students from medical faculties worldwide, titled Hippocratic Values and Medicine, starting at October 16th. Please keep this date.
ending at October 21st, 2023, the next year, when the top graduate medical doctors students from 25 countries will proclaim the Hippocratic Oath. The first and second day of the school will be dedicated to the Hippocratic Botanic Gardens. Students will have the opportunity to study the 235 different plants, herbs, growing in the botanic gardens of the International Foundation of Kos, and be familiar with Hippocratic plants and herbs and the preparation of medication 2,500 years ago. During the third day in our program, students will visit the island of Kalymnos and Patmos. The fourth day will be the so-called Career Day, when students will have the opportunity to meet with professors from different universities and specialties. The aim of the day is to discuss with them details for each specialty in order to get the basics for their future career decisions. During the fifth day, the students will be able to participate at one-day symposium organized by the Greek and foreign universities. Finally, the last day of the program, 21st of October, all students will have the opportunity to join the Hippocratic Oath ceremony. You are, of course, all cordially invited to celebrate with us this excellent ceremony. We hope that that we will have the support from the University of Melbourne, together with cooperation of the President of the Greek Community of Melbourne, Mr. Bill Papasteriadis, and the President of Hellenic Medical Society of Australia, Mr. Marinis Pirpiris, in order to prepare a group of medical students to participate in the summer school. Also, we expect to have the top graduate from the University of Melbourne for the Hippocratic Oath. We trust that our cooperation will continue at all university levels with great success. Dear colleagues,
in the Global Doctors Hippocratic Doctors Institute, Hippocratic Institute, we have now all the members of the Athens Medical Association, 27,000 members, and this is the 45% of all doctors in Greece. We have, 10 days ago, Panagiotis Manolas announced me that all the members of their society in New York joined our activities and are members of the Global Doctors Hippocratic Institute. The members from Austria Medical Association, the members of the Cyprus Medical Associations. And now, Professor Pipidis told me that he will ask the request of your members here in Melbourne to be members of our institution. What is our aim? Our aim is to join all together the 18 medical associations throughout the world, and make them one family, in order what is happening in Melbourne to be announced at the same day in New York, in China, everywhere in the world anyway, in England, and in all Europe. So we invite you all to be our members, and we promise that we will continue to spread the spirit of Hippocrates, to spread all over the world the oath of Hippocrates. Thanks again to our governor, who created these thoughts, this spirit, and we promise that we'll follow him whatever and where he goes. Thank you very much for listening, and we are expecting you in our association, in our institute. Thank you.
Thank you very much for a very, very moving presentation. Ladies and gentlemen, we'll now break for morning tea, and we're back at 11 o'clock, please. Thank you so much. Morning tea's on the 12th floor, where it was yesterday. So, there we go.
introducing him, who he is.
Ben,
Go for it. Shall we start? Alright, cool.
So we might diverge from the original program and just skip forward a couple of sessions and then do a bit of U-turn. So we'll move to session 5 now, current concepts in radiology. That'll be presented by Chris Holden. So Chris is a radiologist with subspecialist training in MRI, musculoskeletal and neurological imaging. Chris has been intimately involved in the setup and direction of imaging independently and imaging associates. He is proud to be part of an Australian business owned and run by local doctors in a sea of corporate competitors. Chris, thank you very much.
Now, before I get started, and thank you very much for having me. Before I get started, I'd just like to clarify one issue. AI stands for artificial intelligence. That's the ability of computers to process a lot of data to enable machine learning. IA refers to Imaging Associates, which is an awesome Melbourne-based radiology group run by 50 radiologists. We're doctor-owned, doctor-run, very friendly and intelligent group. Now, I'll just, and both have a big future in radiology, which I'll try and illustrate now. If you just step back in time, 2018, Chicago, a couple of days after Thanksgiving, the start of the big international annual conference. There's 40 to 80,000 radiologists there. It's one of the biggest conferences in the whole world in any specialty. It was the keynote address. People had just arrived, a bit jet-lagged, flicking snow off their shoulders. Going to the keynote. An hour later, people walked out visibly shocked. Just total change, total downer on the whole meeting. And what happened in there? Well, we just heard the death knell of the radiologists, including the quote, "It would be ethically wrong to train any more radiology registrars as it would be a pathway to unemployment." So that was an interesting meeting for another 5 days. We had a few drinks and relaxed a little bit. But 5 years later, I'm heading off to Chicago again. And that's in like 2 days' time. And I'm still gainfully employed. So what is going on with AI and radiology? And the answer is a lot. A real lot is going on. Radiology remains still the most quoted profession in terms of those that are first to be replaced, which is starting to irk me a little bit now, but it's interesting. The tsunami of AI is coming. It's rising, but it hasn't crashed yet. And radiology remains a really popular specialty. Despite it being really popular, we're terribly under-manned and under-resourced due to the boom in imaging generally. But there will be risks and changes as AI comes in. So, just a few definitions again. So, artificial intelligence, computer science, with data, problem solving in machines. Now, that, for example, that in a CT brain. So in a CT brain, if you're looking for a subdural hematoma, you're looking for a crescent of dense material, bright material situated between brain and bone. And with artificial intelligence, you can instruct a computer through a series of rules to try and find bright spots in that location. And that will create a rudimentary AI. There's a subset of AI called machine learning, and that's where you give those same basic parameters, put a whole lot of data through, and the computer does what it's told, but it also develops its own pathways. And with human feedback, you can create a far better system. You can get rid of artefacts, you can stop it calling metallic artefact from an aneurysm, clip, hemorrhage, etc., etc. So you move forward in that regard. There's a further subset in AI, and this is applicable not just to radiology but to AI in general, called deep learning. And that's where you've got a series of neural electronic pathways, layer upon layer, set up in a similar way the brain is set up, that uses a whole lot of processing and a whole lot of data without any human impact to create some answers and to problem solve. So in our CT brain example, what we do is provide 40,000 CT brains with 40,000 reports, some of which say subdural hematoma, some of which say other things, and you put it into this black box, and the computer basically decides how to decide what is a CT brain and what is not by a series of patterns and learning and feedback internally. So you get a system, you get a result that is potentially very, very accurate, but no one understands how it came to that conclusion. With that CT brain, for example, and this software does exist, there's no actual image created. It doesn't make a CT brain and look at it. There's just ones and zeros. So it can spit out a very, very, very powerful answer. And that's the same way Deep Blue won its chess. Another example is where if we're looking for cancer, I'll look for a lump on a CT. The AI will still look for a lump, but it'll pick up other things along its learning process. It'll notice that maybe there's some cachexia and the fat volumes to muscle volume has subtly shifted. It will assess all the demographics and any information it can gather. It will, I look for enlarged lymph nodes and multiple lymph nodes. I'm just making this bit up, but it might look for a different density in lymph nodes. There'll be all these little patterns out there that we've never perceived, that it does perceive, but we'll never know how it perceives. It'll just throw out an answer. So what will AI do to radiology? And it's happening already. So it's here, but it's developing, and it's developing exponentially. It's in our scanners. So if we're doing a CT scan, it will try and minimise the dose and create the best image possible. It will assess the patient and decide where the patient's the thickest, where they're the thinnest, and put the appropriate amount of radiation through that so we can actually be tailored and minimised. It'll help create networks across medicine. I mean, at the moment, I can't even get a report from another radiology provider easily in Melbourne, let alone the images, let alone correlation with the EMR, let alone correlation with previous visits to GPs. AI will be very good at putting that data together. I mean, that's a danger, but it'll also be very good at doing that and providing a more comprehensive picture, of which radiology is just one part. But radiology, being very computer-based, may be that initial part from which everything else builds. It'll certainly be and is embedded in our reporting station, so it helps us find stuff. So computer-aided assistance, CAD already exists. For example, lung nodules, radiologists can push a button and the computer will find things that are dots, which is nodules, versus lines, which is bronchovascular structures, and differentiate between the two very, very quickly in a way that the human brain probably can't do as well. Also being used for breast imaging, finding breast lesions. But also good for triaging. I've got a list of 100 things I've got to get through, but number 100 on that list is a CT bleed. And if that's sitting down there, I'd love an AI to go through that first and just flag that, have a look at this one first. So I think it'll alter our workflows. So we find stuff. It also helps us measure stuff. I mean, if I'm trying to measure the volume of a liver lesion, I'm going to put a little ruler line across on the screen and say it's 11 millimetres. This will do a pixel count and instantly give you a volume. Much easier to do. I don't want to do that job, and it's far more accurate. And it'll analyse stuff. So if you've got an adrenal lesion, it will give you exactly what percentage of that is fat, and if it reaches a certain percentile, that will indicate it's definitively an adenoma. Or it'll be given an indeterminate value, but rather than me just saying not sure, it'll say this is 64% based on all the cases it's previously seen, likely to be an adenoma. So it'll be very good at analysing things. Similarly, an angiomyolipoma in the kidney, it'll assess how much fat is in that. And then it'll help compare stuff. So in the old days, you used to flick up hundreds and hundreds of CT images on the board, flick up another one, try and compare them. It's just risk of error, massive. Now, the AI will simply find the same lesion, do a pixel by pixel volume calculation, and give a very accurate description on whether this is getting bigger, smaller, by how much. So early on, currently, the radiologist will use this information, useful tools, and I'll create a conclusion and a report. And that's what's happening at the moment. I suspect that won't happen for too much longer. I think it's not long before the AI will say, well, I've seen 40,000 of these. This is what this conglomerate of findings usually equals. And then even more than that, it'll start to give a prognosis. It'll say, well, I've seen 40,000 of these, followed up over 5 years. This is what tends to happen with these findings. And we're really close to that actually starting to happen. The other thing with prognosis, which is really interesting, is it'll work in other ways. So it'll take an X-ray, it'll have 40,000 X-rays of a knee, just a frontal view, right knee, and it'll correlate that with pain scores over 5 years. And it'll then be able to tell us if someone has an X-ray of the knee, and we won't know what it's looking at. We won't know if it's looking at joint space narrowing or a particular ratio of osteophytes or bone density or a pattern of osteopenia, but it'll be able to predict, okay, this patient will have an increase in pain score at approximately 3 years or 4 years or never, and it'll help us decide, let that patient know what they need to be doing and planning for and when might be the optimum time to do a knee replacement. So how will this be perceived by the stakeholders, which are you guys, which are the patients, which is the government, the radiologists? Just to set the scene a little on the perceptions, last week I was reporting a bone age. So you get an adolescent child, you do an X-ray of their left hand, and there's a characteristic pattern of epiphyseal growth, bone mineralisation, etc. You can get it based on a lookup table from the 1950s, a Grueller Compile Atlas. You can get a very good understanding of what that patient's bone age is. Really good thing for an AI to do. You throw in 20,000 bone ages and scans, and it sorts out, it creates what that bone age is. But you don't know how it's doing it. It's not looking at the same things that I'm looking at according to the Atlas. But it's getting a very good answer. Great. But this program exists. If you, rather than a picture of an X-ray of the left hand, you put in a picture of flowers, it won't say not hand as a report. It'll say bone age, 13.4 years. If you give it a double-decker bus, it won't say this is a bus, this is not an X-ray. It'll give you a bone age of 12 years, 3 months. It's really disconcerting. It's really quite creepy. It's not wrong, but there's something not quite right about it. So they're the kind of creepy little things we're going to have to go through as this all evolves. Government regulation, sure, they'll sort it out. They can't even sort out medicine as is at the moment. How are they going to deal with a black box system? They're going to have no idea about standards and risks. They're going to be miles behind. It's going to leave them behind, unfortunately. Huge ethical issues. Are you reporting recommendations based for this individual patient, your mother? Are you reporting it for the greater community where you've got to keep healthcare costs under control? And then is it negligent to use AI when you're issuing a report? And then is it negligent to not use AI? Where are we going to sit on this? We don't quite know that. It's like automatic cars. It raises a lot of issues. And then you need patient consent. If a computer's going to report your chest X-ray, do you want to know about it? Do you need to know about it? And then there's data consent. So this AI is built, as I've said, over multiple scans analysed. But they're all people. And do they give consent for that? They probably didn't. Should they in the future? Possibly should. We don't have time to get all these consents though. So it raises a whole lot of issues there. It's also extremely expensive to get all that data, to buy it, to analyse it, to process it. And it's going to lead to a real centralisation in critical medicine. And this is not just similar to the Amazon, Apple, Microsoft, Facebook takeover. These are the guys that are going to be running it. They're the ones with this processing power. They are going to monetize it. They are going to control it. It's a black box system. They may work for the greater good. They may do no evil, but let's see how that plays out. And it's going to kill off the littler guys as well, who aren't able to invest in it. How are we going to know when we've reached a safe standard? How are we going to even know if the beautiful pictures of the liver that the scan produces are actually that patient's liver, or is it just a symbol or a guesstimate that looks beautiful rather than being accurate? And then are we going to even need images produced in radiology anymore? Are we just going to scan them and an answer will come out and an image will never actually exist? An image is only for us dumb humans. We may not even need images in radiology, which is kind of frightening. More than frightening, are we going to need radiologists? Well, probably not in our current setting. we're probably going to be there more as communicators and regulators and facilitators to take us through this journey and to explain the findings to various members of the various stakeholders. But being a communicator is quite ironic for all those people who did radiology to hide down in a hospital basement, hiding away from people. Thankfully, none of those guys work at Imaging Associates. I'll open up now for any questions. Yep, sorry, front first.
What's the liability presently? What kind of overread do humans?
Yeah.
Terrace from. It's on. Hi. What's the liability today? I forget what's going to happen in 5 years because clearly in lots of other areas, dermatology, pathology, et cetera, GI even, AI is sort of taking over a lot of the reads. But where does the liability end?
Yeah, so it's currently non-regulated in Australia. I don't think that there's no groups who we're aware of that are using AI to primarily report. There are multiple groups that are using AI as a backup. At the moment, a lot of those backups require a radiologist to press a button, and most radiologists think they're too busy to press that button, so it's not actually being utilised that much. It's a great marketing tool. You'll hear it mentioned a lot in that regard. So at the moment, it's very much radiologist-driven with AI as a adjunct, but that's going to flip in the next year. So the answer is it's horribly, no one knows where the liability lies. I mean, the radiologists will have their name on the report for another 5 years, I suspect. So as usual, the liability will lie with us. Yeah.
Thank you.
Sorry, behind.
Yeah, I'm just interested again. So when we get the reports, I don't think this is on, but anyway, when we get the reports, it doesn't actually state at the moment, that you've had assistance or not from an AI. And, renal cysts, Bosniak classification, as you say, there's various things that you need to do surveillance imaging for, including, hepatic fibrosis, whatever. So obviously it's a difficult time and it's a transition. So you either join the race and you control it as best you can, or you let someone control it for you. And, we're all aware that Google fired that engineer a few months ago for that machine becoming what he proposed was sentient. So, it is evolving at an extraordinary pace. And I think in medicine, as we've said, in dermatology, pathology, radiology, it's exploding faster than anywhere else. Now, is there an opportunity for us as a group of professionals to actually work with industry to ensure that we have some control over this? Because ultimately our responsibility is to the patients that we serve and to each other professionally. And I think it would behove us to do that as opposed to government to regulate it, because they're not going to do anything. They're going to let industry do what they have to do, and they've got the big dollars. So you either join the race and try and have some control over it and lead it in a direction rather than fight it, because you can't fight it. It's exploded. It's out, the genie's out of the bottle, and we have to do something to try. What are your thoughts? How has your community approached that? Have they got together and sort of come up with a process to deal with this, a strategy?
Yeah, I mean, what a beautiful summary of where we are in this conundrum, and sort of everything you said I fully agree with. And look, I'll hopefully have a better answer. I think in 5 days' time when I'm in Chicago, it'll be the main focus of every talk. So that'll certainly, the radiologist is certainly aware, but no doctor group is particularly powerful individually in Australia. The radiologist is particularly unpowerful. I think the main driver is not going to come from the patients who aren't organised enough. It's not going to come from the radiologists who have too many biases and too much going on. It's going to come from the referrers. Radiology is very referrer-driven. If a referrer wants a particular thing, particularly as a group, and wants to specify and wants to hold radiology groups to account, that's when the businesses will listen. They'll actually listen far more to a referrer than they will potentially to a radiologist. We're doctor-owned, so we're different. But I really think it's up to the referrer. I think if the referrers are interested enough, the radiology groups will respond.
Can I just add to that? Because the referrer is ignorant of what's actually occurring.
Yeah.
You guys have that knowledge. You're intimately related with it. We have a concept of what might be occurring, but we actually don't understand what you're dealing with. So how do you then bridge that? How do you allow us as referrers to help you?
I hope it'll go the same way as things went with the radiation dose in CT. So radiation dose was going through the roof. It was scanning more and more and more, and the radiation rates hadn't dropped at all. But it eventually realised that this was important, and it was put on the radar. And as a result, radiology marketing for 5 years was all about dose. It was all about dose, 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 dose. And CT scanners improved considerably, and dose came down. So once the radiology groups, and I'm not necessarily talking about us here, but the nasty corporates, once they realise that they can market it, then they will follow. So if they market to you and say this is all AI, and the referrers go, well, that's not actually what we want, I'm going to someone who's not, they'll quickly change that marketing to predominantly radiologist, whatever it takes. So it will still come down to the referrer, but they'll sort of, the corporates will try and educate you, and if you call rubbish, then they'll try and educate you in the correct direction. Yep. Sorry.
In dermatology, we had our AI discussed at every meeting. At one meeting, it was put up 2 pictures on dermoscopy of melanoma. They looked the same, but 1 pixel was changed. The machine said not melanoma. And that's our worry. 1 pixel difference, and the machine went the other way. Have you seen that reported more?
No, I mean, it's frightening though, isn't it? It rings true. And it's in some sense an artificial situation because it's picked up something that shows an alteration or an artifact, but it is absolutely terrifying. And no one will know why that is. And they can't train it otherwise. They can't say, if a pixel gets changed, don't say that, don't change. It's locked in. Yes. All I can say is it is very frightening. But look, the other thing I need to point in is there's a high degree of human error. I mean, even the best radiologists and the best doctors are making errors all the time. So we just need to realise that if we're the gold standard, we're not that good. It's such a frontier at the moment.
So, wouldn't this represent? Just to put an alternative spin on it, doesn't this represent an additional tool that you can use in terms of your armamentarium when you're looking at things clinically?
Yeah, look, we need a positive spin, absolutely.
I mean, like blood tests, right?
Yeah.
You use the blood tests to guide your clinical decision making, and this would be similar, I would have thought.
Yeah, no, it's good. Look, as I said, we're under-resourced. If I can report 200 cases rather than 100 cases, and potentially more accurately, it's absolutely brilliant. It's just more where it's going to lead. So I think right now we're sitting pretty, but it's just carefully watch this space. And look, it may be fantastic. Like medicine's probably going to just be the massive winner here, but just trying to explain some of the potential risks.
To a machine.
Yeah. Okay, no, really, that's
all right,
good to hear.
because when I'm reading this thing, it still might not make sense to me, and I want to ring you up and say, this is the clinical situation, this is the person I'm dealing with, and I'll be grateful for your thoughts. If you're not there, I'll be feeling really nervous.
Yeah. And look,
so again, the referring, 100%.
Good to hear.
And I think most doctors will probably have that.
And I think that probably is the sweet spot. I think that is. And maybe I'm reporting 10,000 cases, but I'm available to review any individual one and communicate that.
Yes.
So look, that's kind of the way I hope it does turn out.
It will turn out like that.
Okay.
It has to.
Right. Cheers. Thank you much.
Thank you, Chris. Taking a U-turn now and going back to the original talk from session 3, the Hippocratic lecture, by Dr. Konstantinos Pandos. Konstantinos Pandos received his medical degree from the University of Athens in 1981. He specialized in obstetrics and gynecology at the University of Athens, and in 1988 he was awarded the title of Doctor of the Medical School of the University of Athens. He specialized in vitro fertilization at the Royal Melbourne Hospital in Australia from 1987 to 1989. With nearly 35 years of experience in obstetrics and gynecology, and 30 years as an infertility specialist, he accepts infertile couples from 67 countries around the world, which is pretty impressive, including Europe, Australia, and the United States. He is a member of many international organizations, including ESHRE, the European Society of Human Reproduction and Embryology, the Australian Fertility Society, the New York Academy of Sciences, the American Society of Fertility, and national organizations, including the Hellenic Society. He is a member of the Medical Tourism Department of the Scientific Research Institute of the Pan-Hellenic Medical Tourism Department of the Scientific Research Institute, and a member of the board of the Hellenic Health Tourism Association. He is the founder and scientific director of the Genesis Athens Clinic. As vice president of the International Centre for Health Tourism and the Global Doctors Hippocratic Institute, he participates in the promotion, organisation and effective management of health tourism in Greece. Dr. Pandos, please.
So, thank you very much. I'm going to be talking about the importance of the authentic oath of Hippocrates and today's assisted reproduction as destination points. I'm honoured once more to be in Melbourne, my birthplace, seeing all friends and mates, relatives once more to discuss all the Hippocratic ethics and values and the opportunities which arise in today's modern times to create destination points. Being the head of Genesis Athens Clinic at the forefront of our science and profession in Greece, me and my colleagues are proud to have contributed to turnaround of an outflow of patients in the past years from Greece into a massive influx of infertile couples seeking treatment in our country, making Greece an important destination for assisted reproduction. I will also discuss the importance of Hippocratic Oath as becoming another possible destination point, and it is becoming, for doctors worldwide. So Hippocrates was an ancient Greek physician at the ages of Pericles, considered one of the most outstanding figures in the history of medicine. As the founder of the Hippocratic School of Medicine, he is referred to as the father of Western medicine. His school revolutionized medicine in ancient Greece, made it a discipline distinct from all else, establishing it as a profession. He became a mythical figure. A doctor during his lifetime, he defined medicine and separated it from philosophy, teaching rational thinking instead. The people of Kos, on his day of birth, worshipped him, and sacrifices were made yearly. His reputation as a great doctor extended beyond the borders of his particular homeland, as told later by physicians or philosophers like Plato and Aristotle. He founded his school at a time when the focus of treatment was to purify the body and soul, since disease was considered divine. So from ancient times, people have been searching for cures to diseases that plague them, leading them to places of worship, where the gods rumored to heal, or to places of gathering where people with special talents dealt with diseases. These places became known in ancient Greece as Asclepia, sanctuaries within nature, places of worship of the hero, doctor, and healer of the god Asclepius. To accommodate large crowds, additional buildings were constructed within Asclepia, such as theaters, gymnasia, and hippodromes, to be used for physical exercise and recreation, with emphasis on the special qualities of the natural environment next to thermal springs. Soon these gathering places became widely known and even more famous for their holistic approach to disease, combining psychological, emotional, recreational, and environmental factors, and the healing effects of thermal baths. As ancient Greeks searched alternative treatments in what they believed will relieve them from disease, this led them to thermal baths for relief. It's even argued that thermal springs was one of the oldest forms of health tourism. The thermal baths were used as places of relaxation, body care, hygiene, and wellness, combining aromatherapy and herbal medicine to relieve fatigue. The possible benefits of the thermal baths were known by Hippocrates, with special references to thermal waters and its healing properties. During the 18th and 19th centuries, the affluent social classes of Europe and Americas, experiencing health problems, visited these thermal springs for healing purposes. When the Roman Cornelius Sulla visited the baths of Oedipus at 83 BC, he was thrilled by the wellness of thermal waters and gave the order to build the first stone house on the baths at that time. This in turn led to the appearance of spas, contributing to the further development of tourism tourist destinations for such purposes around the world. Today, we live in an era of globalization, and cross-border movement of couples is an inevitable fact. In the context of what we call medical tourism, in vitro fertilization is the main service provided. Only in the United States, an estimated 1.5 million Americans travel abroad for medical care, and an estimated 4% of Europeans will receive medical treatment in a country other than their own. Spearheading attracting couples from abroad, thus adding to the growth of medical tourism, is indeed assisted reproduction. It is evident that the desire to reproduce has no borders, and IVF seems to be the leading medical service and a source of happy testimonials for troubled couples, full of sentiment which tend to be readily covered by the media. Infertility is an unexpected and dramatic event for couples who think that childbearing is an absolutely normal process and rightful in its own sense. A willingness to pay study suggests that to have a healthy child, couples in UK will accept a 20% risk of death and or will give up 29% of their income, whereas United States families will be willing to pay an amount that exceeds the actual dollar cost of IVF. These couples do seek and deserve the most comprehensive and objective advice possible. So many couples seek otherwise solutions to reproductive issues that cannot be solved in their countries of residence, and such destination points are created. The reasons for this include previous IVF failures and or legal restrictions. Couples crossing the borders demand a high quality of services, high success rates, and take into account accessibility of fertility treatment, facilities of IVF, and cost of treatment. The most important components of the strategic development of medical tourism are consumerism, quality, cost, and performance, the major lead being on academic medical centers and partnerships with public or private systems. The goal is for our countries to claim a respectable share in international medical tourism. The Diaspora constitutes a valuable national asset, an important part of the political, economic, business, cultural, and scientific potential of the nation. The spread gives a global dimension to the Greek nation and a unique opportunity to turn the disadvantage of past migration abroad into an asset for all today. They are a powerful tool for awareness within the countries of residence of Greek scientific achievements and can act as catalysts for promoting health tourism in general. So Governor Patoulis a while back set a priority on strengthening relations with our diaspora by aiming at our communities abroad and developing bridges with Greek medical associations in major capitals around the world, like the twinning of the Medical Association of Athens and the Greek Medical Association in New York. An awareness campaign on our innovations, coupled with testimonials of couples who came to Greece and managed to make their dream come true, creating headlines in the local and international press in regard to human stories, have had a direct emotional impact and particularly positive view for our country, attended by prominent members of the scientific and business communities in New York. These testimonies confirm the sense of trust we need so much in order to attract more couples. The same was repeated in Chicago, in Los Angeles, in Montreal, Canada, in Melbourne a few years ago, in London. Our innovation in our invitation to the Global Fertility Festival in Bucharest was the opportunity for the main square to be filled with smiles of children, most from IVF in Greece. As a result, through this awareness campaign about realizing expectations and making dreams come true, a destination point was created for Greece, as we now have infertile couples coming from 67 countries around the world, combining medical service and tourism options. The cross-border phenomenon is now well entrenched. This can be further augmented by enhancing partnerships between countries, raise public awareness regarding medical tourism options, describe medical options of countries according to excellence in specific fields, pinpoint tourism attractions, Initiatives such as these from our countries and institutions would not only promote further medical tourism, but also create new possibilities and opportunities for the business community to invest in health tourism. Medical tourism is the new opportunity now in sight for all to grasp, for couples, for investors, for companies, even for nations to make their presence more felt and together claim a larger and more respected share in this huge developing market. The Global Doctors Hippocratic Institute is all about Hippocratic legacy on medical science and thought, with the purpose of exchanging information, scientific knowledge, creating new perspectives for joint organization, development and implementing activities related to education and training in medicine, assisting scientists for postgraduate studies between universities, and raise public awareness regarding these options. Assisting scientists from Greece for postgraduate studies abroad, but also assisting scientists from abroad for relevant studies in Greece. Bypassing the unexceptional love, devotion, and loyalty of the Greeks abroad towards the land of origin, we are among a few countries to have Greek medical associations in major capitals around the world. In other words, we have a world network of Greek physicians ready to provide reliable synergies, beneficial cooperation, and new business perspectives. A network with unlimited capabilities, high quality, and competitiveness. By linking doctors, patients, and citizens abroad in a coordinated structure, we have a global network with huge potential. Making a difference is about recognizing the creative opportunity based on collaboration, joint operation and performance, as well as interconnecting medical schools, to enhance knowledge, to further stimulate research, to provide work experience and employment opportunities for new professionals, all within the context of Hippocratic values and lessons brought in from the past. Initiatives, as you heard from Dr. Polidorou, like the unveiling of the bus culture of Hippocrates within medical schools around the world, in Belgrade, done earlier this year, as well as in Melbourne University on Thursday, repeated in Bucharest, Romania, just a few months ago, as well as the University of Pavia, where the graduates were sworn in with the oath in ancient Greek language, with symbolic Hippocratic dedication ceremonies and planting of plane trees under which Hippocrates taught his pupils, and planned for next year to be repeated in universities of other cities like Bucharest, Cairo, Milano, and others, will further help spread all over the world the ethics and values of Hippocrates. Promoting further medical dedication, symposiums held with medical associations titled Hippocratic Values in Medicine will further promote our cause. Furthermore, such initiatives will create a vision for the business community to invest in good health practices, contributing further to the development of destination points for our country. Hippocrates' approach to medicine was humble and passive for his strict professionalism and discipline and rigorous practice. The Hippocratic Oath, one of the oldest binding documents in history, defines the morals and ethics of good medical practice, sworn to by medical graduates around the world. It has historically guided physicians' professional conduct and principles held sacred by doctors to this day. Though many versions of the oath have appeared, they all derive from the classical version as translated from the Greek. It has been adopted by the American Medical Association as standards of conduct, which define the essentials of honorable behavior of physicians, rewritten in 1964 as a modern version, and also by the World Medical Association in the Declaration of Geneva of 1948, with a latest revision of the Hippocratic Oath in 2017. Most medical schools worldwide still administer a version of the Hippocratic Oath to its graduates. All doctors worldwide do acclaim to possess the virtues and characteristics of devotion, pathos, and ethos to all that our Hippocratic Oath stands for. An oath that has more than just a historic or symbolic value. It guides us all in our everyday professional activities for the rest of our lives. As such, to invite all to renew the oath in providing services to our fellow citizens by auditing the authentic oath of Hippocrates on the very same place taken in antiquity, the island of Kos, the birthplace of Hippocrates, is a once-in-a-lifetime experience for all doctors around the world that can only but strengthen our resolve and commitment to medical ethics and protect moral boundaries in medical practice. Thank you for your attendance.
Thank you very much, Dr. Bardos. Many impressive achievements and indeed looking backwards in order to go forwards. We move on to session 4, current concepts in chemotherapy, and it's my pleasure to welcome Dr. George Iatropoulos, who is a medical oncologist at Austin Health, who will be discussing the treatment of breast cancer. George is a medical oncologist currently working in Austin, Olivia Newton-John Cancer Centre, Warringal and Waverley Private Hospitals. He completed training in the UK in tertiary academic centres such as Guy's and St Thomas's and Queen Elizabeth Hospital. On moving to Australia, he undertook a 2-year post-specialty fellowship at Austin Health in gastroenterological and breast cancers. George has extensive clinical trial experience in Australia and overseas. He also holds an MSc degree in cancer biology. He has a special interest in gastrointestinal cancer research and is completing a PhD in the field at La Trobe University. He enjoys engaging with the Greek Australian community and promoting cancer awareness. Let's welcome George.
And welcome, George. Just before your talk, though, the Greek guests just have a commitment for a moment. So what we'll do is we'll present the doctors in the room with, they'd like to present everyone with a pin as a symbol of the joining of the two societies. And then we can take a group photo and then we can continue with George's talk. So if we can get the doctors to come up. Maybe if you come from the left side, and you can present it with your pin. You got a microphone?
Anna?
It's okay. Yeah, it's okay. Hello. What time is it? Okay. Good morning. Good morning, everyone. My name is George Iatropoulos. Thanks, Dr. Stabelos, for the introduction. I was asked, it's a pleasure to be here today. So I was asked to present treatment of breast cancer, and obviously this is a huge topic. So I'll try to keep it short and sharp. So before I start, just to mention that Hippocrates was not only, as the father of medicine, is also the first one who described cancer, breast cancer. The first evidence, he was the first, and he actually used the word carcinos or carcinoma. And carcinos is when it was used the word when it was a non-ulcerated. You use the word carcinos, and carcinoma when it was an ulcerated lesion. It was obviously referring to the English word, to crab, the English word, and because of the appearance with the finger-like projections. And then that was 4th, 5th century BC, and then later Celsius, a Roman physician, he translated to Latin and used the word cancer that we use till today. And it was later in the Hellenistic period that Galin, he used the word ongos, like an outgrowth, a swelling. And obviously we took the first part of that, that's the first part of our medical title, oncologist, which actually means ongos and logos, oncologist. And funny enough, one patient who, when I was in the UK, he was very keen into the ancient Greek and said, I know what oncologist means like ongos and logos. You are the guy who going to talk to me about cancer. I hope you know, you just not only talk and you know you'll be able to do something about my cancer. The other thing that Hippocrates said that, and I'm just doing this just because we are talking about the Hippocrates, that he thought that cancer was an imbalance it was a humoral disease. humoral disease because he believed that the body, every disease has to do with the imbalances of the four humors of the body. One was the blood, the other one was the phlegm, the yellow and the black bile. And he thought that was cancer related to an excess of black bile. So I'll start my presentation after that. So it was about 20 years ago when this group of physicians, they took a number of breast cancers and they did some gene expression analysis, like human breast cancers, and they from this gene expression analysis they segregated breast cancers they actually molecularly classified breast cancers, and they came up with different, as we say, intrinsic subtypes, and so they came up with basal-like, which is otherwise triple negative breast cancer, HER2 positive breast cancer, and luminal A, B, and C. Obviously, since then, there's been like heaps of further sequencing and profiling, and they have really refined the molecular subtype of breast cancer. But what was apart from the molecular, these intrinsic subtypes they had different prognoses. With, as you see, the luminal 1A having the best. This is without any adjuvant therapy. I was talking for early breast cancers that didn't have any adjuvant therapy. Has the better prognosis than the other three, with the HER2 enriched or HER2 positive having the worst prognosis. But in clinical practice, what we do, we don't do gene expression or for every cancer. There is surrogate clinical pathological markers that we use, and this way we can classify. We can figure out the intrinsic subtype, and for luminal A and luminal B is basically the hormone receptor positive. The difference they have is that luminal A is very hormone sensitive, high ER positive, PR positive, high progesterone receptor. And when I say ER, I mean estrogen receptor, and PR, I mean progesterone receptor. And Ki67 low, which refers to is a proliferation index, while luminal B is less hormone sensitive, with still ER positive, but lower PR progesterone receptor, and high Ki67, suggesting it's a more highly proliferative cancer. Then we have HER2 positive, which HER2 as a marker is a negative prognostic marker, but at the same time, because we now have treatments, it can compensate because it's negative prognostic, meaning becoming a predictive marker, because the treatments we have developed, they can make this cancer and patients to have a good, better outcomes. And finally, we've got the basal-like, as we say, otherwise the triple negative with no expression, no HER2, no ER, no PR expression. Obviously, before we decide what treatment, we take into consideration a lot of things when we decide what treatment and how we're going to treat someone. I'm talking from the oncologist's perspective. We're looking at the stage of the tumor. You see the TNM, about the grade of the tumor, the differentiation grade. As you see, we're taking into it's a mix of three things. We're looking the tubular formation, the nuclear atypia, and the mitosis, and then you sum these up and you get a number, and it tells you if it's a well or poorly differentiated tumor. Also, staining, the pathology will stain for ER, PR, Ki67, HER2, and sometimes if the HER2 is equivocal, because it could range from 0, 1, 2, and 3, if it's 2 plus, which is equivocal, they will proceed and do FIS, as we call them, like fluorescence in situ hybridization, and will tell us if it's amplified or not. So we'll get out of this ambiguity in case it's a +2. So we'll take this all into consideration, and then we design the treatment for every individual. So just this flow chart. For early breast cancer, if it's a small cancer, if it's going to be able to resect it with cosmetically fine, then you proceed and you do breast, because we're now doing breast conservation surgery, you do that. If it's a bigger tumor and it's too big for a mistake, or you need to downstage it so you get a better surgery. If it's not amenable to mastectomy, you want to downstage it to get a mastectomy, or you want to shrink it a bit so that you can get a better lumpectomy, or let's use the term breast conservation surgery. We proceed and we do preoperative chemotherapy. And obviously the third group there that first, the patient doesn't want to have patient wishes to go straight and or it's not amenable, and we go straight to doing a mastectomy. And after the surgery, depending depending on the response to preoperative chemotherapy, if it's good, we do breast conservation. If not, we proceed to mastectomy. And then after that, we oncologists come and we offer, based on taking into consideration all these parameters I mentioned earlier, what kind of treatment we're going to give them. And that could be include chemotherapy, anti or not anti-HER2 therapy, and endocrine, followed by endocrine therapy and radiotherapy. So again, on this graph, so the first thing is we separate them if they are ER positive or ER negative or ER positive. That's the first thing we look at. And then after that, we go and say if it's ER negative, if they're HER2 positive, then these patients are going to take chemotherapy and anti-HER2 therapy. And probably you all know Herceptin, that's one of the anti-HER2 drugs. If it's a triple negative, it's an aggressive cancer, and most of the times they need chemotherapy, unless there's some special subtypes which are rare that they don't really need chemotherapy. And then if it's hormone receptor ER positive, then again we'll look if it's HER2 positive, HER2 negative. The luminal A, which is the very estrogen and progesterone receptor positive, usually they don't need chemotherapy, they go straight to endocrine therapy. The luminal B, which they're less sensitive, then we have to look all these other parameters, how high, how low is the ER and NPR expression, the Ki67, the burden of the disease, and we may or may not offer chemotherapy. And if it's obviously ER positive, then we give everything. We give chemotherapy, anti-HER2, and endocrine therapy. I'm just going to so chemotherapy, it could be short or long course chemotherapy, 3 to 6 months. We usually nowadays, we use a combination anthracyclines sequenced by taxane. Sometimes we may avoid, if there is cardiac history or possibility of cardiac complications, we might omit the anthracyclines. So there's short and long course chemotherapies. And then as regards the endocrine therapy, for premenopausal women, we use tamoxifen 5 to 10 years. There's now mature data that the more you push the tamoxifen out to 10 years, the more benefit you get, and you may get to see that benefit even like 15 years later. But in premenopausal women, we can also use aromatase inhibitors. Aromatase inhibitors are the drugs that they block the conversion of pretty much fat, the production of estrogens by the fat tissue. So you've got these two options in premenopausal, but when you use aromatase inhibitors, you also have to suppress the ovarian function with usually LHR8 agonists. For the postmenopausal, the best drugs, what everyone's using is aromatase inhibitors. And then coming to the anti-HER2 therapy, every HER2 positive patient after surgery for HER2 positive cancer, they do get anti-HER2 therapy, which is Herceptin, trastuzumab. Sometimes only we may skip the chemotherapy if it's a really small tumor. There is risk of they can cause cardiotoxicity that we monitor the cardiac function while they're having treatment. There is data, there's a second anti-HER2 drug which is called pertuzumab for high-risk patients, and that might be the bulk, big tumors with lymph nodes in the axilla involved. We might give the combination of pertuzumab and trastuzumab. Yeah, and so this is pretty much an outline of how we manage early breast cancer surgery, and after the surgery, sometimes, quite often, we might give chemotherapy first, shrink the tumor, have a breast conservation surgery, and then follow with radiotherapy or more chemotherapy or endocrine therapy. That's pretty much how we manage early breast cancer. Now, there's been a lot of advances in the advanced breast cancer mainly in two fields, in the endocrine sensitive cancers and the HER2 positive cancers. So this is by ESMO, the European Society of Medical Oncology, and this is how an algorithm of how we manage metastatic breast cancer, which is ER positive, HER2 negative. Before, till recently, we were just using endocrine therapy, the same drugs I mentioned, aromatase inhibitors or tamoxifen, but now we have these new beautiful drugs. They're all therapies, and we call them CDK4/6 inhibitors. And now, I mean, most countries, I don't know what's the situation in Greece, but here in Australia, we use them all the time. It's very convenient drugs and overall well tolerated. So that's the first option. Then, if they progress, then we might do some mutational analysis and look what other treatments we can give after. And there are treatment options, other combinations of hormonal therapy with targeted therapies. I won't expand much about this because it's big, the second line therapy options. I will just talk a bit more about the CDK4/6 inhibitors. As you see here, in the signaling pathway in breast cancer, obviously on the right side you've got the classical endocrine therapies, the aromatase inhibitors. You've got the estrogen receptor down regulator like fulvestrant, which is an intramuscular injection, and tamoxifen. And the breakthrough was by bringing new drugs to target other parts of the signaling, like PI3 kinase inhibitors, mTOR inhibitors, and the big advance was the advent of the CDK4/6 inhibitors, which those three drugs. So there's been, I know in oncology we're getting very technical. We present a lot of studies. It's sometimes difficult for other doctors to follow the presentation. So I'm just putting a summary of what we know about these drugs. So we have three drugs: palbociclib, ribociclib, and abemaciclib. They all have been used predominantly in postmenopausal women. We've got data from ribociclib for premenopausal women. So all drugs, what they do, they delay the progression. The time takes for the time they go on the drug, the time they stay on the drug and they don't progress, and they clearly offer a survival benefit that could range from 10 to 15 months. Obviously, in the palbociclib, that's not obvious there because there was crossover allowed in the study. Also, they're good drugs that you can use as a second line. If, for instance, you started with only single agent endocrine therapy like tamoxifen or an aromatase inhibitor, you can second line use them, and still they're good drugs, and they delay the progression and they offer a survival benefit. So these drugs now have really revolutionized the field of the first line therapy for advanced endocrine receptor positive breast cancer. And then about the HER2, and I'll probably start going a bit faster. So if you got HER2 positive metastatic breast cancer, then you need to get some sort of anti-HER2 therapy, and there's been a lot of new things coming in that area. The algorithm, ideally you should have it with chemotherapy because it's more benefit. If you cannot have the chemotherapy, it's contraindicated, then you can just have the combination of the two anti-HER2 drugs. So first line, based on a hallmark study, the Cleopatra study, when you put the two drugs, anti-HER2, pertuzumab and trastuzumab together, plus chemotherapy, then you offer a significant, really significant survival benefit. And it's not only the survival, it's also the symptom control, the response of the disease, and that has really changed the practice. That's what everyone pretty much gets first line as a first line treatment for HER2-positive metastatic breast cancer. For the sake of time, I won't go. If anyone wants to ask me about these drugs, I can tell you after. But the field and the science keep working, and we got more and more drugs on the HER2 field. This is the Cleopatra study, just the curve showing. Yep. The second line, what's been the new thing? So if second line, if you have brain metastasis, your doctor has to do something about that. Get you some kind of treatment, surgery or radiotherapy, stereotactic or whole brain radiotherapy. But if you are okay and you don't have brain metastasis or under control, there are drugs like the new drug is trastuzumab deruxtecan. That's where I would like to tell you about today. So before that, we had the TDM1. We still have the TDM1. TDM1 is not new. It was second line, showing a survival benefit. We've been using that. Now we've got trastuzumab deruxtecan. It's pretty much the same Herceptin drug. It's a different way of delivering it. It's bound to chemotherapy. It's the antibody plus a linker and a chemotherapy, and it's more efficient delivery of chemotherapy through a monoclonal antibody. This is the study. It's been a successful study. So far, big, at 12 months, a huge difference in progression between patients. Still early to say any survival data because, as you understand from previous, the HER2 therapies, they have prolonged the time it takes for the cancer to progress, but we are very confident that this drug will make a difference in this field. And this I'm closing with this study. It's another anti-HER2 therapy. I have personally been involved at Austin with this drug, tucatinib, which is an oral anti-HER2, plus trastuzumab, plus chemotherapy. It's more for people that, it's more that you should be using people that they have, I'm talking about second line, that they have brain metastasis, that they're stable brain metastasis, or they're progressing but they are stable. So this drug has shown, in combination with Herceptin and oral chemotherapy, shown that it improves the survival in HER2-positive breast cancer patients with brain metastasis. We don't have here this available in Australia, but I believe it will come soon. And that's it.
Thank you very much. Thank you very much, George. George, thanks very much. And a number of advances there, which I can certainly say in general practice, we are seeing the improvement in the survival rates as well. So we move on to session 6, current concepts in diabetes management, and it is a pleasure to welcome Associate Professor Spiros Vroulanos, who of course is Director of Endocrinology at Royal Melbourne Hospital. He's on the HAMSA board and one of our favourites in many ways. And continuing along the technology line, the title of the talk today is Technology to Deliver Better Diabetes Care in the Hospital. Let's welcome Spiro.
Thanks very much, George, for the kind introduction, and to the conference organisers, to George and Marini, and very grateful to our international guests for coming and joining us. They've made a huge effort, and it's been delightful meeting them. So this is a field which is in its embryonic stages, actually, and we've helped kickstart this in Australia. Hopefully we can advance. I don't have any relevant disclosures, apart from the fact that I treat about approximately 400 Greek patients per annum, and I'm sure there are people in this room who treat even more. One of the reasons this talk is relevant is that diabetes is more common in people of Greek descent. So this is the Melbourne Collaborative Study, which was published almost 20 years ago, and it showed that diabetes occurs in 3- to 4-fold rates compared to people from Northern European origin. So there is a strong genetic predisposition, And multivariable analyses with this particular data set showed that even though the Italians and Greeks were overweight, the effect was independent of BMI. Now, what has happened in Melbourne, and these are data we've published from the Royal Melbourne Hospital. I'm very fortunate that my predecessors, Skip Martin and Peter Coleman, actually had data collected based on point prevalence studies in the hospital and showed that the prevalence of diabetes in inpatients at the Royal Melbourne used to be under 5% in the 1970s. Now, obviously, in the 1990s, WHO changed the criteria and lowered the threshold for diagnosed diabetes from 7.8 to 7.0, so that partly contributed. But as you know, we have many migrants in the city, an ageing population, plus obesity, and what that has conspired to create is 25 to 30% of inpatients have diabetes now at the Royal Melbourne. So you come to the wards and there's diabetes everywhere, and these data are very much consistent across all of Australia and very much similar to data from the UK. The reality is diabetes is costing a lot of money. You probably know 1 in 16 people in the world have diabetes, approximately 520 million people in the world. And if you look at these particular data here, on average 229 million is spent in healthcare in public and private hospitals in Australia per day, and diabetes accounts for at least 10% of this. That's $29 million a day spent on diabetes in hospital. On average, there's 32,000 admissions in Australia to our public and private system, and at least 8,000 of those are in people with diabetes. And guess what happens to people with diabetes when they're admitted to hospital? They have extremely high rates of healthcare complications, a concept called HACs. I'm not sure what's in the US and Greece. And this is sort of, medical misadventures, things like, pulmonary emboli not occurring on DVT prophylaxis and severe hypoglycemia. And on average, in Australia, there'd be 4 cases of Staph aureus bacteremia on any given day. And we'd estimate at least one of these is occurring in people with diabetes, if not more. And what we're seeing at ground level is the staff are burnt out. Obviously, the COVID pandemic has not helped. And the last thing you need is a whole lot of finger pricks, insulin administration, a whole lot of angst around diabetes in the hospital. And that's the reality. And I call myself a diabetes fireman. I spend my whole day putting out fires in relation to diabetes. And this is impacting, obviously, on the people with the condition, most importantly, and their carers. And it's costing money because of increased length of stay. Now, the Brits have documented this par excellence with the Nadia study. We were very grateful. We had Professor Jerry Raymond visit us, and he's the leading person in inpatient diabetes in the UK. He was our guest at the Royal Melbourne and for our National Congress a few months ago. He's a fabulous person, and he kick-started this whole process to audit diabetes care in the UK over the last 15 years. And what he's found, he and all his colleagues in the UK have shown that for type 1 diabetes, if you come into hospital, there's a 1 in 25 chance you'll get diabetic ketosis or ketoacidosis, which is really quite high. We're talking about in hospital. And when it comes to severe hypoglycemia, which is blood glucose under 3, there's about a 1 in 4 inpatients with type 1 will experience that during the admission, probably about 10% overall. So really very high rates of hypoglycemia. Now, we have done the DINGO study, which is really one of the largest observational studies, which has been extremely detailed at characterising what's happening with diabetes in the hospital in relation to adverse clinical outcomes. And you'll see on the bottom panel, it's a little bit small, but there's healthcare-associated infection, which is, my pointer's not working there, on the left, and we have mortality on the right. And we've looked at glucose prior to event. Patient day mean glucose, pre-event, pre-death, and these are all clinical outcomes in hospital outcomes. So if you come into hospital with diabetes, you have a 1 in 30 chance of not getting out due to death. If you come into hospital and you experience what we call in-hospital hypoglycemia, which is 2 glucose levels above 11, you have about a 1 in 8 or 9 chance of dying. So the reality is that diabetes and new hypoglycemia are strongly associated with all the big ticket items: acute kidney injury, healthcare-associated infection, and mortality. And I'm talking about glucose levels pre-event. And we've subjected this to a multivariable analysis, and it's totally independent of everything. It's independent of Charlson score, it's independent of age, it's independent of renal function, etc. So there is a strong biological link between glucose, and we're talking about in-hospital glycemia. And in fact, your glucose status in hospital is a better predictor than whether you have diabetes. And that's why this finding actually holds even truer if you don't have diabetes. So, with that background, just quickly, I'm going to cover the diabetes technologies, which I think will start transforming diabetes care in the hospital. And the first one is network blood glucose meters. So in the US, the big centres have network blood glucose meters. In the UK, about 35% are networked. In Australia, we have been a little bit behind. So, what I have been busy with in the last 4 or 5 years at the Royal Melbourne Hospital is laying down the tracks, the electronic tracks, for better glucose care. And this is obviously, you can see the Athens network there, the rail network. Our rail network's not too good here, but it's going to be improved, hopefully. And what has happened with point-of-care testing is we've gone from urine dipsticks in the 1970s to standard point-of-care meters in the 80s. And then in the last 15 years, there's been the availability of these network glucose meters. And all that simply is a glucose measure is assigned a patient identifier, and it can be linked to an electronic medical record. Very simple. But up until very recently, you do a point-of-care glucose test at the bedside. It was not linked with a patient identifier, so you couldn't do any research around it, and certainly couldn't transfer into a medical record. Now, what's happened at the Royal Melbourne is we've become the first hospital to have a fully networked blood glucose meter system in Australia. So we are fully wired across all wards, so I can go to my computer, I know exactly what everyone's glucose control is, no matter where they are. We don't have to physically around anymore. So we're delivering a lot of virtual care, and I'm really glad we put that system in, because we put it in before COVID, and it was an absolute godsend for us. And we're also the first hospital to have auto integration with an EMR. So when the point-of-care blood glucose is done at the bedside, it wirelessly is sent off into the EMR and avoids the nurse having to run to a computer to type in the blood glucose measure manually, and we know there's a lot of error when that happens. So these devices are fantastic, and they are transforming our care. Now, to set this up was really quite complicated, and thank God I had Rahul Barmanray, who's a PhD student, a young endocrinologist, a very smart boy. He's a bit of a tech guru, and we helped set up a whole lot of middleware to connect the device to the Epic EMR. Epic is one of the main proprietary EMR systems used in the US, and we've had that inserted at the Royal Melbourne recently. And all of a sudden what's happened is we've been able to benchmark ourselves against other hospitals, in particular the US. And so for the first time, we've published data to say, well, how are we doing compared to America, where these benchmarking systems are really much more advanced. And what we found with our particular data set is that our mean glucose is probably a little bit higher, and that makes sense. I think the Americans are more aggressive with their glucose management. Having said that, we have much lower rates of hypoglycemia. And more recently, we've just shown that by bringing in a whole lot of initiatives, and this has been published in one of the leading tech journals now in the US, that we actually started to improve our care. And you can see our arrow is starting to move in that bottom left quadrant. So on the y-axis, we have patient day mean glucose, on the x-axis and y-axis hypoglycemia. So you want to be in that bottom left quadrant, which is lower rates of hypoglycemia, lower patient day mean glucose. So any hospital that's coming to this section is really gold standard. And we've demonstrated we're starting to improve our care at the Royal Melbourne, although there's work to be done. Now, the great thing with this technology is it's been an enabler for us to do two major large clinical trials. And the first one was called RAPIDS, and this is a bundled intervention where we brought in this meter system, a pathway for managing diabetes in hospital, plus a specialist team. And what we did was we did what's called a cluster randomised clinical trial. So we randomised certain wards to early intervention care with specialist teams, and using this meter system to alert us about people with diabetes versus standard care. It's quite a big study, biggest study to date in the world outside of ICU, and that was 1,000 people. And what we demonstrated is that we reduced glucose. We achieved our primary outcome measure, which is adverse glycemic days. We reduced patient day mean glucose, and really what surprised us was a 60% reduction in healthcare associated infection. So we thought, this is quite incredible. In fact, we don't even believe it. Now, the healthcare associated infection was a secondary outcome measure. We thought we better do another study, because this is really quite surprising. So what we've now done is we've just completed, and this happened last year during the COVID pandemic, we completed our second big trial. This is N equals 1,370. This is now the largest RCT of a model of care in hospital. And this was individually randomised, not cluster. So we randomised at the level of individuals within the hospital. And we compared standard care, which I call reactive care, which is you wait for the parent team to involve the specialist to help out, versus what we call electronic-based care, okay, proactive electronic-based care. So what happens is when a patient was admitted, within 24 hours, the system would send us an alert to say the person's in with diabetes, these are their glucose values. We would provide an electronic consult virtually, and then we had certain criteria and we'd escalate to bedside review for their diabetes if there were problems. And then once they were stabilised, they'd pop back to the parent team. And there was no differences in the intervention control arms. And we achieved our primary outcome measure, which is we lowered patient day mean glucose. Now, it's only 8.6 to 8.2. It's highly significant. You may think that's not that much of a difference, but across a big population, it is very significant. And most importantly, yet again, we've shown a reduction in healthcare-associated infection for the second time now. That's a 30% reduction. And essentially, surgical site infections, bacteremia, respiratory tract infections, UTIs were decreased. So this is going to be relevant to all medical and specialist disciplines. Now, this study was done specifically in surgery, and we have a medical study planned. And importantly, there was no increased hypoglycemia, which is always our worry. And what is quite surprising to us is mortality almost achieved significance at 0.08. If we'd achieved that, then it really would have been big news. So that's the network glucose meters, and that's coming. And then we have continuous glucose meters, which those of you working in primary care will be very familiar with. Συνεχής παρακολούθηση της γλυκόζης. I've just had to look that up. Now, they're interesting, these devices, because they're measuring interstitial fluid glucose as opposed to blood glucose, but we know they're an excellent proxy for blood glucose. And with the COVID pandemic, especially in the US, people said, well, maybe we should start using these devices when we don't want to go into the room with patients, and they hooked them up to these sensors. And in fact, Americans did a study in the context of COVID in ICU use, and it does look like the point of care measure correlates extremely well with interstitial fluid glucose. And importantly, they've done an RCT most recently. This is actually Spinakis, another Greek. He's quite well known in the field in the US, and they've shown that use of these devices leads to less hypoglycemia in hospital. So I think they're coming to hospital very, very soon, and they measure glucose on a minutely basis. So inpatient care is going to become a lot more busy and complicated. And then we've got pumps. Now, I never knew what the Greek word was for pump until I managed an Athenian girl who came to me at the Northern Hospital when I used to be there, and it's andlia, which I didn't know. So she was fantastic. She taught me a lot of terminology about insulin pumps in Greek. And now we've got some fantastic hybrid closed-loop pump systems called, otherwise known as automated basal insulin delivery. And Leah Bally is one of the leading people in the field with Havorka, have actually used these devices in the inpatient setting. This is a study involving about 130 or so medical and surgical patients where they randomise them to going onto a pump with automated basal insulin delivery, so artificial type intelligence, as Chris Oldham was saying, versus standard care, and they improved glucose control. So I think this is also coming for the very tricky patients on the wards. I wouldn't be surprised next 5 years if we start seeing this being used. So the summary is that network blood glucose monitoring is enabling benchmarking and newer models of diabetes care. Early proactive intervention with specialist care seems to improve clinical outcomes, specifically infection, so we're quite excited about that. And I think the scene is being set now for CGM and pumps in hospital. I think it's coming, and that's why we're preparing. I think there may be even an opportunity to collaborate with our colleagues in Greece, because I actually did a bit of a search, and there doesn't seem to be too much on inpatient care and diabetes that I'm aware of in terms of published literature. So thank you.
Spiros, thanks very much for those insights, and I must say anything that reduces the burden of diabetes management to the patient and to health professionals is more than welcome. Now we turn to our surgical specialties, and session 7 is current concepts in neurosurgery. I'd like to welcome Dr. James Dimu, who is consultant neurosurgeon at the Royal Melbourne Hospital. He's going to discuss current treatments in the treatment of brain cancer. James is a neurosurgeon scientist with subspecialty expertise in clinical management and research of brain tumours. his neurosurgical philosophy and probably velocity is that he emphasises the importance of prioritising compassionate, individualised patient care that is grounded in the best scientific evidence. Let's welcome James.
Okay, good afternoon, everyone. I'd first like to start by thanking the organisers for the opportunity to speak today. So I'm going to be talking about brain cancer, which is something that I've decided over the last 5 or so years to dedicate my working life and career to. So just an overview as to what I'll be talking about today. So first, I think we'll talk about the genetics of brain cancer, a little bit about epidemiology and clinical presentation, just to paint a picture. Talk about the radiology, the management, both from the point of view of surgery, radiotherapy and chemotherapy, and then just a conversation at the end about new advances. So much like a school debate, it's really important to get the definitions right. So there have been now 5 editions of the WHO CNS tumour classification, the last one having been released actually just this year, although it's dated as 2021. So how do we get from this really long list of, really convoluted and contorted names to come to a final definition of what we would consider to be brain cancer, at least in the majority of cases? So we are focusing on this group of tumours, so gliomas, glioneuronal tumours and neuronal tumours, and in particular, the worst of them all, IDH wild-type glioblastoma. So before 2016, this is all you got with regards to pathological classification of these 3 tumour types. So it was literally some glorified Rorschach plots done in hematoxylin and eosin, which come back with a report saying that's either a grade 2 astrocytoma or a grade 3 anaplastic oligodendroglioma or a glioblastoma. And the only thing really differentiating them, if we look across at the astrocytoma column, is really the features that were seen under the microscope. So grade 2 was defined by nuclear atypia, grade 3 by the presence of mitoses, and grade 4, or a glioblastoma multiforme as it used to be known then, which is now outdated nomenclature, constituting grade 4. The problem is, of course, is that the prognosis related to all of these 3 was not necessarily related to the pathology that was seen under the microscope. And also confusing thing was this 3rd column of oligoastrocytoma, where there were features histologically of both tumours, but in reality, the prognosis and the clinical manifestations were not easy to kind of put in a prognostic box. So there have been a number of next-generation sequencing studies done in glioblastoma, dating back probably from 2008 up to 2015. In that time, glioblastoma went from well and truly being the poor orphan of oncology to all of a sudden being the shining star in terms of molecular characterization. So you will have read papers in Science and Nature from luminaries like Eckel-Passow and Parsons who've basically sequenced hundreds of high-grade and low-grade gliomas. Now, the one thing you'll see up there is this concept of an IDH mutation. So the IDH mutation basically was discovered as part of this cancer sequencing as being consistent with those tumours that had a better longer-term prognosis. They seemed not to progress as quickly as those tumours that did not have the mutation. So IDH wild type, which means normal IDH, was bad. The other thing that they also noticed was that there was a chromosomal abnormality whereby you lose the short arm of chromosome 1 and the long arm of 19, and that also portended a better prognosis, leading to the diagnosis of oligodendroglioma. So this is what we've ended up with, and there have been a number of other studies which have further augmented our understanding of what brain cancer is. But if we look to this slide on the right, you can see that now you cannot have the diagnosis of glioblastoma with an IDH mutation. And not only that, the features under the microscope no longer make any difference as to whether or not a tumour would be diagnosed as such. So a tumour that's got an IDH wild type, but has one or two of the key genetic abnormalities that have been found in a number of cancer sequencing studies will automatically lead to the diagnosis of an IDH wild type glioblastoma. So this is something that has quite radically changed the way we talk about genetics and molecular classification. Has it made a change to management? At this stage, it has not. And I'll go into that shortly. Just a little bit about epidemiology. So glioblastoma accounts for 50% of all adult primary brain tumours. The incidence overall is pretty low. It's actually higher in the West than in Asian and African countries, and the male to female ratio is almost 2 to 1. Probably the most interesting thing though about this tumour is that it is the 15th most common type of cancer. So it is way behind prostate, it's way behind breast, lung, even renal cell. But in terms of productive years lost, and there is more than one study on this, it is number one. It is a bigger killer than all of the other cancers, including pancreatic, which is also a cancer which does present at an earlier age. The median survival, as you can see there, is 15 months. It's been 15 months for almost 20 years. The 5-year survival rate is less than 10%. The 2-year survival rate is just over 25%. How do they present? So patients present really with symptoms dependent on tumour location. So if patients have hemiparesis or hemisensory loss, it's likely to be adjacent to or invading the motor or sensory cortex. If patients have frontal lobe dysfunction, so indifference or neurocognitive issues, then there may well be frontal spread. If there's an occipital lobe tumour, then it's likely to lead to visual field deficit. Seizures are a common form of presentation, but in actual fact, seizures are much more commonly seen in lower grade gliomas like lower grade astrocytomas and oligodendrogliomas. And of course, and I'll show an example very shortly, we always talk about the symptoms of raised intracranial pressure. So severe worsening headache, particularly worse in the morning when patients have been lying flat for 7 or 8 hours at a time, associated with nausea and vomiting. And that's usually in the later course of the disease. And then of course, this is a rapidly progressive cancer. The majority of patients, from the symptom onset to the time of diagnosis, it's less than 3 months. So this is a patient that I treated recently, and just to show you the radiology from left to right. So on the top left, we have the T1 with contrast view. And as you can see there, it's a very large lesion, 6 centimetres, which is essentially invading the frontal lobe all the way down to the corpus callosum, which is essentially basically the part of the brain that connects the right to the left. Now you can see on the picture below it, there's a lot of white. That's called the FLAIR study. So it's fluid attenuated inverted reduction. That's what it stands for. And basically what it does is it takes the white of the normal fluid away and leaves the tumour fluid behind. So as you can see, there's a lot of flare. It's important to remember that for the next part of the talk. You can see very deep, just here, sorry this doesn't work, very high perfusion. So that will also be interesting in regards to some of the other treatments. Spectroscopy shows that there's significant neuronal destruction. This is the post-operative scan, and as I'll show in a minute, this is essentially the goal of surgery. The goal of surgery is to remove all of the enhancing tumour whilst keeping the patient as well as possible from a neurological point of view. These are some other presentations. So on the left, you have what's called the butterfly glioblastoma invading through the corpus callosum, both frontal lobes. Up to 25% of patients will have multifocal glioblastoma, so in more than one location, in 2 or more separate lobes. And this looks benign enough because there isn't any contrast enhancement, but you can see that it involves the insula, frontal lobe, and also deeper through the internal capsule. This is something called gliomatosis cerebri and portends a particularly poor outcome. So appearances don't necessarily account for the aggressiveness of the disease. So in terms of surgical management, we actually have no class 1 evidence to say that extended resection changes, is beneficial. That being said, these are two retrospective studies which looked at extended resection graded up from about less than 80% up to 100%, and then looking at the overall survival depending on the extended resection. Both these studies came from the same author. He initially was at UCSF in San Francisco, and then he moved across to the Barrow in Phoenix. Both those studies essentially show, the first being in primary glioblastoma, the second being in recurrent glioblastoma, that the minimum requirement for extended resection is around about 80%, and there's a stepwise improvement in prognosis as you take out more contrast-enhancing tumour. Now, in order to maximise extended resection, there is, in fact, class 1 evidence, 2 randomised controlled studies, which show that you can improve extended resection with certain adjuncts. So the first is 5-aminolevulinic acid, 5-ALA. It's a protoporphyrin derivative. And what it does is the patient drinks the substance. It then crosses the blood-brain barrier, and then under blue light with the microscope, it's able to be visualised, as you can see on the screen here. So this was actually a true bench-to-bedside study, and it got to the point where the German investigators found that there was clearly an improvement in extended resection compared to normal stereotaxy, and that was published in 2006. The other technology, which is also available, is intraoperative MRI, which is obviously a lot more expensive, but certainly does the same job in that you've got time to then operate on the patient, put the patient in the MRI scan, check that you've taken out all the contrast-enhancing tumour, and then move on. So a subsequent study by another German group about 4 or 5 years later also showed that the extended resection was increased. Neither study, however, showed that there was an improvement in overall or progression-free survival. But when the Stummer paper back in 2006 was retrospectively reviewed, they did find that extent of resection and the only threshold for extent of resection which mattered was 100% removal of the contrast-enhancing tumour. And that did portend a better survival benefit, so that the class of evidence for extent of resection in glioblastoma is level 2B, not level 1. However, as I alluded to before, this cannot come at the expense of neurological deficits. There's no question that patients who have poor ECOG scores, poor Karnofsky performance status, do poorly even when the extended resection is adequate, and that's been shown in a number of retrospective studies. This is probably one of the more recent ones out of China. This leads to the concept, though, of supratotal or supramaximal resection. So when I was doing my neuro-oncology fellowship at the University of Calgary under John Kelly, we undertook a systematic review of supramaximal resection in glioblastoma. Now, this has come from the low-grade glioma surgery groups, and the concept is by taking out tumour beyond the contrast-enhanced margin, that will improve survival. The problem, of course, is that there are very, very few groups doing it, and of course, there are very few patients in amongst that group that are actually eligible to have a supramarginal resection because of the fact that a lot of there's eloquent tissue. In one study, for example, only 5% of patients actually qualified for anything approaching a supramaximal resection. So this, in essence, for a lot of patients, is not really it's not really feasible. That being said, the RANO group, so the Response Assessment in Neuro-Oncology group, have done a very large retrospective study looking at over 1,000 patients from 7 different centres, and they too have found the same thing, that if you achieve a supramaximal resection compared to 100% gross total resection to subtotal resection, there is a stepwise drop in the overall survival. Now we come to adjuvant therapies, the STUP protocol. So STUP protocol is concomitant radiotherapy and temozolomide, which is given for 4 weeks after the, for 6 weeks after surgery, and that usually starts 4 to 6 weeks afterwards, and then followed by monthly temozolomide, which is given over a week. This is arguably the most, well, this is definitely the most famous Kaplan-Meier curve in neuro-oncology, if not the most famous Kaplan-Meier curve in medical oncology. So as you can see on the graph here, blue is the group that was treated with radiotherapy and temozolomide, and red is the group that was treated with radiotherapy. So it is class 1 evidence, a randomized control trial, and the median survival went up from 12 months to 15 months. That's blocked. It's kind of frozen. It's frozen. So moving on from there, there was shown to be an association with MGMT gene silencing, and then there are other treatments which have shown some benefit in recurrent glioblastoma, such as bevacizumab, which got late FDA approval through this New England Journal of Medicine paper, as well as tumour treating fields, which is a very controversial treatment, which did show a statistically significant survival benefit. However, there was no sham device as part of that trial. So, unfortunately, when it comes to new advances, the needle hasn't moved for 20 years, and there are lots of different groups doing lots of different things. And as you can see on this very busy slide here, there's really no consensus about the best way of attacking this lethal tumour. And so really there needs to be a conversation about developing superior laboratory-based tumour models, working, I think, more assiduously on the stem cell theory of differentiating between stem cells in cancer and non-stem cell differentiated tumour cells. Is glioblastoma a true cancer, or is it really simply organ failure to a catastrophic degree? Is supramaximal resection of glioblastoma really the answer? Like, are we just going to keep hacking out more and more brain to kill this or to defeat this? And is surgery and chemoradiation actually the thing that's stopping us from moving forward to trying to find a new direction in treating this? So in conclusion, the current standard of care for IDH wild-type glioblastoma or brain cancer is maximal safe resection, radiotherapy with temozolomide chemotherapy, and bevacizumab for those patients who have recurrent glioblastoma. And new advances require significant changes in terms of innovation and a fundamental rethinking of how we approach this tumour moving forward. Thank you for the invitation to speak.
Thank you very much, James. We will move on to session 8. So current concepts in health and diet. Our first presenter is none other than Dr. George Stabelos. George is a GP clinician with 30 years of involvement in the healthcare sector, initially in allied health and later in medicine. He completed his medical degree along with myself at the University of Sydney, graduating very, very soon after myself. Has interest in family medicine, musculoskeletal pain, and sports and lifestyle medicine. He's also one of the fellow HMSA board members. Welcome, George.
Κυρίες και κύριοι, καλησπέρα και σας καλωσορίζω. Ladies and gentlemen, good afternoon and a warm welcome. We are discussing lifestyle medicine this afternoon, and what better place to start than in the Mediterranean, and in particular, Greece. In the next 15 minutes, I'm going to define the emerging discipline of lifestyle medicine. What is it? Who's involved? What's the difference between lifestyle medicine and preventive medicine? How does it fit in with public health? And what are the lifestyle medicine doctors, scientists and others are telling us will be the advantages of this approach? We're going to talk about food as medicine versus the other lifestyle factors, then take a whirlwind tour of the blue zones, the 5 places on the earth where people live to the ages of 90 to 100 at 10 times the rates of industrialised nations such as the United States. 2 of those zones are in the Mediterranean, and 1 of them is in Greece. Once we've done all that, we're going to do the lifestyle medicine thing, and we're going to slow down. We're going to ponder. We're going to contemplate. We're going to question, perhaps in a similar way to what Socrates or Hippocrates did. And we're going to ask ourselves 3 questions during this presentation. The first one is, what do we do about this lifestyle labyrinth that knowingly or unknowingly many of us, most of society, finds itself in? Secondly, as doctors, what's going to be our lifestyle legacy? And thirdly, on the basis of the evidence, are there habits and behaviours in the Mediterranean lifestyle and the Blue Zones lifestyles that are so precious that they deserve immortality? In 2020 in Australia, around 60% of the population was overweight or obese. In 2025, the projected figures are 72%. Where will this end? When you look across the world, nations with similar BMI issues, like Australia, are in the orange. There are others, however, where the story is even worse, the ones in the red. When you look at the Mediterranean, in particular Greece, Italy and France, they are certainly doing better. And there's something quite sad, SAD, that's been going on for a while. The standard Australian diet, the standard American diet, which is pretty much 85% processed or animal-derived food, with only 11%, for example, being things like vegetables, fruits, nuts, and around 4% being whole grains, the type of thing that we would call the Mediterranean-style eating pattern. And intriguingly, and perhaps not so surprisingly, 50% of those 11% of vegetables is what? Fries, potato chips, what we term in Australia chips. So the average American consumes around 130 pounds of sugar each year. That's around 60 kilograms. And down under, even the kangaroos are getting a bit of a waistline. But we're only spending 1.34% of the annual health budget on prevention. In fact, when you look at what's happening with chronic disease, and of course the lifestyle diseases contribute significantly to chronic disease, the blue line at the top is the United States. Greece and Australia are somewhere in the middle. There's no doubt that things are rising drastically very quickly. It seems unsustainable, but the biggest worry is it actually seems unstoppable. So in general practice, as the GPs know here, we deal with all systems. With the burgeoning of the chronic diseases, we're getting more and more chronic disease coming in across a number of systems. You know, a day in general practice is not uncommonly getting more and more complex. In fact, I don't know about you guys, but not uncommonly, this is what I feel like at work. I feel like I'm pushing up the big boulder every day. And it's really hard, not uncommonly, to manage what's going on. Perhaps doctors have turned into the modern Sisyphus, where we're constantly pushing up against something that maybe alone we are not actually strong enough to handle. the thought came to me that maybe the world, the modern world in particular, has been caught up in a lifestyle labyrinth, and we don't know how to get out with a lifestyle monster here in Greek mythology as the Minotaur in the middle. Well, maybe a clue about what to do about this might come from Greek mythology. As you know, Theseus was given the task of finding the Minotaur, disposing of him. But he had one big challenge at the end of that. This was such a maze, apparently, of tunnels, etc., that the Minotaur could never find his way out in the first place. So the challenge for him was going to be, how was he going to get out afterwards, Theseus? So what he did is he brought with him a big ball of something woven, just like thread. That's what it was, thread. And once he did what he had to do, he traced his way back. He traced his way back. Enter lifestyle medicine. In the last 20 years, there's been about 20 to 25 societies of lifestyle medicine that have started up around the world, including in Europe. They all argue that we need an evolution of how we're dealing with the lifestyle diseases. In 2019, the first article regarding lifestyle medicine appeared in the Royal Australian College of General Practitioners. It argued that we needed more in terms of an understanding of the science, the art of how to deal with these patients in general practice, for example, or elsewhere. We needed more tools and we need more action. So lifestyle medicine bridges the gap between public health and what's happening in terms of what clinicians are doing. And the biggest deal here is that it can't just be the clinician, any of us, pushing up against the boulder all the time. This has got to be a whole of society approach that starts with the educators at a young age. For example, it involves the scientists all being on the same page. The lifestyle medicine literature says government has to be very involved. If you want to change habits and you want to change lifestyle, you cannot just leave it to individuals. And we know that in Australia with the incredible results that we've had with smoking cessation. It needs everyone working on it together. So lifestyle medicine is finding its way into undergraduate education. In this instance, not only for the benefit of patients, but the poor doctors who, I think Spiros said, you know, people are burnt out, they're overworked. And that's happening in general practice too. And, you know, I think we're all pretty good on the exams saying, oh, the first thing you do, non-pharmacological. But in practice, it's not happening enough. And in fact, here's an article from JAMA Psychiatry that recently reported on RCT where they found that mindfulness was as effective as escitalopram in the treatment of this particular cohort of anxiety disorders. So lifestyle medicine is at a postgraduate level or even as a continuing medical education level, it's being taken up pretty much all around the world. And one example is Harvard, who have started up their Lifestyle Medicine Institute some years ago. I had a look at their once-a-year course that happens, and if you want evidence-based medicine coming out of your ears in this field, that's one of the places to go. We are doing stuff in Australia too from the various universities. So the lifestyle medicine doctors are saying to us, you want to get good marks on the lifestyle exam? You've got to do well on 6 sections, not just 1 or 2. Firstly, the idea of, and that we have been underachieving, the idea of healthful eating of particularly plant-based foods. I'm going to keep it simple. Do what Yaya said. That's simple. What she was cooking was the way to go. And when we talk about the Mediterranean-style eating pattern, we're not talking about what happens in Athens today at Goodies or wherever. We're talking about what people were eating in the 50s and 60s. It was hospital, it was vegetables, it was fruits, it was whole grains, etc., etc. And the research clearly shows 10-year extension in healthy life years by undertaking an especially plant-based diet. We've got to do better with physical activity. We'll talk about that soon. Relationships. I think, you know, Greece and the Mediterranean, you know, they value their relationships. They do that incredibly well, and we can learn a lot from them there. Sleep, you know, this is getting hard, you know, with technology and so on, but we really do need good quality sleep, and probably about 8 hours a night. And then also, of course, the smoking and other substances have got to go. So this is the Mediterranean style eating pattern in one pyramid, and also the lifestyle. So it's very top heavy in plant-based food. It's mixed with ongoing physical activity, enjoying meals with others, etc., etc. So when you look at the literature, there's no question there is now level 1 or level 2 evidence which supports the role of the Mediterranean style eating pattern in primary, secondary prevention with obesity, with the cardiometabolic diseases, with cancer, probably with cognition. There's a few sort of more recent studies that are maybe casting a little bit of doubt on that, but potentially in so many areas. And there's been a lot more research than I really knew in this field. And it makes you wonder, if this is so precious, maybe, we should do something to keep it for the future. And UNESCO has now actually put the Mediterranean style eating pattern on its list of intangible cultural heritage for humanities. So of course, Mediterranean style eating pattern has the support of the cardiometabolic associations, at least as a recommended approach, with a level of evidence B supporting its ability to improve glycemic control, cardiovascular risk factors. Okay, I'm not going to say much more about food because we have a world expert amongst us. Professor Catherine Itsiopoulos unfortunately couldn't be here today, but she has submitted something in relation to the Mediterranean style eating pattern on the virtual platform of this conference. I do want to talk about the idea of food versus other lifestyle factors, and there's no question that strong community ties, outdoor activities, relaxed life rhythm, tradition, religion, and this thing called conviviality, enjoying yourself when you're eating with others, also tremendously important. Physical activity, I think everyone's aware about the 150 minutes a week. I do want to actually emphasise that muscle strengthening activity, which builds the metabolic motor, in other words, our skeletal muscle, is very important, not only for cardiometabolic benefits, but it's been shown to have superior effects to aerobic activity when added to cognition, sleep, bone, joint and muscle health. And a diagram that blew my mind when I first saw it is, that the dotted line is what we call the frailty threshold. That's the point at which each of us, maybe, hopefully not one day, gets to the point where you lose your independence and you're dependent on other people. As you can see, a sedentary person gets to that at average age 80. Someone who is trained, including when the targeted prevention in terms of exercise happens at the age of 50-ish, is going to push that out to 90 plus and therefore give them more healthy life years. Similarly, the difference between trained, active and sedentary. How about this? A trained, and admittedly this is to elite level, 80-year-old is comparable to a 50-something-year-old in terms of functional capacity and VO2 max or muscle strength. So just to make the point that aging and frailty is not just a genetic process, it is modifiable by physical activity and exercise. And it is said that if you could put the benefits of physical activity and exercise into a pill, it would probably be the most widely prescribed pill in the world. I've learned in getting this presentation, for example, that even undertaking physical activity reduces your risk of glaucoma, reduces your risk of infection, and of course there are those cognitive benefits, cardiometabolic benefits, no question about it. I put this slide in just to show that in the past people didn't really need to exercise, it was part of their everyday routine. But what impressed me about this slide, it's not just about gathering olives. Look at how they're interacting. They are building relationships, they've got those close-knit communities, very, very important. And as you can see, smoking and inactivity, significant risk factors for cardiovascular disease, but look at the effect of isolation and loneliness, just as big a risk factor, absolutely incredible. All right, we're getting to the end. Okay, so we hit this thing called a pandemic lately. It flattened the healthcare system. Even lifestyle's important there. Obesity being the single biggest modifiable risk factor in hospitalisations. Building immunity, it can even, when you're physically active, improve your response to vaccines. Blue zones, I want you to know that the twin studies show that 75% of longevity across the world is due to lifestyle and not just due to genes. And if you've ever wondered why in Ikaria, which is a blue zone in Greece, they are doing better, we're actually still not sure, but it's got a lot to do with the consumption of legumes, which happens at all the 5 blue zones across the world, have that in common together with close-knit community, and something that I'm not doing at the moment, and that is I don't have a sense of time urgency. So this is the summary. This is, if you want to get good marks on the exam, this is what you've got to do. We've pretty much talked about that so far, and just to wrap up, so quite simply, perhaps sometimes we need to go back in order to go forward. There are things we can learn from the Mediterranean lifestyle and the Blue Zones lifestyles. There are opportunities for leadership here. And just to point out too, that sustainability is also very important. And the Mediterranean lifestyle and the Blue Zones lifestyles tick the boxes in all of those areas. Bana pola igia. Thanks very much.
George, thank you very much, and hopefully we can rise to this challenge of making Melbourne a blue zone, maybe at some point. Moving on to the next talk, Prenatal Health, Epigenetics and Fetal Alcohol Spectrum Disorder by Associate Professor Magda Simonis. So Magda is a GP, Clinical Associate Professor in the Department of General Practice at the University of Melbourne, a Government Health Advisor, Board Director of the Melbourne Teaching Health Clinics for the University of Melbourne Faculty of Medicine, Dentistry and Health Sciences. She's a leading women's health expert, climate change and gender equity advocate, and holds positions on several not-for-profit organisations, bridging gaps across the healthcare sector, whilst informing their health initiatives. She's on the Expert Committee of Quality Care for the Royal Australian College of General Practice, President of the Australian Federation of Medical Women, Medical Women's International Association Scientific and Research Subcommittee Co-Chair, and Chair of the MWA Mentoring Group. Magdalena is the RACGP representative to the government-funded Your Fertility and the Victorian Associated Reproductive Transition Authority, and has been closely working with HMSA now over this last 6 months or so. So if you can please make Magda welcome.
Well, thank you, everybody, and thank you, Ben, and thank you, George, for a fabulous presentation. And I would love to hear that slowly. It was just, I was so enjoying it, and there was just so much in there. Now, I come to you today from the not-for-profit spectrum that I'm involved in, and I'd like to. And so this is some of the not-for-profit work that I've been involved with for a very long time. As you'll see, Your Fertility and the Victorian Assisted Reproductive Treatment Authority, I've been working with them very closely for probably close to a decade now as the RACGP rep, and have helped redesign their website and have provided a lot of their consumer-facing products and messages, and also have developed a lot of guidelines and tools for the health profession, primarily for primary care, general practice and nurse practitioners. Now, what I'm talking to you about today is really an extension of what George has been talking about, and also what Spiros Foulanos has touched on about, you know, Spiros mentioned that he felt like he was a fireman, and George, Maria and I and other general practitioners, what our role really is in preventing fires. We prevent fires because we work in primary care, and primary care is where we translate the excellent science that you all and we all undertake in our specialties and in our professional lives, and we translate it into healthcare messages and messages that our patients can digest and understand and take action upon. Now, this is a concerted effort. We do it repeatedly over time. One of the beauties of being a general practitioner, which is why we love what we do, is that we do cradle-to-grave medicine. So now I'm going to take this conversation before the cradle. And that is why lifestyle medicine, what George has been talking about, is really pertinent to the health of any community. And I hope that it'll eventually be witnessed in outcomes that Spiros can report on favourably. So Your Fertility is a government, it's federally funded, it's a not-for-profit organisation, consumer-facing organisation, and they provide, very few people know it exists, but it provides excellent information on how to improve your chance of pregnancy and having a healthy baby. Now, having a healthy baby starts before you actually decide to have one. And there are a few really interesting things about this, in that 50% of pregnancies in Australia are unplanned. So we do need to reach our audience effectively, and that takes more than a general practitioner. That takes community effort, that takes advocacy policy. This is me planting the seed, taking the opportunity with any consultation that we have where it's appropriate. You know, by the way, you know, thinking of having a baby in the next couple of years, if so, that's an opportunity to talk to them about lifestyle. That's an opportunity to talk to them about men and women. So it's not just a women's conversation here. So I'm also heavily involved with Healthy Male. It used to be Andrology Australia, and they appoint me every year to give a presentation during Men's Health Week. And September is also Fertility Week for your fertility. So I do both and enjoy really threading those messages effectively, hopefully for the community. And we do this fabulous sort of thing online with Reddit with the men who call in with all their healthcare problems. It's fabulous, you know, people from all around the country just calling in saying, you know, I'm on my way to work and I'm sort of worried about this, and, you know, and they can ask questions, and plugging fertility and how to have healthy sperm and how to change your lifestyle and your diet to improve that is really a key part of that. So I'm not going to go into the details because everything that George talked about is really mentioned here. It's really about your diet, weight, exercise, eating a balanced diet, smoking, prevention of smoking, not drinking alcohol, most important. And I'm going to focus specifically on alcohol, and we've done excellent work getting people off cigarettes in Australia, but not so well with the alcohol front, and certainly not in preconception. So the checklist for women is pretty much the same as it is for men. So we give the same message, and I'm going to sort of race through this. So it's really about eating well. You can improve your chances of having a healthy pregnancy and a healthier baby. We encourage men and women to have all the healthy foods in the Mediterranean diet and to omit alcohol. Exercise more. We know that, you know, anovulation can be stimulated in obese women by the loss of 3 to 5 kilos. And it also will help with reducing the chance of gestational diabetes during pregnancy and pregnancy-induced hypertension. Limit alcohol intake. No amount is safe at any stage of breastfeeding or pregnancy, and that message needs to get through. So this sort of thing of a little bit is okay, not too much is not okay, that needs to be corrected, because I think that that's what we've been taught originally, and that's probably what we fundamentally want to believe, but the studies are showing otherwise. Quit smoking. Take the correct supplements. We know about iodine, we know about the minimum dose of folic acid, minimum 400 micrograms, but, you know, in products that we prescribe or recommend, it's anything up to 800 micrograms, and they should be started at least a month before conception. Does it help with males? The jury's out on that. So the answer to that is actually no. And vaccinations, of course. So I've been heavily involved in, you know, promoting vaccination during COVID and pregnancy. So now we have influenza, COVID vaccination, pertussis vaccinations. So, alcohol. Alcohol is really the key issue that I want to talk to you about today. Simply because fetal alcohol spectrum disorder is a diagnostic term. It's used to describe the impacts on the brain and body of individuals prenatally exposed to alcohol. It's a lifelong disability. You might not diagnose it until years into a child's life with failure to learn, behavioural disorders in adolescence, and problems with motor skills. So there are sort of severe forms of it and less severe forms of it. Issues with memory, attention, communication, emotional regulation, social skills to reach their full potential. And the problem with fetal alcohol spectrum disorder is that women who drink during pregnancy aren't really informed about this. They often don't even know that this exists. They might think that it might be associated with just having smaller babies, but they don't necessarily know about the long-term consequences of this. And men are a really important part of this where there's a male and female in the relationship, but in any relationship where they're partnering and having children, the partner of the pregnant person should really also modify their behaviour to assist them. So, fetal alcohol spectrum disorder. How and why does this happen? Because alcohol crosses the placenta, it's toxic, it causes fetal-related, alcohol-related birth disorders, neurodevelopmental disorder, and the incidence varies depending on the nation and the drinking habits. In Australia, it's also not very well measured because it is a multi-system disorder. It sometimes doesn't present as obviously at the time of birth, and it can present later on with school and learning difficulties. So in our Indigenous population, we expect that it's somewhere around 12%. In USA, somewhere around 2 to 5%. Italy, around 5%, and in some South African countries, as high as 23%. So it's really quite a big and significant social issue. So it's associated with serious learning difficulties, intellectual disability, poor eyesight and motor skills, defects of the face and bones in the baby, heart, liver, kidney defects, slow physical growth after birth, and behavioural problems. And for those of us who've practiced in obstetrics, this will be familiar. This is familiar to us. We have seen this when I was doing my Diploma of Obstetrics and Gynae at Preston Northcote Community Hospital, where a lot of very young women were having unplanned pregnancies, drinking Coca-Cola in one hand and beer and wine in the other, and having unaware, and it's a social issue. These babies with microcephaly, flat nasal bridge, epicanthal folds, ear anomalies, micrognathia, thin upper lip, and they are typical features of a newborn who's been exposed to alcohol. So in Australia, we have a few government-funded organisations, and we have the National Fetal Alcohol Spectrum Disorder website here, which is about, it's consumer facing, it's about helping people understand the risks, but you can't really point people to this unless you have the conversation. So there is a heck of a lot of research that's been undertaken here on behaviour modification and the effects of alcohol on pregnancy, and the concern, of course, during COVID was that statistics suggested that young women, especially facing living alone or experiencing some financial uncertainty and social isolation, were drinking more than before the pandemic, and more so than men. So, the 22.8% of young women in that age group were drinking more than men in that age group, and that they reported high levels of stress. And there was also a significant shortage in contraceptives during the COVID pandemic, and some of the most commonly prescribed oral contraceptives were inaccessible. So they were so often having unprotected sex. So we may well see the outcome and the result of this down the track. And there was a randomised control report on systemic reviews for the association between different levels of and patterns of maternal alcohol consumption during pregnancy whilst breastfeeding, with selected health outcomes for fetuses and children up to the age of 5. And this was prepared by Cochrane and the South Australian Health and Medical Research Institute, and it was published in 2018. Which tells us that there is no safe time, no safe amount, and no safe type of alcohol. Alcohol can harm throughout the pregnancy, that is. Alcohol can harm a developing fetus at any point during a pregnancy, even before pregnancy is confirmed. 50% of women experience an unplanned pregnancy, and many are prenatally exposed to alcohol before the family becomes aware of the pregnancy. And if you're planning a pregnancy, advise that abstinence from alcohol is safest. And if you drink alcohol, use effective contraception to prevent unintentional prenatal exposure to alcohol. And alcohol use during pregnancy can increase the risk of miscarriage, stillbirth, preterm birth, SIDS, which is sudden infant death syndrome, and can also result in fetal alcohol spectrum disorder. So it's a spectrum, which is a lifelong disability, no turning back from that. So we talk about epigenetics, and probably a lot of what George was talking about there about the healthy lifestyle and the pillars of healthy lifestyle. Yes, we can change our telomeres, we can change our genes, we can change our genetic structure by exposing them to environmental insults and toxins. And so there is a significant area that's being researched even more so now, and it's the area of epigenetics. And it's genes change in response to the environment. These are called epigenetic effects, and these can be passed from one generation to another generation during reproduction. And so parental exposure to a number of lifestyle and environmental factors in the months leading to conception also play a role through transgenerational epigenetic effects, which can affect the programming of the embryo and fetus and ultimately the lifetime health of the child. And we suspect that some diabetes can be inherited in that way. So the health of mothers and fathers-to-be sets the trajectory for a lifetime of health for the baby. More and more pressure on mums, but we're trying to inform dads that also there's a responsibility there too. And it may well affect the chances of their child developing chronic illnesses later in life. So genes are sensitive to the environment, such as smoking, obesity, environmental toxins. They're all culprits of epigenetic changes that adversely affect the health of the offspring. So make the safe choice. Alcohol labelling on beverages. So this is very interesting because, of course, we talk about public policy and what George was saying, you know, pushing that big rock up the hill. Yes, I very much feel like that a lot of the time, which is why I do a lot of the policy work that I do and why I sort of step out of the consultation room and do all of that. So the labelling on bottles started, that whole movement to change that was in 2006. And it took nearly 20 years to effectively get the labels on wine bottles and alcoholic beverages. However, it doesn't seem to be having that much effect, much like the labelling on cigarettes. So we need stronger messages, and these are some of the resources that exist. And thank you very much for your time.
Okay, thank you, Magda. And your talk and George's talk are excellent segues into the final two presentations before lunch. Hopefully everyone's still holding up. So the next talk is Understanding Brain Changes in Early Psychosis and Schizophrenia by Professor Chris Pantelis. So Christos Pantelis is Foundation Professor of Neuropsychiatry and Scientific Director of Melbourne Neuropsychiatry Centre at the University of Melbourne. He's affiliated with the Florey Institute and has been a visiting professor at Harvard University, Cambridge University and the University of Copenhagen. He is Senior Consultant at the Adult Mental Health Rehabilitation Unit at Sunshine Hospital in Melbourne, where he treats patients with severe forms of schizophrenia. So he's a world-renowned expert in schizophrenia and psychosis in general and neurodevelopmental disorders. He's published over 700 scientific papers and 3 books, has been a highly cited scientist in the top 1% of his field, in fact, each year since 2014. In a world first, he described dynamic brain changes at psychosis onset. His work explores the basis of brain changes in psychosis and schizophrenia, including the role of early risk factors, genetics, stress, neuroinflammation, and how metals in the brain may be relevant. His work on brain development has led to studies of children with schizotypal disorder compared with autism. His recent studies of a neurodevelopmental mouse model aim to identify possible new treatments for these disorders. And other recent work examined neurological, neuropsychiatric and intergenerational impacts of COVID-19. So thank you, Chris, for your talk.
Thank you very much, and thanks to Marinis and the organisers for the invitation to come and speak today. I'm going to give you a bit of a whirlwind tour of the work that we've been undertaking, looking at patients with early psychosis and with schizophrenia. I'm going to show you some of the changes that we've identified, but I'm also going to focus on the people, because the people that we've worked with over the years have been key, and the collaborations that we've been establishing across Australia and also internationally have been so important in terms of the work that we've been undertaking, in terms of pushing this complicated field forward. So just to mention the centre, the Melbourne Neuropsychiatry Centre, we established that in 2004, but Dennis Velikoulis and I, we co-direct the centre. We started working together in 1994 when Dennis joined as a doctoral student. He now heads the neuropsychiatry unit at the Royal Melbourne Hospital, a premier neuropsychiatry site internationally. Our work is very much translational, not just bench to bedside, but importantly, bedside to bench. Many of the observations that we have made that have led to the, some of the breakthrough studies that we reported derive from those observations at the bedside, at the clinic, and I work clinically at Sunshine, as you heard, and working with some of the most severely affected with the disorder. Our centre has become well known with regard to neuroimaging work, and I must say I'm one of the culprits in terms of developing some of the artificial intelligence and other techniques that we heard about earlier on, and I think they will prove useful in understanding disorders like schizophrenia. Certainly working across the various fields, though, not just imaging, we work across neuropathology, neurochemistry. We've been working most recently with Arthur Christopoulos to develop both a preclinical model looking towards developing novel treatments, and that's a very exciting initiative that I'll touch on very briefly. So schizophrenia, it's a disorder that is characterized by hearing voices, experiencing delusional ideas, sometimes quite bizarre, a characteristic disorder of thinking, and as well as that, negative symptoms of amotivation, apathy, withdrawal, blunting of affect, as well as cognitive deficits. So there's a range of features that manifest in these disorders. And importantly, it affects young people. It affects young people at the prime of life, in late adolescence, early adulthood. And that, I think, speaks to the impact of the disorder and how devastating it can be, not only for the individual, but also for families. And out at Sunshine, I do a lot of family work, because the amount of trauma that you see in those families is huge. We know certain things about the disorder. It occurs across the socioeconomic spectrum, across cultures, very similar manifestations. It has a high genetic component. The heritability is 80%. Having said that, it's proved difficult to discern exactly what that heredity is about, and I'll touch on that briefly. So it's a polygenic disorder, it would seem, and in some of the work that we've undertaken, it's also a polypathway disorder. We've done a genetic analysis of biological pathways in the brain, and it seems to affect multiple pathways, which presents a challenge when we're thinking about how we treat this disorder. Certainly, it responds to dopaminergic drugs, but that's not the full story, and currently we're exploring how we can take that further. Just some figures with regard to prevalence, and we've become interested in children who develop schizophrenia, or children that manifest features that might lead to the later development of the disorder, such as schizotypy. And those children have very rich fantasy worlds, if you like. I'll touch on that very briefly, but it's an area that we're looking at in a concerted manner, and looking at brain networks relevant to that. So the fact that it occurs in young people, the fact that the notions about schizophrenia are that it's a neurodevelopmental disorder, means that we need to look at neurodevelopment, and we need to place the findings in schizophrenia in that context. Recently, we did some work with the University of Copenhagen using their case registers and their twin registers, and we looked at all the risk factors relevant to that have been proposed in the literature. As you know, Copenhagen databases have huge amounts of data, so it was a fabulous opportunity. We looked at all suggested risk factors, but 3 came up as particularly significant. A polygenic risk score for schizophrenia with an odds ratio of about 1.6, so not huge, but the 2 other risk factors were very large. Childhood trauma had a risk factor of 4.5, so 4.5-fold increase in the risk if you had suffered childhood trauma. The other one was cannabis use with an 8-fold increase. We see regularly that cannabis precipitates the illness in those who are susceptible to the disorder. So this also means that these risk factors are across development. They're not occurring just in childhood, not just prenatally, but also during critical stages of development. And cannabis use in adolescence is a key problem and driver of the illness. So in terms of normal development, looking at normal development becomes quite important. This is work by Nitin Gogte and Judy Rappaport from NIMH in the US, and we've done some collaborative studies with them. Here they're looking at normal brain development, looking at how the brain is changing from age 4 to age 21. There's a gradual loss of grey matter from the back of the brain moving forward and downward and culminating in association cortices such as the prefrontal cortex and the superior temporal gyrus. And that parallels the synaptic pruning that is occurring during adolescence. You get a massive proliferation of synaptic connections during childhood, and then later you see synaptic pruning. Synaptic pruning is the dominant notion that we have with regard to what is driving the brain changes in the disorder, that there is, in effect, excessive pruning of synapses, particularly in regions such as the frontal lobe. So this provides an interesting hypothesis to examine and to test in more detail. And in a recent study that we contributed to as well, published in Nature, this is a study taking scanning studies from across the globe and across development, from prenatal through to age 100, I think. And it's looking at the way the grey matter and white matter are changing over the developmental period. And what you see is that grey matter increases, and then there's a decrease during late adolescence, early adulthood, akin to what the Nitin Gogte, etc., found. And white matter seems to continue to develop into the 30s and beyond. So there's a progressive change in the way that the brain is changing. And when we look at what's happening in schizophrenia, we need to take account of these findings. So what's happening in schizophrenia? Certainly the frontal and temporal lobes are key. And these are the regions that are maturing most during adolescence and early adulthood. And it seems that the onset of the disorder impacts the developmental trajectory of those brain regions. I was fortunate to, I was working in London and published a paper which got me a fellowship to go and visit and work with Dan Weinberger in the early 90s. He was the key figure in schizophrenia research and had generated the neurodevelopmental hypothesis of schizophrenia, suggesting that, and he suggested that there was a lesion that was induced during the second trimester during development that subsequently led to schizophrenia. It drove research over the subsequent 20 years. And when I arrived, he showed me these scans of twins discordant for schizophrenia. It was a study they'd recently published in the New England Journal of Medicine, and you could visually identify which twin had schizophrenia based on 2 indices: smaller hippocampus and larger ventricles. So for us, that proved an interesting way to go, to look at potential markers that might be relevant to impending schizophrenia. And we were fortunate to be working closely with Pat McGorry and Alison Yu at the time when they were developing their ultra-high risk strategy for identifying young people who subsequently developed psychotic illnesses. And when you look at the data, at the time we undertook our imaging studies in these cohorts, almost 40 to 50% were making a transition to psychosis. So we were able to scan them before they became ill, and then we were able to scan them again after illness onset. The first study we did, though, was done by Dennis Velakoulis. We had collected data on almost 500 subjects across stages of the illness. We were looking at hippocampus and ventricles, and what Dennis did was to trace the hippocampi on all those individuals. Indeed, he did it twice, blinded diagnosis, in order to determine whether our data was correct, because the findings were counterintuitive. What we found was that in the pre-psychotic group, the hippocampi were not smaller. What this study led to was a longitudinal study. And it led to a paper in the Lancet. It took 2 years to get this published. It was going backwards and forwards from the reviewers. Finally, we were able to show that the brain was changing dynamically in schizophrenia and early psychosis, affecting frontal lobes and temporal lobe regions, as well as the cingulate. This was the first demonstration worldwide of dynamic brain changes as people were developing the illness for the first time. And it led to rethinking what we understood about schizophrenia. From a position of doomed from the womb, we moved to a position of therapeutic optimism. If we could make a difference to these changes, perhaps we can also develop novel treatments. It got us thinking about trajectories. We started to map, and I realise that we've got limited time, so I'll go fairly quickly through some of these slides. We mapped changes over the first 4 to 5 years of the illness and showed the frontal shrinkage, which is a normal process, was accelerated twofold in schizophrenia, consistent with the synaptic pruning or accelerated synaptic pruning hypothesis. We looked at childhood schizophrenia, and one of the things we identified here, we looked at connectivity. The y-axis is a connectivity metric. The children with schizophrenia are in red, normal, typically developing children in blue, and it's the one in the middle that's interesting. They showed abnormality. They were the siblings of those with childhood schizophrenia. They showed abnormalities at age 12, but normalized by the age of 16. So there may be resilience factors acting. We subsequently looked at hippocampus and memory, following on from Dennis's study. We looked at subfields of the hippocampus with relevance to particular neurobiological areas of interest to pursue. And then subsequently, we wanted to explore what affected these trajectories, the impact of drugs, stress, inflammation. I'll very quickly show you some of the data. This is the genetic analysis in schizophrenia showing, published in Nature. Again, we contributed to this study. Over 108 loci here, and there's a more recent paper showing over 200. So it's affecting across the genome, and probably in any one individual, genes can be affected differently, making it very difficult to try and work out what is happening in the disorder. But the immune signal is important. The dopamine receptor genes came up, as well as glutamate, and we're now looking at the interaction of glutamate and childhood trauma leading to the brain changes. Liliana Laskaris, and I will focus a little bit on some of our Greek colleagues who undertook work with us, did a PhD with us, did some nice work on the immune system in schizophrenia, looking at complement system here that the Boston group have been exploring in terms of the synaptic pruning hypothesis, and we demonstrate changes in the complement system. We looked at stress, looking at the size of the pituitary, and larger pituitary was predictive of those who would go on to develop psychosis from a high-risk state. This was a world first where we looked at the impact of cannabis in those that were long-term cannabis users. And what we found was that the hippocampus and amygdala were smaller, and that the connections from the hippocampus were also significantly impacted, very specifically. And then more recently, we've been looking at ubiquitin system, the process in the brain that removes debris from cells. We examined the whole machinery of the ubiquitin system and showed that the ubiquitinated proteins were elevated, and this got us thinking about oxidative stress in the disorder. So we've looked recently and found that iron levels are elevated. We've been doing some imaging studies looking at iron as well, a paper just published in Translational Psychiatry and Nature Journal. And then finally, we've moved from there to animal work. We're working with Arthur Christopoulos. We obtained a $10 million NHMRC grant, and I've been involved in developing an imaging brain lab across brain maturation in the mouse. So not many studies have looked at neurodevelopment across in rodent models. So that's quite exciting. We now have an MIA model that we've been exploring and looking at cognition. And the task for us is to identify treatments that can reverse the cognitive deficits that we induce. I just want to touch on two studies. This one, a pathway analysis we did in autism. I did this with Stan Skafidis, another Greek professor of nanoelectronics at Melbourne University. He's the inventor of Bluetooth technology. Seriously talented guy who approached me and said, I want to look at the genetics of ASD. We spent the next 5 years working every Friday on this paper that was originally in submission and under revision for 2 years with New England Journal, but the geneticists, I think, were not happy with young upstarts coming into their field. But we published it in a Nature Journal, Molecular Psychiatry, and it led to a great deal of publicity nationwide. The childhood schizotypy study is beginning. We're looking at brain networks in kids with schizotypy. And then finally, just to show you some of the collaborations, we have an important one, a recent collaboration between Athens University, Copenhagen, and Munich with Nikos Koutouleris, where we had used machine learning to see if we could predict remission. And this was a study that Riga Soldatos from Athens, he came to our group. Dennis and I have established a Melbourne-Athens Neuropsychiatry Fellowship, and he's one of the recipients of that. We're hoping that this fellowship will continue. We certainly need more funding for it, but it's been fabulous, and you can see Rigas there enjoying some of the local talent. And then, of course, it's not moving forward. I was going to show you a picture of Greece. Finished. Yep. That one, I think. Yep. We were in Athens and Spetses, and COVID has interrupted all our plans to go back to Greece. But hopefully we will see many of you in Greece, which, of course, is always fabulous. Thank you.
Thank you, Chris, for that incredible, but unfortunately very rushed journey through just a fraction of your research. And you know, I really love the term therapeutic optimism. I think that's a really good take-home message about mental health and mental illness in general. The final talk before lunch is an update on ultra-brief ECT, electroconvulsive therapy in psychiatry of old age, and that's to be presented by Dr. Chris Plakiotis. Chris is a consultant psychiatrist in adult and old age psychiatry. He obtained his medical degree from Monash University, where he also completed his basic psychiatry training, as well as his advanced training in adult psychiatry and psychiatry of old age. Complementing his professional training, he has undertaken extensive postgraduate study in psychological medicine, clinical research, health professional education and medical leadership. He's been awarded a Doctor of Medicine degree for his thesis titled Electroconvulsive Therapy Research in Psychiatry of Old Age. He's a fellow of both the Royal Australian and New Zealand College of Psychiatrists, as well as an Associate Fellow of the Royal Australasian College of Medical Administrators. He works closely with a number of private entities as well, and I'll let him present his talk. Thank you.
Thank you for the introduction, Arthur. Thank you, Marini, for the invitation to speak here today, and thank you to all our Greek guests for making the long trip down under. I work predominantly as an old age psychiatrist in the public sector, and I guess the question is, why get an old age psychiatrist to talk to you about ECT? The simple answer is we use quite a lot of it in old age psychiatry for treatment resistant depression because it works. However, it also places a great responsibility on us to know how to administer it well, because as you can imagine, our patients are a particularly vulnerable group to the cognitive side effects of ECT. So we need to think carefully about how to administer it so as to maximise its benefits, its clinical benefits, while minimising cognitive side effects. Before I launch into this, I can use that. So ultra-brief ECT is a new form of ECT, which I'll explain what it means in a moment, but until maybe about 2015, here in Victoria, the Office of the Chief Psychiatrist really discouraged its use because they said, well, there's not enough evidence to support it. It may not be quite as effective as conventional ECT. The appeal of it is it may cause less cognitive side effects, but they wouldn't let us use it very much. In more recent years, there's been a bit of a backflip, and the question now is, well, why aren't you using it as a first-line treatment in all your patients? So, you know, we've had to do a bit of a backflip as well in our clinical practice. This can become rather technical, so I'm going to try to whiz through a few concepts very quickly so the rest of the talk makes sense. So ECT basically involves giving a patient an anaesthetic, a muscle relaxant, and while they're asleep we apply electrodes to the scalp and administer a therapeutic electrical stimulus, and we do that 2 or 3 times a week for 8 to 12 acute treatment sessions, and we can also administer continuation and maintenance ECT for people who tend to relapse easily. That slide shows the 3 main electrode placements that we use with conventional pulse width ECT, so bilateral or bitemporal, right unilateral, which is thought to be more sparing of cognition because it avoids direct stimulation over the left temporal lobe. There's also the option of bifrontal stimulation, which also avoids stimulating over the temporal lobes. Very quickly in terms of waveform and pulse width, so what you see at the top is a sine wave. That is obsolete. I first started practicing as a very junior doctor in psychiatry in the late 1990s, and sine wave ECT machines were obsolete because the sine wave is not good at all on cognition. So what we had moved to by that stage was what you see in the second diagram, which is a square-shaped bidirectional pulse, and that's a lot better in terms of cognition. This just illustrates basically the same point. It just shows that down the bottom it's pretty obvious with a sine wave, you know, for example, how you calculate the frequency. It's basically number of cycles per second. It's the same idea with the square-shaped pulses as well. This kind of tries to superimpose what a brief pulse width and an ultra brief pulse width look like. But basically with conventional treatment, we've been using a brief pulse width of 0.5 to 1.5 milliseconds, whereas with ultra brief ECT, we're using a pulse width that is 0.3 milliseconds or less. Essentially, it's 0.3 in most clinical applications. The reason I've included this slide, in case you're getting worried about the complexity of all of this, is, yes, you can get really, really preoccupied with the physics that goes on in the background, but you actually don't need to know these particular details to be a competent ECT practitioner, because the key thing you would really do is, decide what particular dose or charge you want to administer to any particular patient, select the pulse width, and there are programs inbuilt into the ECT machines which will adjust for all the rest. If you're doing ECT research, you might want to individually set parameters. I'm also going to very quickly explain dosing of ECT is rather complicated. It's not just, this is the dose I want to administer, I'm going to do it. You need to begin by determining what is called seizure threshold, which is the smallest sort of electrical dose that's required to elicit a grand mal seizure. And once you've done that, you need to dose ECT at a suprathreshold level for it to be efficacious. So for bitemporal and bifrontal, it's not that important. We normally dose 1.5 times threshold, but it would probably work even if you dosed it at threshold. It's more important with right unilateral ECT, where you definitely have to dose 3 to 6 times threshold. And we follow a process called dose titration in the first 1 or 2 treatment sessions, whereby we administer incrementally greater doses till we find threshold, and then we go over. So why an ultra-brief pulse width? Well, I said earlier that, brief pulse ECT, 0.5 to 1.5 milliseconds, was certainly advantageous from a cognitive side effect perspective relative to sine wave ECT. But there's evidence from neurophysiological studies that using even smaller pulse widths is better, because smaller pulse widths are actually more efficient at eliciting seizures. They cause less excitotoxicity during the refractory phase. There's also computer modelling which suggests that the briefer pulse widths stimulate a narrower band of tissue, and thus the hippocampus and temporal regions are relatively spared during the seizure. And this is thought to reduce the likelihood of cognitive side effects. In practice, as I said, we tend to use a 0.3 millisecond pulse in clinical practice. And the other thing I should emphasise, and this is paradoxical, with a conventional pulse, bitemporal ECT is actually the most clinically effective. But we don't find that with ultra-brief ECT. There was actually a prominent study done by Sackheim's group in New York in 2008, where using an ultra-brief pulse width in combination with a bitemporal electrode placement reduced its efficacy. So that's the background. Now I'm going to take you quickly, essentially through 2 studies. The first is a systematic review and meta-analysis of brief pulse versus ultra-brief pulse right unilateral ECT, which was undertaken a few years ago by Colleen Liu's group at the University of New South Wales. Colleen is the preeminent ECT researcher here in Australia. I'm going to, I guess, a couple of things maybe to emphasise on this particular slide. So my talk is titled Ultra-Brief ECT in Psychiatry of Old Age. However, a lot of the evidence doesn't come from particularly old patients. So the average age of people in this meta-analysis was 50.7 years. The other point I'm going to emphasise is that in these pooled studies, the average number of acute treatments that were needed for patients to to respond was 8.7 for brief pulse, conventional brief pulse treatment, versus 9.6 for ultra brief. And this is an important issue because you tend to need more treatments with ultra brief ECT. Okay, so we'll move straight on to the forest plot. So this first one looks at efficacy of brief versus ultra brief right unilateral ECT at the end of an acute course for depression. And as you can see, does this work? No, it doesn't. As you can see from the diamond shape at the bottom, it's on the left of the line of no effect. So that actually favours brief pulse ECT. In other words, ultra brief ECT is not quite as effective as brief pulse treatment. This looks at remission rates for the same two conditions. And again, the diamond is on the left of the line of no effect. And that is actually indicative of ultra brief ECT having a lower remission rate than conventional pulse ECT, which is consistent with the first slide. So it doesn't mean that ultra brief doesn't work. It just suggests that it's not quite as effective as conventional treatment. Where ultra brief ECT does much better is in terms of cognitive side effects. So here they've got, pooled results for retrograde memory deficits, anterograde memory, so learning, delayed recall, as well as global cognitive function. And essentially for all those measures, ultra brief ECT comes ahead of conventional pulse ECT. So this is why it's used, because it's less likely to cause, post-ECT confusion and, short and long-term cognitive side effects. So Colleen Liu's group concluded that the current evidence supports the efficacy of right unilateral ultra-brief ECT in treating depression. Ultra-brief ECT may be slightly less effective than conventional ECT, but it requires more treatment sessions. However, the benefit is fewer cognitive side effects. And the decision of whether to use ultra-brief ECT or not needs to be made on an individual case-by-case basis. So, for example, if you had a patient who was not eating or drinking, or was at very serious risk of suicide, who might be attempting, suicide on your inpatient unit, you might make a decision to not treat them with ultra-brief ECT and go straight to a conventional placement. But it's a really hard call to make, because I've also, I have seen people with severe psychotic depression, who have responded to ultra-brief ECT. So it really depends, I guess, on a judgment about the level of immediate risk. How am I going for time? 2 minutes. Look, I'll whiz through the rest of the slides because I don't have a lot of time. A lot of this evidence was in young people. You have to extrapolate it to older people who tend to be a lot more unwell, tend to have a lot more, psychosis and melancholic symptoms. Kellner's group in New York did what they called a prolonging remission in the depressed elderly, or the PRIDE study. The first phase was an observational design, and basically from what you could see, going through very quickly from response and remission rates, the declining Hamilton score, the Hamilton depression rating scale over time, and from this graph here, which shows the speed of remission, it actually, in that sort of observational design, it does actually work. The same authors then went on to do a second phase where they randomised patients to either receive maintenance pharmacotherapy, either sort of a combination of venlafaxine and lithium, either pharmacotherapy alone or a combination of pharmacotherapy and some continuation ultra-brief ECT treatments. And the patients who were receiving the the combination treatment actually did better. So there is some evidence that it works in the elderly. And while they were doing this, they also did a whole battery of neuropsychological tests. And by and large, they found that people's neuropsychological function tended to improve, across the period that they were having the ECT, because being depressed itself will impair your cognitive performance. So in summary, given that we're running out of time, ultra-brief ECT is a legitimate treatment option, but one of the main problems that we're finding is that we're actually having to administer a lot more treatments. There's also a proportion who will not respond, who after you give them 6, 8 treatments, it becomes clear they're not responding, so you have to switch them to another conventional form of treatment. So this has led to the number of treatments that we're administering in recent years going through the roof, to the extent that at the Kingston Centre we've actually asked for a whole new ECT suite to be built, because we can't manage the number of people that are having to go through the ECT suite. But for people that do respond to it, they respond well, and it does tend to be more gentle on cognition, but that's not absolute either. So despite all the positive press that is given to this, I have also seen at least, well, more than one older person who have become quite, confused even with ultra-brief ECT. I'll finish at that point. Thank you very much. That's okay.
Ladies and gentlemen, thank you very much for your patience. It's been a very long session. We'll now break for lunch. May I please ask that we'll be back here at around about 2:30, so only a slightly short break. We are going to try and catch up a little bit if we can, because we do have a ball to get to tonight. So thank you for your patience. We'll see you again here at 2:30. Thank you.
Okay, yeah, no, I'll go for it.
Cool, no problem. All right, everyone. I think we might get started with the afternoon session now. If everyone can move to their places, please. So we might skip forward a couple of sessions and begin with current concepts in prostate cancer by Mr. Peter Liadakis. So Peter, who I've also had the pleasure of being your resident at Austin before. So Peter qualified as a urologist in 2009 after completing training in advanced laparoscopic and robotic techniques for benign and malignant urological conditions. He is a high-volume surgeon, having performed hundreds of laparoscopic and robotic procedures, as well as offering latest techniques for managing all urinary issues. He works at the Austin Hospital, Epworth Richmond, Warringal Private, and he also visits Mildura on a monthly basis and has private consulting suites in Heidelberg. He's committed to research with a full-time clinical fellow working with him and has presented at national and international conferences and has made regular contributions to published literature. You can make him welcome, please.
Hi everyone, thank you for coming along and thank you for the opportunity to speak. So I'll move through this at a fair pace because we'll just go through some prostate cancer in 15 minutes, cover everything there. So if you've got any questions, feel free to chat to me later on about it, but I'll go at a fair clip. So basically, we'll briefly talk about PSA testing, MRI, won't say that much about active surveillance today. I'll give you the gory video that every surgical presentation needs to have, and then talk about some of the newer focal therapies. So PSA testing is controversial. A lot of people don't understand it. There's a lot in the literature as to should it be done, should it not be done. I'm just going to briefly touch on a couple of the papers that looked at this and where all the controversy comes and where we're going. So there was a couple of key papers that were published in 2009. They were big studies, as you can see. One had 170,000 men, the other one had about 78,000 men. The one to the left, a PLCO trial, said that there was no benefit from PSA testing, so there was a general consensus we should not actively look for this. And then the ERSPC trial, which was going to disclose their results 18 months later, saw this. They had some preliminary results and they said, this can't be happening. We're actually going to disclose our information earlier to show what the differences are. And I'll show you what it showed here. That basically the PLCO trial, which was the big American trial, 44% of the patients in the control arm were already having PSAs anyway. So what you're meant to be comparing is patients having PSA testing to ones not having PSA testing, but 44% of the ones who were not going to be having PSA testing were actually having it. So you weren't controlling them, you weren't comparing them to a control arm. There was already significant contamination. And a lot of those patients who had abnormal PSAs actually pulled out. So you could see here that the benefits or the survival benefit from prostate cancer screening occurs further down the track. And usually as patients live beyond 9-10 years from the time they're diagnosed, that's where the survival benefits start to occur. But if you look at when the PLCO was reported, it was actually too early in the piece. So there wasn't much of a benefit seen. But as there have been subsequent papers that have looked at these patients beyond that time, you can see that those survival curves start to move further apart. And you can see as you move along that the curves spread. And this was more clearly seen in the ERSPC study, which had a slightly longer follow-up. But now, as we move on, they're getting further and further, and the benefits are more obvious. So we still need to diagnose a lot of men to actually save a life of prostate cancer. And since these trials, we have become a lot better at trying to choose the men we're going to operate on or radiate or treat, as compared to the ones we think that this is a small amount of low-grade prostate cancer, unlikely to become an issue, and often we will not subject these people to treatment. We will say to them, we know you've got this, we know it's a cancer, and you're more likely to die of something else, and we won't subject them to treatment, but we'll keep a close eye on them. So if they develop a change, we'll then subject them or offer them treatment should they choose to want it. And that's the concept of active surveillance. So, you know, the debate, as I said, risks and benefits. Some of these men may not die of the disease, therefore why subject them to treatment? Why, you know, potentially subject them to complications and side effects for something that may never give them any grief? As compared to, we know that men do die of prostate cancer. 3,000 men a year die of it. Many won't die of it, but some of them, the disease can progress, and it can be a very difficult condition to treat in, you know, later stages. So it is a real condition, but we are trying to improve identifying who is going to have an issue and who isn't going to have an issue. So these are the current Urological Society of Australia and New Zealand guidelines. You need to have the discussion with the patient. Let the patient know and understand that most men won't have an issue with prostate cancer if they're diagnosed with it now for another 7 to 10 years. So if they've got, you know, stage 4 heart disease or a million other comorbidities, they're unlikely to have issues with prostate cancer. We probably don't need to be checking their PSA because they're going to die of something else. And back onto that lifestyle talk we had before, that was fantastic. I have a lot of patients who come in morbidly obese with an elevated PSA, and, you know, they go, have I got prostate cancer? And I'll say to them, that's the least of your problems. Your obesity is going to be your number one pressing issue. You know, if you don't attend to that, that's going to be a much bigger problem for you than your slightly elevated PSA. So apart from PSA, which we use as a screening tool, we also use the digital rectal examination. I know some of the GP guidelines are that the GPs don't necessarily need to do it. I think not doing a digital rectal examination misses the opportunity to sometimes find some non-PSA secreting tumours. But I understand if the GP is not comfortable in doing it, sending them off to a urologist is an entirely reasonable thing to do. But nowadays, most of these patients are having MRIs. MRI is a lot more sensitive at identifying what we call significant prostate cancers. Significant prostate cancers meaning cancers which are more likely to progress. It'll pick up about 90% of them, and they are now Medicare funded for these indications. People under the age of 70 with 2 elevated PSAs, above 3, or, you know, above 2 if they've got a strong family history, or over the age of 70 with PSAs above 5.5. And you can see here, you can see some subtle changes in that bottom left-hand corner. This is what we call a Pyrex 4 lesion. That's an ADC image there, and that gives us an idea that there may be something sinister going on here, and then we should target it. So what everyone has with an MRI is they get given a PIRAD score. 1 to 2, the chance of there being a cancer is very low. We often tell these people, we're just going to watch your PSA, see what it's doing. If it continues to rise, we may say there is a possibility the MRI's missed something, and we may subject you to a biopsy. But if they're 3 or above, we'll often consider biopsying these patients, targeting that area, but also doing a template biopsy to see what's happening with the rest of the prostate. This is just a couple of pictures on grading or the architecture of the cells, because not all cancers are the same. People say, what happens if I've got cancer? It's such a big spectrum of disease that it's not one size fits all. It's got to, and many people would argue that Gleason 3+3 or grade group 1 disease should almost not be called prostate cancer, because the likelihood of this kind of disease progressing is sort of less than 1% over a 25 to 30 year period. So if we do find a patient that has got, you know, grade group 2 disease, or even 3 or 4 or 5 disease, that is likely to live another 8, 10, 15 years, we then think about treatment. And there's a wide variety of treatments available. These are historically the most traditional techniques, which are still most widely used, surgery and radiation. That decision's made upon patient factors, lifestyle factors, what the patient is willing to accept. So robotic prostatectomy has been around now for about 20 years, not as widely available in the public sector, but there is a push. I note the Liberal Party is promising to deliver about 15 public robots. These are quite widely available in the private sector at the moment. I think there's undoubtedly, there's been a couple of papers that have looked at it and compared it to open surgery. Definitely less bleeding, earlier return to continence and recovery. But long term, we think the cancer control rates, erectile function and continence rates are probably similar. But really, the open technique is something that which is sort of fading into the background now and not seen. What I'm seeing is that it's easier to teach a trainee to do this. It's easier on the surgeon. You're not bending down a pelvis for 2.5, 3 hours. The vision is remarkably better. There's definitely less bleeding and the recovery is a lot quicker. So this is the setup for robotic prostatectomy. I don't know if any of you have seen this, but basically the surgeon is looking down this console where he gets a 3D picture of what's happening inside the patient, which we'll go through. You'll see the video of it shortly. These instruments are controlled by the surgeon here and the patient lying on the table here with nursing staff and a surgical assistant adjacent. So this is a video which is sped up, because this usually takes about 2.5 hours, anywhere between an hour and a half and 3 hours. So we've sped up aspects of this. So basically what we're seeing here is we're reflecting the urachus, which is a remnant which is attached to the top of the bladder, pushing that down to get into the space between the bladder and the prostate and the anterior abdominal wall, and basically creating this space. We can see the instruments here. The laparoscopic instruments basically don't have an elbow or a wrist. They work in one dimension. These can bend around, which gives you an ability to dissect important structures and really get around corners. But most importantly, the great advantage here is in doing your anastomosis and stitching in a really difficult to get to place. And being able to do that has really eliminated one of the side effects of bladder neck contractures, which is scarring between the bladder and the urethra, which leads to the patients having difficulty voiding. So here we can see the bladder being pushed down, prostate in the front, and basically getting to the space between bladder and prostate. Here you're going to see the catheter appear shortly. We try and sometimes preserve the bladder neck because there is a theory that it does contribute to some of the continence function. And also, if you don't get a very big bladder neck, it avoids the need to re-stitch it and potentially damage the ureteric orifices. So basically, we're in bladder here, coming through what we call the posterior bladder wall. We're going to get down to the vas deferens and the seminal vesicles, this is probably one of the most technically demanding parts of the procedure in terms of learning the planes to get into, where a lot of the younger surgeons will struggle with this part. You can see here there's hardly any bleeding. I mean, historically, these operations, deep down into a pelvis, lots of big veins, often you'd lose, a litre, not uncommon for patients to need multi-unit transfusions. We just don't see that now, right? Transfusion rate's about 2% for this procedure. Many patients are ready to go home. They are being done as day cases in certain places. Most of them are overnight to 2-night stay. And patients really remarkably very, very comfortable in a short amount of time. Now, that's not to say there are no complications, right? The robot is a great piece of engineering and a lovely tool. The quality of the outcome is completely dependent on the surgeon operating it. But as I said, the key here is a lot easier to teach someone to do this operation, which means we're getting better results from younger surgeons earlier in the piece. And if you look at the key papers that compare open surgery to robotic surgery, the outcomes were fairly similar, but the open surgeons had 20 to 25 years experience compared to the robotic surgeons who had 2 or 3 years experience. They weren't necessarily comparing surgeons who both had the similar amount of experience. So basically, where are we up to here? So we've brought up the seminal vesicles. We're coming on the underside. This is the bowel, the rectum, pushing this away. And we're controlling the vascular pedicles, or the blood supply here, which goes into the prostate, using little clips to control this area, and basically moving in such a way where we're trying to preserve the nerves which go down to the penis for erectile function, and the nerves and the blood supply that go to the sphincter that control our continence, right? So this is why we're creating these pillars either side of the prostate to preserve the function of the neurovascular bundles as such. So you can see here we've got prostate underneath. This is all prostate. This is dorsal vein, which is a big venous complex which drains all the blood from the penis. And we're basically cutting onto, this is all prostate down here. We're going to cut on here and then remove the prostate. The prostate's usually put into a plastic bag within the abdominal cavity, and then a little cut is made in the patient's abdomen and drawn out into that, through that bag. So I'm going to move on shortly. I'll just show you the part of the anastomosis here. The anastomosis means the join, or the join between the bladder and the urethra, and that's where the real, I mean, there are multiple benefits to this procedure, but this is where the real, you know, your ability to be able to suture in a really difficult to get to position is really beneficial to the patients, and we've seen outcomes as such. So I'll move on from here. So briefly, focal therapies, we are moving to a point where imaging of the prostate's become a lot better. We're identifying where the prostate cancer is. We're now talking about just treating that spot in the prostate rather than the whole prostate to minimise potential side effects. There's things like cryo and HIFU which have been around for a while. Now the nano knife is something which has been around now for several years and probably starting to gain some serious traction. Basically involves putting a couple of leads or a couple of little needles into the prostate and an electric current running through those areas to create little pores into the tumour cells and lead to apoptosis and kill those areas. It's basically done as a day case. Patients often leave with a catheter for a couple of days. Much more improved side effect profile. The likelihood of patients needing repeat intervention is moderate. It's probably in the order of about 30% over a 5-year period. But this is all changing. As our imaging improves and our ability to identify significant cancers on imaging gets better and better, we're probably going to move away from whole gland therapy like we did with nephrectomies. Years ago, we'd take out a whole kidney for a 2-centimetre lump. Now we're just taking the lump out. We're going to probably look at just treating the prostate going forward. I'm going to leave it at that. So, any questions? Any questions? We taught you well at the Austin, but you know.
You did. Thank you very much.
Thanks, everyone.
And certainly the robot is a fantastic piece of technology to watch in action. So we'll go back 2 sessions now to current concepts in vaccine development by Professor Vassou Apostolopoulos, who's Professor of Immunology at Victoria University. Vassou has 30 years of experience in the areas of immunology, crystallography, cellular biology, translational research, clinical trials, and the development of drugs and vaccines. Vassou has led and directed a number of research programs at several research centres and universities locally, nationally, and around the world, and is currently the Pro Vice Chancellor, Research Partnership at Victoria University, Australia. She has received over 100 awards, published over 460 research papers, is an inventor on 23 patents, and her current interests in research are treating chronic diseases with an immunological focus. So please make Vassou feel welcome.
Okay. So thank you for inviting me to present at this conference today. I'm going to give a bit of an overview of what we've done in the last 30 years. So, and in the area of vaccines, I mean, you know, in the last year or last 2 years, we've heard a lot about vaccines, but what have we done in the last 30 years on vaccines? In particular, my focus has been in cancer and developing vaccines for cancer. We've done lots of clinical trials, which I'll show some data. We've got 25-year follow-up data from breast cancer vaccine trial, and what other type of vaccines we are developing. So basically, we've heard about vaccines a lot in the last 2 years, and basically there's different ways of making vaccines, whether it's DNA, mRNA, or based. But first of all, to make a vaccine, you have to identify a target. So we've all heard about COVID, so I'm going to bring up COVID, but I'm not going to bring it up again because we probably don't want to hear about COVID, but it's just to get the concept right. So with COVID, the antigen or the marker that's present on the virus was identified, the spike was important. Therefore, if you make antibodies or T cell responses to the spike region, you'll kill the virus or the virus won't replicate in the body. But how do you do that? How do you stimulate the immune system to generate these antibodies or the cellular type responses? First, you have to identify the target, which it's easy for COVID. It was the spike region. But then you have to have a way of delivering it into the body. And there's different ways of delivering it. There's DNA. You can make it as a DNA. You can make it as a synthetic protein, peptides. You could make them as little virus-like particles, non-replicating viral vectors. So they're all different ways of putting this target that you've identified, in a way, and it delivers it to the cells in the body, and you activate them. Now, we've all heard about, Moderna, Pfizer, that uses the mRNA of the virus. Sputnik, the AstraZeneca, Johnson & Johnson uses a viral vector. So inserts part of that spike into a viral vector, and that's how it's delivered. We've all heard all these names. Sinovac, Sinopharm, that uses a whole virus inactivated, or that spike region inactivated viral vaccines. Novavax is more protein-based. But it doesn't matter how you make it, the end result is the same. The end result is to stimulate the immune system, okay? Now, so that's how I'm introducing you to vaccines, because that's, we've all heard about vaccines in the last 2 years, and I think we're overloaded with information, but there's different ways of making them, but the end result is the same. The aim is to stimulate the immune system. Going back 30 years ago, how did we do this to try and develop vaccines for cancer? So that's just the first paper I ever published was in 1993. It was a result from my honours year in 1991. So it's over 30 years ago, where we were trying to identify and characterise cancer. In this case, it was breast cancer markers. I mean, these days, you do next generation sequencing, you do all these fancy technologies, and we've come up with hundreds of different markers that are present on the cancer. Back then, how did we do this? We mushed up cancer cells, we injected them to mice, and we were generating monoclonal antibodies. It was just going back a long, tedious way. But anyway, we characterised this marker that was present on breast cancer. We called it mucin 1. It was the first one that was identified. So far, there's probably about another 20 different mucins. So breast cancer, it's highly expressed on the breast cancer cells. So 30 years ago, we had identified a marker that was on the cancer. So that was the first step, identifying the marker. The next step was we had to deliver it to stimulate an immune response against the marker, because that's what's overexpressed on the cancer cells. So as I said, that's to reminder of the vaccines. Ours was the marker we had identified, and I characterised it. So there's lots of publications way back. These days it's called CA15.3 or CA19.9. It's a MUC1 antigen. They used, actually, the kits used some of the monoclonal antibodies that we made 30 years ago. So basically, the method that I used was synthetic peptide, and we also used proteins, okay? But using that marker. We did a phase 1 clinical trial just to see whether if we inject this as a synthetic peptide or as a protein into humans with breast cancer, can we stimulate a response to that marker? We did a phase 1 clinical trial. That was in 1993. We did that at the Austin and at Peter MacCallum Institute, Cancer Centre. And basically, we found that we got, in this phase 1, it was the first time there was a phase 1 study on a cancer vaccine in the world that we had done as a result. That was as a result of my honours and PhD research. But we found that, we were able to stimulate a weak response in humans. There were some clinical responses, T cell responses were generated, some antibodies. So we went back into the lab and we tried to further improve the vaccine technology, and we used a method where we were targeting these cells which educate the T cells. So these are cells up there, the dendritic cells. So we targeted the vaccine to these cells, and they're the ones that go and educate and stimulate the T cells, because they're the ones that we wanted, because the T cells are the ones that are more therapeutic or protective. So we published a phase 1 clinical trial where we used an improved version of the vaccine where we're targeting, it was a specific targeted approach. And we published, it was a 1995 clinical trial, we published it in 1997, we did a phase 1 dose escalation from 10 to 1,000 micrograms. We did a phase 1/2 where we did different routes of administration, subcutaneous, intramuscular, intradermal. We also used intraperitoneal because there was some colon cancer patients, and the doctor, this was the doctor up in Queensland who was inserted a catheter or a port into the peritoneum and was injecting the vaccine that way. And we found that we were able to stimulate antibody responses, but more importantly, we were able to stimulate T-cell responses. Then technology advanced a little bit. That was just basic, cytotoxic T-cell responses. Technology advanced a little bit at the time, and in 2001 we published that we were able to identify that by giving the vaccine to the patients, they were generating T-cells, but they're also generating a TH1, which is more of a cellular type response with interferon gamma production, and they were actually the therapeutic ones. So we did a phase 1, phase 2. We found that there was some, phase 1, phase 2 clinical trials. Then we did it's a pilot phase 3 clinical trial, and this clinical trial is a 25-year study, and it's 25 years this Christmas. So this is a long-term clinical trial. One, we know that it's safe because it's been safe in all the patients, but most importantly, the data suggests that we're able to protect people that had the vaccine from the cancer recurring. So we injected women that were considered early stage breast cancer patients. They were estrogen receptor positive, they were postmenopausal, and they're all put on tamoxifen. So after 5 years, the ones that are put on tamoxifen, there's about a 20% at the time they put on tamoxifen for 5 years. I believe now it's changed the guidelines, and they put on tamoxifen for 8 to 10 years. But at the time it was 5 years. 5 years later, the women that are on this treatment, so they have had all the treatments, and then they're all put on tamoxifen, the hormone therapy. 5 years later, 20% have recurrences, compared to the ones that don't have tamoxifen. Obviously, it's a higher recurrence. So we used that cohort of women, the women that were all on tamoxifen. So all women received tamoxifen, and so they all received, that's the standard care, that's the standard treatment. In addition, what we did, we gave half of these women a vaccine. So we had half the women, in addition, that got tamoxifen, in addition, they got the vaccine. 5 years later, we found there were no recurrences. So we were able to further decrease that 20%, which was the control, down to 0% recurrences 5 years later. These women have been followed up for 25 years. In the tamoxifen group, 25 years later, the clinician, this clinical trial was done in Europe. Greece also had participated. They had some patients from Greece were also in this study, but it was a larger study. And the tamoxifen group, there's 25 years later, there's about 60% recurrences, 25 years later. That's in just the standard treatment group that are on their standard treatment, which is tamoxifen. 25 years later, all the ones that receive the vaccine are 100% protected against cancer recurrence. So now that we have this data, we are now confident that this actually can protect women from cancer recurring. So now we've got this long-term data because it's powerful data that we have. Now we could go out and then try and get it out and inject everybody, because we are confident that it can protect the high-risk group. We could protect them from the cancer coming back. We published various papers, the 8-year follow-up, 15-year follow-up data, 18-year follow-up data, and I've just submitted the 25-year follow-up data to the Lancet because, with a lot of these clinical trials, it's very hard to get long-term data showing such striking information. So that's my vaccine that we've developed, and the next phase now is to market it out and commercialise it or do a large phase 3 study. So that study was happening. Back in the lab, obviously, we're researchers. We're trying to improve on and make other vaccines. So we developed a vaccine for ovarian cancer. In the meantime, what we found is that marker that we had found that was present on the breast cancer is also present on ovarian cancer. It's present on prostate, colon, pancreatic, lung. So it's an adenocarcinomas, this marker. So the same vaccine could be used for other types of cancers. But we did another approach. So I had done this in the I think I did this in 1997 before I left and went overseas. But then I came back and the company had done some clinical trials where what we did is we basically, because in ovarian cancer, the cancer is already advanced, and when we gave them the direct injection of the vaccine, it was hard to see any clinical benefits. So what we did is we did apheresis, we got the bloods from the patients, we isolated those white blood cells and we differentiated them for 5 days in the lab, and they became, down the bottom, they became those dendritic cells. We mixed them with a vaccine and we re-inject it back into the patient. So this is quite powerful, this technology, but it's very tedious, very expensive, because you need special GMP facilities and sterile conditions, etc. But so that's what we did. We injected that back into the patients. That's called CVAC. You could read up about it. But basically, what we found, or the clinicians are reporting, the top one doesn't have this arrow, but there was a lung metastases in one of the patients 14 and a half months later after the treatment of the vaccine. The lung metastases had disappeared, and then there was a liver metastasis in a different patient, and the liver metastasis had disappeared 14 and a half months later. Being immunologists, being scientists, where the clinicians report the clinical data, but I'm an immunologist, so I want to look at what's happening to the cells and what's being stimulated, and I was excited to find that T-cell responses were being generated. It's all published. We're able to, these are the CA125, the marker for ovarian cancer. We're able to show that we either have stabilisation or complete, it went down to 0 levels, the CA125. We're able to show T-cell responses. These are phase 1, phase 2 clinical trials, etc. So these have all, we published these a few years ago. In one of them was progression-free and overall survival. So the controls, it was like we were able, by having the vaccine, we're able to extend the progression-free and overall survival from 22 to 48 months. But we're back in the lab, we're trying to improve the vaccines, new technology, so we're making DNA-based vaccines, we're using these dendrimers, so we're making the vaccine look like a branch of a tree, so we can have more of those markers present, and we're also delivering it using nanoparticles. So we're doing a lot of optimization in the lab. We've developed vaccines for pancreatic cancer, prostate, colorectal cancer, and leukemia, which the pancreatic cancer, we're going to start a clinical trial. That's going to be done up at the Fred Hutchinson's Cancer Center up in Seattle in the USA. So developed all these vaccines, it's all going great, but you know what? Technology has advanced over the last 30 years. It's not what, how we identified the marker 30 years ago by mushing up cancer cells, putting them in animals, and then we made monoclonal antibodies, and then we characterised them. It was like a long, tedious effort. These days, we know a lot more by doing mRNA, next-generation sequencing. We know more about the cancer. We know that it's very complex. So I've published quite a lot on the cancer microenvironment, so what's in the environment. There's a lot of immunosuppressive markers. There's a lot of cancer cells in the area. There's a lot happening. It's very complex. That's why you're seeing a complex picture up there, because that's how complex it is. It's not as simple as, okay, we're just, there's just a marker there and we're killing the cancer. But it's very, very complex. So going back into understanding what's happening in the microenvironment and what other immunosuppressive markers are being present, then we could improve upon drugs and vaccine delivery. I'm finishing up. So here's what it was on the cover of one of the journals last year. That's colorectal cancer, where we had identified these novel markers present on colon cancer cells. They light up beautifully. I'm finishing up. So we did some studies with actually, this is one of my Greek collaborators in Greece. He's a breast cancer surgeon. So he had given us 300 breast cancer samples from different stages of breast cancer, and he gave them to us. He had collected them over a few years, and he gave them to us, and we actually looked at, this is from the Greek population, and we actually found that there were changes in a single nucleotide. So it's one nucleotide, which is a small change. A single nucleotide change in the interferon gamma gene, and that was enough to correlated with risk and aggressiveness of the disease, of cancer. And also we just found that there was also a checkpoint marker, one polymorphism change in PDL2, which is one of the programmed death ligands. But we found that there was, in this cohort of patients, that there was a one nucleotide different, which is different, and we compared it to the rest of the European population, and it was novel in the Greek cohort. So getting this information, we could then diagnose patients or try and understand better or look for these changes, and then the clinicians could do their treatments. And I'm finishing up actually. We've got a model in the lab where we've got normal mice. We've got mice which have inflammatory bowel disease. If you leave them to get old enough, they get severe inflammation in the colon, and they get prolapse of the colon. And then if you leave them even longer, and we add actually dextran and glucose in the water, they develop cancer, colon cancer. So we've got the progression of, we've got this model. It's us and one other lab in the world that have got this model, these mice. So we're able to see from normal to early inflammation, severe inflammation to cancer. We know we could see the progression happening. We've got the colons from these mice, and we've done next generation sequencing, and we've been able to identify pathways that are altered as there's progression from inflammation to cancer, and what genes are upregulated, downregulated. So we're about to publish that. So that's actually quite powerful, that information. So using this next generation sequencing, we've got about 30,000 genes that we've identified. It's just so powerful, a lot more powerful, this technology, than what we knew 30 years ago. And finishing up, this is my last slide. So I've developed vaccines using immunotherapy, all these approaches. We've done vaccines for multiple sclerosis. We're going to be doing a phase 1 study. I got a grant from JDRF, which is a Juvenile Diabetes Research Foundation, and we fast-tracked and we developed a vaccine or immunomodulation for type 1 diabetes. So we're able to revert back or tolerize these activated T cells that are damaging the pancreas. We're able to tolerize them, so basically put them to sleep. So we've got a vaccine for type 1 diabetes. I've also got a lab, one of my group in my lab, I've got an active lab. It's about 10 people working on a methamphetamine drug addiction vaccine. So we've got a blocker. So we've got this novel way of delivering ice or methamphetamine. The body makes antibodies, and then the antibodies will go and bind to the meth, and then it doesn't have its effect. So we've got a blocker, but we call it a vaccine because it works like a vaccine. So we're going to do a study on that in people that are addicted to methamphetamine. I actually have a vaccine for COVID, not to the spike region, because that's the one that mutates and there's all the variants happening. Mine's to the core, where there's no mutations occurring. So that will be one vaccine fits all for all the mutants that are coming out. And finally, we're developing a vaccine for Alzheimer's disease to try and stop the plaque formation that are happening in the brain. And that's it. So that's what I've done. That's just part of what I've done in the last 30 years. Basically developing vaccines. A lot of people have said to me, "Oh, you'd made a vaccine 30 years ago. What did you do with it? What happened to it? We heard it in the news 30 years ago. You're all over the newspapers, but what happened now?" I'm like, "Yeah, but you have to wait. There's one study. One study alone was 25 years. So you have to wait and get the data. You don't just get the data the next day." And a lot of people were telling me during COVID, they made a vaccine in 3 months for COVID. What about you? You made it 30 years ago. I said, yeah, it's different. COVID's different. You know if it's going to work because you've got a whole population that's been infected with viruses. You know if you're going to get protected or not protected. You know if you get it, you might have minor symptoms or, more advanced symptoms. With cancer, you had to wait 25 years to get that result. So it's completely different thing. So I've got hay fever. I'm not crying. I've got hay fever. So that's a bit of summary of what I'm doing. I also do research partnerships, Pro Vice Chancellor at the university. I've been at this university for 8 years. I've been all over the world at different universities, but I'm involved in partnerships. So if anyone wants to do research and partner with what we do a lot more. We do mental health, we do physical activity, we do lifestyle work, we do name it. We do it at the university. So I'm the person to talk to. Thank you.
Vaso, thank you very much. It'll be amazing to see how that technology unfolds and completely changes clinical practice. Moving on to session 11, Current Concepts in Internal Medicine, by Dr. Dimitris Skliros from Philadelphia. Dimitrios Skliros was born in Lefkada in Greece and graduated from the Athens Medical School in 1980. He's been practicing general medicine in Athens in private practice, and he's affiliated with Ygea Hospital. From March 2008, upon his arrival from the United States, where he had his basic training in general medicine, acquiring his credentials from Episcopal Hospital in Philadelphia in 1993. Dimitri.
The pointer is here, huh? Yeah, okay. Well, δεν είναι ο πρόεδρος εδώ του Ιατρικού Συλλόγου Αθηνών, αλλά να τιμήσουμε την μητρική μας γλώσσα. Καλώς ήρθατε. Χαίρομαι πάρα πολύ που είμαι εδώ. Εδώ εξάλλου είναι και η δεύτερη πατρίδα μου, γιατί μικρό παιδί μετανάστευσαν οι γονείς μου εδώ και έκανα 18 χρόνια εδώ στη Μελβούρνη και χαίρομαι που είμαι εδώ. Πριν δώσω την ομιλία, θα ήθελα να αναγνωρίσω και να δώσω τα συγχαρητήριά μου στον κύριο Περπηλή για, εγώ πιστεύω, πολύ καλή ποιότητα ομιλιών και θέματα πολύ αξιόλογα, πραγματικά. Και χαίρομαι που ο ελληνισμός εδώ στη Μελβούρνη είναι σε τόσο υψηλό επίπεδο. Και θα ήθελα να αναγνωρίσω και τον κύριο Πάντο, το φίλο μου, που βασικά περπατάγαμε στην Ιθάκη το καλοκαίρι και λέει πάμε Αυστραλία και ετοιμάσου μια ομιλία να δώσεις και τον ευχαριστώ για την ευκαιρία. Λέγοντας όλα αυτά, θα πούμε μισά ελληνικά, μισά αγγλικά. Όλοι οι γιατροί που έχουν περάσει από το νοσοκομείο που εκπαιδεύονται έχουν πάντα, τους καλούν 2-3 ώρα το πρωί, ότι ένας άρρωστος εκδηλώνει chest pain, dolor de pecho, στη Νέα Υόρκη, έτσι, στη Θάχη. Και πραγματικά μόλις που το ακούς αυτό το πράγμα, σε βάζει σε σκέψη τι μπορεί να έχει. So the etiology of chest pain in primary care is just not coronary artery disease. As you can see, 36 to 49% is musculoskeletal. 15 to 18% is only coronary artery disease, gastrointestinal, pulmonary, psychiatric. A lot of people that have psychiatric disease manifest chest pain. So in the differential diagnosis, so it can make your life easier and you don't have to admit the patient if he really doesn't have a reason to be admitted, you have to think what could be going on. Now, this is data from the United States. There are around 8 million visits per year in the United States with chest pain in the emergency department. This is the statistical reality. Less than 10% have what we call acute coronary syndromes. About 60% have a negative workup for acute coronary syndromes. Despite the low threshold for admission, 2 to 5% are missed. Oh, yeah, okay, thank you. First cost. Without associated mortality and high morbidity, and the cost is around 10 to 13 billion. Well, of course, you don't want to miss it though, because that could kill the patient. So I've got about 39 slides here, so I'm not going to really go through it. I'm just, the acute coronary syndrome, aortic dissection, pericardial tamponade, επιμονισμός που λέμε, διαχωριστικό ανέβρισμα, I'm sorry, εμβολή, πνευμονική εμβολή, pulmonary embolism, πνευμοθώρακα, μεσοθωρακίτιδα, mediastinitis. So everything is history taking. You gotta really take a good history, do a good physical exam to come hopefully to the proper diagnosis. The characteristics of chest pain, pulmonary embolism may cause a sudden onset of pleuritic chest pain. The pneumothorax is a potential cause of pleuritic, sharp, and sudden chest pain. The history, as we said, is very important. You can see the numbers there. Around 5.6 million individuals each year in the US contract community-acquired pneumonia, another potential diagnosis for those with chest pain. So you could have infectious diseases that are manifesting with this type of clinical presentation. Now, of course, when you want to differentiate, there are different modalities that you can use, and the EKG is the number one thing you're going to do to see if there are any changes. And if you have an old EKG to compare, that will always help us to differentiate. For example, if you see ST wave elevation, then that will make you think that this is an acute coronary event. That's right, in the myocardial infarction. Now, once you make the proper diagnosis, because everything in medicine, as we know, is proper diagnosis, you can give it the proper treatment. For example, for thrombosis of the coronary arteries, you know, you have the ruptured plaque, you have the aggregation of the platelets. What you don't, that's what you want to stop. And of course, we have the anti-platelet medication there, the 3 different forms: clopidogrel, prasugrel, anti-serolol. The anticoagulant therapy for ST wave elevation, myocardial infarction, for a primary percutaneous coronary intervention. Routine medical therapies, we know that, you know, myocardial infarction, you have all these neuroendocrine, epinephrine, norepinephrine. It's really a very stressful situation for the heart, and we know that beta blockers are indicated because they really relax the myocardium. They try to stabilize the plaque which is in the coronary arteries, so they're clearly indicated. And as we said, seeing that you have a lot of renin-angiotensin, aldosterone system, we also like to inhibit this because it's having a profound burden on the myocardium. The statins, of course, we know that the initiation of a plaque in the lumen of a coronary artery, really the basic is that you have the plaque formation, you have a lot of monocytes that are coming in, ingesting the cholesterol and forming foam cells, which then inevitably lead to occlusion of the lumen of the coronary artery. So statins are a very important part in trying to prevent a coronary event. When you do have ischemia in the myocardium, as Nico mentioned in the morning, that's a good real estate, that's a good substrate to have a lot of arrhythmias. And we know after a myocardial infarction, ventricular fibrillation is around the corner, which could be the cause of death. So you always have to think of an implantable cardioverter defibrillator after you evaluate the patient and you want to send him home. Risk stratification, of course, patients is very important to try to predict which patients are going to have another event in the near future. Misdiagnosis of acute cardiac ischemia in the emergency room, that you don't want that to happen, because sending a patient home, like we have a lot of patients that go, you send them for a stress test, they're negative, and you hear too much, and that happened about a year ago. We had a patient who came, he was 56 years old, he was a smoker, hypertension, but the stress test was negative. We sent him home, and it was September. He was down in Ilia going to a wedding, and we found out that he had sudden cardiac death. So, you know, nothing's foolproof here. Prediction of the need for intensive care in patients who come to the emergency department with acute chest pain, you have to really evaluate them. TIMI risk score, thrombolysis and myocardial infarction, the risk score. So you're really trying to stratify the patients so you can send them home and you can know that these people are not going to have a sudden event going home. The TIMI risk score interpretation are really, there's a lot of mathematics, so you can sort of predict the danger of a patient having a future event. This is a low risk when you have a TIMI score between 0 to 2, an intermediate risk, and a high risk. While the global registry for acute coronary events risk stratification for STEMI, for ST wave elevation myocardial infarction, when the gray score is less than 125, you have a low risk, intermediate risk, and high risk. So all these studies are trying to identify people preventively so they won't have an acute coronary event. Okay, cardiac and non-cardiac conditions that can mimic non-ST wave elevation acute coronary syndromes. You have your cardiac, you have myocarditis, pericarditis. A lot of people now with COVID. I have a very good friend at Ornacio Heart Center. A lot of people, even with the vaccination, they manifested. It was hard to believe, but a very good friend of ours had her vaccine and she was admitted with chest pain, and it was shown that she had pericarditis, which was correlated to the vaccine. Pulmonary etiologies, sickle cell crisis, anemia, vascular aortic dissection, aortic aneurysm, cerebrovascular disease, gastrointestinal. A lot of people have peptic ulcer disease, which could manifest with chest pain. And of course, orthopedic and infectious causes. The echocardiogram for acute chest pain, I think, is the hallmark, especially if you compare with the previous EKG that the patient might have. The aortic dissection, a lot of people have sudden death, and it's not because of coronary artery disease, but they have a tear down the wall of their aorta. The DeBakey classification, the Stanford classification, the myocardial perfusion imaging. So all these, we're trying, as I said, to assess if a patient is having a blockage in his coronary artery. And the chest pain in the emergency department, we're using a lot of modalities right now to try to see what the risk is for this patient. The nuclear cardiology. And of course, the gold standard really is the CT angiogram, because a lot of these tests, their sensitivity and specificity is not the best. I mean, even an EKG, a patient might be having a heart attack, and in around 35%, the EKG is completely normal. So you always have to look at the sensitivity and the specificity of a test that you want to rule out a specific disease. Now, the CT angiogram in the emergency department is also a very good way to predict if there's any pathology. Evaluation of a triple rule-out protocol, we're always trying to, as I said, send the patient home knowing that he's not in danger. We're using the 64-slice CT, and at a Yale hospital that I'm at right now, we do have that. And of course, the non-ST segment elevation myocardial infarction, meaning that it's in the subendocardial, just underneath the endothelial cells that line the inner surface of all the vasculature and the heart, because when you're looking at ST wave elevation, we know it's transmural. It's starting from the endocardium, going right to the epicardium, and that's why that might kill you. These are more small infarcts that you could sort of get away with. Okay, a selection of initial treatment strategy, invasive versus conservative, recurrent angina, elevated cardiac biomarkers, the troponin, new or presumably new ST segment depression, signs of symptoms of heart failure, high-risk findings from non-invasive testing, hemodynamic instability, sustained ventricular tachycardia, a PCI within the previous 6 months, a percutaneous coronary intervention, a prior CABG, high-risk score on the Timeo Grace, the mild to moderate renal dysfunction, diabetes mellitus, and a reduced LV function, the ejection fraction, a very, very important prognostic indicator for long-term events is the ejection fraction. It's actually showing you cardiac reserve. Okay, the antiplatelet therapy, as we said, the blockage in the coronary arteries start when you have rupture of the plaque. You get the accumulation of the platelets. That's the beginning of the process. So you want to really try to stop it in the beginning. And there's no such thing as a sudden heart attack. It requires years of preparation, and that is true. That slide, I think, says a lot. And you're always invited to come to Lefkada, to the village of Maradohori. I'll be happy to see you there, okay? So you take good care, and it was always nice being here.
Moving on to our next talk, current concepts in renal artery disease. by Dr. Antonis Polidorou. Who we're all very well familiar with by now, but is otherwise a graduate of the Medical School of the Kapodistrian University of Athens, having specialised in cardiology at the University Hospital of the Cardiology Clinic of the Hippocratic Hospital in Athens. In 1978, he was awarded a PhD from the University of Athens, and until 1985 trained in hemodynamic and invasive cardiology at Guy's Hospital in London in the intravascular treatment of carotid arteries, peripheral vessels at Nancy Clinic in France, at Scripps Clinic in San Diego, and M of the United States of America. In 1985, he worked at the cardiology clinic of the Nimitz Hospital in Athens, where together with his associates, they started the first coronary artery angioplasty surgeries. In 1990, he was appointed Director of Hemodynamic and Invasive Cardiology at the General Hospital of Nikia, and then took over the management there of the respective department of the General Hospital of Evangelismos in Athens until he retired. Please make him welcome.
Thank you. How can we do the picture?
This is the picture.
Hmm?
So just go to the next one.
No, I want to repeat in order the.
They are getting the big picture, you're getting the small picture. Okay?
Mhm.
This is your next slide, this is your current slide.
So and we go by that here, yeah?
Yep. This is what's coming up. This is the slide that they
Thank
are
you very
watching.
much. Thank you.
Okay.
Dear colleagues, good afternoon. I would like to thank again Professor Pirfiris for inviting me here in the beautiful city of Melbourne. I'm going to talk about the exclusion of renal artery aneurysm, work that was done many years ago after an experimental work. So, we all know the types and location of renal aneurysm. According to the type, the saccular and fusiform. According to location, the extraparenchymal and the intraparenchymal, and the current methods of treatment. Of course, the renal artery aneurysm is a rare condition found in less than 0.01% of adult population. Elective repair of renal artery aneurysm is generally undertaken to reduce the risk of rupture. Open surgical repair with renal preservation is the current standard of care. So we start to think how to treat an aneurysm without surgery. And for 2 years, we did this experimental work at Nancy on animals, on pigs. We are working with the French colleagues and Dr. Dietrich from US. And in 2 years' time, we developed the multi-layer stent. The multi-layer stent, self-expandable stent, consists of a 3D braided tube. It is built as a structure involving several interconnected layers, as you see on the picture there. And the number of layers is adaptable to the application, different to femoral or carotid artery, cerebral or aortic aneurysms. For our experimental work, we use the particle image velocimetry. According to this method, we studied the vortexes in the aneurysm and how the aneurysm gets bigger because of the vortexes, until the rupture of the aneurysm. So we follow the movement of every vortex. Sorry. as you see on this picture, we follow the movement of every vortex with time at a rate of 25 images per second. And we found out that more the vortex moves along the aneurysmal wall, more it becomes stronger. We may say that it is like a heritage with an eye, if you see in the aneurysm. And each vortex, it follows by another. On the second image, where we use the multi-layer stent, at equal time, we saw that the movement of the vortex slows down and reduces the force on the wall. So we use a multi-layer stent. There is no force of the vortex on the aneurysmal wall. Here we can see on the image, again experimentally, so in this picture, we can see that the vortexes are aligned when we use the multi-layer stent. They follow the same trajectory. That's why it leads to thrombosis. We found out that this behavior is effective only when the stent was enough density of the mesh as the multi-layer. And this was not possible with the monolayer stent. So we started to put layers on the stents until to find out how many layers can we use in order to treat an aneurysm. So we found out that when the aneurysm is circular without branch, we have an organized stable thrombus if we use the multi-layer stent. This theoretical simulation shows that at each branch, if we have a side branch, at each branch entry, we have a systematically flow recirculation due to the change of the direction of the flow lines. That's why we have atheroma on the ostium of the renal arteries. And the second picture shows the effect of the branch of one-layer stent. So we can see that the recirculation is diminished, but is still there. And the last picture shows that the multilayer aligns the flow lines, which improve the speed. Clinically, this speed, it does not allow the cells to get fixed as shown on the next slide. So we may say that when the aneurysm has a branch, there is no thrombosis formation. The whole flow entering the aneurysm is aspirated by the branch, and no flow stagnates along the aneurysmal wall. What's happened is that the wall falls down, which leads to its shrinking. This unique behavior keeps the branch patent. All the flow is directed to the branch. More the flow is moving toward the branch, more it creates a barrier between the aneurysmal wall. This is directed by the layers again. This is not possible by normal stent. So after this, we put the stent, the multi-layer stent, on pigs on the animals, and we found out that we were correct. As more layers we are putting, the aneurysm was cured in less time. So this is some of our images of the animals we used. And we decided to cure the first renal aneurysm in our hospital in Athens. So at the left, you see the first image with the aneurysm, and at the right, few minutes after placing the multi-layer stent. And again, the examination after 6 months where there is no anymore any aneurysm. So this is the first worldwide treated circular aneurysm of the right renal artery with branch. Again, we see the aneurysm disappeared, but the branch is still there. So we can cure the aneurysm and keep the collaterals wide open. This is the follow-up 30 months after. This is the second worldwide treated large calcified circular aneurysm. Of the left again, renal artery. And we see by the follow-up that where we are correct, the aneurysm disappear, keeping again the side branches wide open. So we go on, and we saw that in every aneurysm we use it was working. This is the third aneurysm we cured. This young patient had a transplantation to the left renal, and we treated the right by multi-layer stent. So after renal arteries, we went to other arteries. And this is, again, a popliteal aneurysm, which we use the multi-layer stent, and in more than 10 minutes, there is no aneurysm there. And we went to the iliac aneurysm. So the iliac arteries, again, we see that we can cure them by the multi-layer stent. To the mesenteric arteries, also we use it by good results. Then we went down to the abdominal aneurysm and thoracic, but I may say that we are not satisfied for this aneurysm. And we may say that it's suitable for renal and peripheral aneurysm, for cerebral aneurysm, and I may say that it's suitable for small aneurysm, for small arteries as renals, as mesenteric arteries. But if we go to larger arteries, abdominal or thoracic, we don't have so good results. I don't know why. We follow all the aneurysms for many years, and we see that the results for the abdominal aneurysm were not, didn't satisfy us. So we may say that it is only for the small arteries, not for large. Thank you very much.
Are we keeping this up here? Or? Yes, the next speaker also. Okay, cool. Thanks, Steve. So moving on to our next talk, current concepts in nephrology, by Associate Professor Evgenia Pedagogos, who is. What is that? Are we going 14? Or? Are we going? Okay, so we're going to go 14 first. Okay. Sorry. So we'll go in order. Sorry. From current concepts in obstetrics, gynecology, and IVF, commencing with Dr. Victoria Polidoro, who's a cardiologist herself with an area of expertise in fetal cardiology, having trained at King's College Hospital in the Fetal Medicine Institute in London. She's a lecturer at the European University of Cyprus and works as a consultant fetal cardiologist at Genesis Athens Clinic and REA Maternity Hospital in Athens, Greece. Her area of research is the maternal cardiovascular system and how it correlates with pregnancy complications. Thank you.
Good evening. I would like to thank the organising committee for the kind invitation. I am truly honoured to be here today, and thank you for the amazing hospitality. Today I'm going to talk about the management of mothers with anti-Ro antibodies from the fetal cardiac point of view. This is an area, a controversial area, and an area of continuing research. Anti-Ro antibodies are autoantibodies found mostly in patients with Sjogren's syndrome, lupus, and rheumatoid arthritis. 1 in 200 women, or 1 in 100 women of reproductive age have them, but 50% of them, interestingly, are asymptomatic. So complete congenital heart block, which is the main concern we have in the pregnancies of these women, are the first sign of presence of positive antibodies in many mothers. So why do anti-Ro antibodies concern the fetal cardiologist? Because these antibodies can cross the placenta from 16 weeks onwards and reach the fetal circulation. So these antibodies attack the AV node, causing inflammation and fibrosis of the atrioventricular node, leading to irreversible complete heart block. Also, lesser degrees of heart block are possible. Also, these antibodies can attack the myocardium and cause inflammation of the myocardium, leading to fibrosis and necrosis of the myocardium, known as endocardial fibroelastosis, leading to cardiomyopathy. What happens in a complete fetal heart block is that there's no electrical communication between the atria and the ventricles. So the electrical stimulus produced at our normal pacemaker in the right atrium cannot pass down to the ventricles in order for them to contract. So what happens is a secondary center within the ventricles takes over and produces the stimuli, the electrical stimuli, in order for the ventricles to contract. The problem is that this secondary center fires in a much lower rate than normal, so that means low heart rate for the fetus. But low heart rate in the fetus will lead to low systemic perfusion, and this will lead to hydrops fetalis due to heart failure, and finally at intrauterine death. There's a 2% incidence of complete heart block in the fetus of anti-Ro positive mothers, and this raises up to 20% if there's a previously affected pregnancy. So 1 in 20,000 live births has complete AV block. This has a high mortality, but it can be diagnosed prenatally using fetal echocardiogram. This usually happens between 18 and 26 weeks of gestation. So what we see on echo, I hope this plays. No, I don't need, I just wanted to play. Thank you. Nope. Oh, thank you. Thanks a lot. So what we see is a fetal heart beating in an abnormally slow heart rate. We can even see signs of heart failure, an enlarged heart, and a pericardial effusion. We use M mode to assess the rate of contraction of the atria and the rate of contraction of the ventricles and the relationship between them. Normally in sinus rhythm, every atrial contraction is followed by a ventricular contraction. But in complete heart block, every atrial contraction is not followed by a ventricular contraction. There is complete dissociation between atrial and ventricular contraction, and the ventricles are contracting in a much lower heart rate than the atria. Now, concerning treatment options and fetal heart block, when it comes to complete heart block, there is no treatment. This is an irreversible situation. Concerning lesser degrees of heart block, steroids, IV immunoglobulins, plasmapheresis are commonly tried therapies, but there are limited data and no randomized trials for the proposed treatments. Dexamethasone is reserved for fetuses with complete heart block and heart failure or hydrops to improve myocardial function and reduce hydrops, and in second-degree heart block in an attempt to convert to sinus rhythm, but this is not always possible. It happens in almost 25% of cases. Of course, we should consider side effects of steroids during pregnancy, and proposed benefits of therapy need to be balanced against the risk of side effects. Now, when it comes to complete fetal heart block, if there is no hydrops and the systolic ventricular function is good, what we do is monitor the fetal heart. Our aim is to balance the risk of intrauterine death and of preterm delivery such that delivery occurs at the most favorable time. Complete heart block is variably tolerated, and there's a poor prognosis in the presence of hydrops or preterm delivery. Other predictors of adverse outcome is ventricular heart rate below 55, endocardial fibroelastosis, myocardial dysfunction, hydrops, and an early diagnosis before 20 weeks of gestation. So lesser degrees of heart block can occur in anti-Ro positive pregnancies. First degree heart block has not been shown to progress or be predictive of higher degrees of heart block. In second degree AV block, corticosteroids have been associated with conversion back to sinus rhythm in some cases, 25% of them. Now, can fetal echo predict complete fetal AV block? The PRIDE study attempted to answer this question, and they concluded that no measures of fetal cardiac conduction predicted anti-Ro associated complete heart block. Another interesting study is that of Bettina Cuneo and her group. What they did, they performed monitoring of fetal heart rate by mothers twice daily between 16 and 26 weeks of gestation using a home Doppler monitor. This study confirmed the rapid progression of normal rhythm to AV block, and that there's a time window for treating second degree AV block, which is less than 24 hours. Another question is, how often should we follow up with fetal echoes, these fetuses of anti-Ro positive mothers? The American Heart Association recommends a weekly echocardiography from 26 to 28 weeks, which is the most vulnerable time frame for for complete fetal heart block, but its real utility is questionable. Fetal heart rate monitoring performed directly by mothers in the home context has been recently proposed. Now, in the absence of abnormal findings, a feasible approach would be monitoring the fetal heart rate once a week or every other week by the obstetrician, and perform fetal echocardiography 2 to 3 times between 18 and 30 weeks. Of course, if complete AV block is present, close follow-up by fetal cardiology specialist is required. Now, there is a study by Kaiser and his group that attempted to reduce the burden of surveillance in pregnant women with no history of fetal AV block using the negative predicted value of anti-Ro antibody titers. They concluded that there is a level of maternal anti-Ro antibodies below which the pregnancy, below which the pregnancy is at low risk of fetal AV block. So this study speculated that prospectively applying these data may avert the costly serial echoes currently recommended for all anti-Ro antibody positive pregnancies and guide future management. So the first two questions we've already answered. Can we predict complete AV block in the fetus? No. Can we treat it? No. It's an irreversible situation. Can we prevent it? Here we have good news coming from the PATCH trial. This was a prospective multi-center study. They administered hydroxychloroquine 400 milligrams daily in women positive for anti-Ro antibodies and previously affected pregnancy. And they found that hydroxychloroquine significantly reduces the recurrence of congenital heart block, of complete congenital heart block, suggesting that this drug should be prescribed for secondary prevention of fetal cardiac disease in anti-Ro exposed pregnancies. Hydroxychloroquine is an immunomodulatory drug compatible with pregnancy that decreases the pathologic effects of antibodies via inhibition of toll-like receptor signaling. So it can be used for the preventive treatment of pregnant women with previously affected pregnancy, and it should be initiated by completion of 10 weeks gestation. Now, coming to childbirth, what we aim at is maximize the gestational age to allow for fetal weight gain and reduce complications of prematurity. Delivery is usually planned at 37 weeks of gestation or later in the absence of complications by cesarean section in a tertiary center. We say cesarean section because fetal heart in a fetus with complete heart block will not change under stress, so we can't monitor if the fetus is struggling or not peripartum. Now, neonates are assessed with ECG and echocardiogram. A pacemaker during infancy is the case for the majority of cases, and a long-term follow-up both of cardiac rhythm and cardiac function is required as late cardiomyopathy has been described. So although complete fetal AV block in anti-Ro positive pregnancies is an uncommon complication, it has serious implications involving fetal or neonatal demise or lifelong pacemaker dependency. No therapy has been shown to reverse third-degree heart block. Positive women who are planning a pregnancy should be referred to a specialized fetal medicine center, and a multidisciplinary approach should be started. Home-handled Doppler daily screening for the early detection of congenital heart block may allow for early attempts at reversal, but large multi-center studies are needed to evaluate the feasibility and utility of this approach. Close follow-up from fetal heart specialists is required if complete fetal AV block is present, and hydroxychloroquine 400 milligrams daily could be used for secondary prevention. I thank you for your attention.
Moving on to our next talk. What Next in IVF by Dr. Nick Lolatis from the IVF Specialist Centre for Infertility Solutions, who's been an obstetrician and gynecologist for 40 years now. Please make him welcome.
Look, thank you very much, and thank you for the organising committee to invite me. And I was very interested in Victoria's speech talk because in my IVF practice I use Plaquenil all the time, and I'll go into that in a moment. Sorry. I do a lot of immunotherapy in my practice, and I'm attacked for it constantly. However, I believe the immune system plays a major role in infertility. And I published this, it was an abstract, but it showed that if you suppress the immune system, if the patient has elevated natural killer cells, either in the blood or in the uterine lining, you can increase the pregnancy rate. My vision is to fully investigate patients before we start any IVF treatment, because mainly that's what I specialise in, patients with primary or secondary infertility or failed IVF cycles, and they come to me for a second opinion. And I believe they all should be thoroughly investigated before they start IVF, and this doesn't happen, unfortunately, and I have lots of patients who have multiple cycles. It costs them a lot of money. They come along to see me, I investigate them, I work out the problem, they get pregnant straight away, and they're very angry, and they don't know why they haven't been investigated. And in some cases where they've had multiple frozen embryo transfers in natural or medicated cycles, maybe the window of implantation is incorrect. So we have to determine that, and there's this test out of Spain, now Japan, where you can look at the window of implantation in patients. So in summary, all patients are fully investigated. I look at every aspect of their IVF journey. I wait for the results before I start treatment. I'm very patient, and as you know, most patients aren't very patient, and they want it done yesterday. My investigations are pretty thorough. I look at the immune status, their karyotypes, thrombophilia screen, diabetic screening, thyroid function tests. I do an endometrial biopsy for natural killer cell assessment, and I look for tissue compatibility. In America in 1995, a book was written, Is My Body Baby Friendly? By a man called Beer. He's dead now, but he looked into tissue compatibility. Do these patients, these infertile patients, share a certain gene? And he focused on a gene called the DQ alpha gene, which is found on chromosome 6. And I look at the DQ alpha gene compatibility, and I set up a service. There's only two in Australia, one in New South Wales and one here in Melbourne, mine, where we can treat tissue compatibility by a process called lymphocyte immunotherapy. I'll go back to that in a moment, but they get thoroughly investigated, and sometimes it involves looking at the sperm DNA fragmentation, because we have to remember that the man plays a significant role in some of these infertility situations. It's very personalised and precise when I finally determine what we're going to do, and I look at the produce, the egg quality, the sperm quality, how good is the embryo, and we can test now for gene defects, for the chromosomes. So embryo biopsy is very important, and then we look at the oven. Is the uterine anatomy good? Can we improve implantation by scratching the lining of the uterus or injecting HCG or filgrastim, which is a drug that proliferates the endometrium? And then we have surgery for the ERA test and for natural killer cells. The immune system problems. When an embryo goes into the uterus, it sends a message to the host. Please look after me, I'm different. And the host makes antibodies to protect the T-regulator cells to protect the embryo. And in plants, we have a baby. If there is tissue compatibility between the mother and her partner, When that embryo sends the message, HLA-G, to the host, please look after me, I'm different, the host sees self in the embryo and not self, and it doesn't protect the embryo, and it gets attacked by the patient's immune system. And that is one of the big problems causing recurrent pregnancy loss and recurrent implantation failure. So we have two parts to the immune system, as you all know, and we have Th1 and Th2 cells, and that plays a major role in infertility. And when I started doing this some 13 years ago, I was a bit sceptical, trepidation. I was setting up a new clinic, and it's not a cheap treatment, but I have been inundated with patients from around Australia to have this treatment, and they get pregnant. So I won't spend too much time on the T helper cells, but basically they have to be in the right combination. But the tissue compatibility is the thing that is so important for my fertility patients. And when they come to see me and I do this test and they get an answer to their infertility, they are very happy and they're very keen to proceed to treatment. And the treatment is the following. You can change the sperm. Not many people want to do that. You can put your name down on the list for a donor embryo, but that's a 3 to 6 year wait time. Or you can put the embryo into a surrogate. Now in Australia it is very difficult to get surrogates, and I had been sending patients to Crete for a while, but now I'm going to be sending them to Kostas Pantos in Athens because they've changed the rules there a little bit, so it'll be a lot easier. But it is very difficult to find a surrogate here in Australia unless they're a relative or a close friend. So for most of these patients, they undergo lymphocyte membrane immunotherapy. So this is 2 injections 4 weeks apart and lasts for 6 months. The blood from the husband is taken, the white cells are retrieved, the membrane of the white cell, which has a protein CD200, which is temperature sensitive, is isolated. And in the afternoon, the partner, the wife, comes in and we inject that CD200 protein into her skin. It gets taken up by dendritic cells back into the immune system, stimulating her to make specialised cells to protect the embryo and antibodies. It lasts 6 months, and if the patient happens to conceive after her consultation, because a lot of these women have had recurrent pregnancy loss, they get injected with the blood during the pregnancy. But that's only half of the treatment. You have to suppress the immune system as well, otherwise the embryo can still be attacked. So that's a summary of the tissue compatibility, but the immune system is not suppressed and has to be looked at. I've just described that process, but I use the following drugs to suppress the immune system, and all my patients get dexamethasone, aspirin, Clexane, intralipid. If it's a complete match, they all get IVIG, which is very expensive. 5 grams is $470 and 10 grams is $940, and some of these patients need 30 grams or 35 or 40. Humira, which is a TNA medication. Tacrolimus, which is used in organ transplants. I now use it prior to the transfer of an embryo. Naltrexone and Plaquenil, which are immunomodulators, and they all need a little bit of progesterone support. So for people with thyroid antibodies or anti-Ro antibodies or antibodies that exist without there being a cause for it, there's no diagnosis made. Patients with elevated natural killer cells, tissue compatibility, and blood clotting problems are all included in this treatment schedule. So to suppress the immune system, I use the steroids, dexamethasone, up to 4 milligrams, intralipid, which is a fat emulsion and has very good immune suppression qualities, and IVIG, which is fantastic, but it's very expensive. And the other immune therapies are the LMIT, and as I've mentioned before, I use Plaquenil. And the problem with Plaquenil in Australia was that when Trump said it cured COVID, they put a ban on who could prescribe it. So now I have to send patients to an immunologist or rheumatologist or a hematologist to get the Plaquenil prescribed. And Humira is also expensive. The other things that I do is that I try and improve egg quality and the lining of the uterus by using stem cells. Patients give their blood, the stem cells are isolated. I have a lab that does this for me. And then I have an interventional radiologist who cannulates the femoral artery and deposits the stem cells in the uterine arteries or the ovarian arteries, depending on what I want to do. So for the ovarian rejuvenation, it's called SCORE, and for the lining, it's called SCOOP. And the other two treatments that are available now for endometriosis is a nasal spray, and also a lot of my patients end up having to have the window of implantation defined. Just a little thing on infralipid and what it does. And the same with immunoglobulin. It's very, very good. The pregnancy rates when I use immunoglobulin are fantastic, but it's very expensive and a lot of patients can't afford it. So the adjuvant therapies improve egg quality, improve lining thickness, and suppress the immune system. I've just listed all the drugs that I use again, just for completeness. But these are adjuvant therapies to try and improve egg quality. I don't think very many of them work, but nevertheless patients always ask. And the ones that I give routinely are melatonin and L-arginine. I think they're probably the best. And they're the other adjuvant therapies that I do now. Polycystic ovarian syndrome, we used to laparoscopically drill out the small follicles, but now we use metformin, so I don't do that very much. Platelet-rich plasma is something that I now inject into the ovaries laparoscopically, and that restores periods, and I've had a few pregnancies from that. But the main treatment for patients of an older age who are struggling with their egg quality is to move on to donor eggs. I send about 100 patients to Costas every year for donor oocytes with a 60 to 70% pregnancy rate, and they often come back, well, very, very happy and very excited. Other drugs that I use, Viagra should be given orally because there are no receptors in the vagina for it. Trental to improve blood flow, Nitrodor, and filgrastim, which is a cytokine which, when you place it into the uterus, proliferates the endometrium and you can get a nice thick lining. And all my patients get filgrastim injected into their subcutaneous tissue an hour before the transfer. So these orphan drugs were obviously designed for treating other conditions, but I use them in an IVF setting, and all my patients get investigated, and a large number, about 60 to 70%, have got either antibodies or elevated natural killer cells. So virtually all my patients are on some form of immune suppression therapy. Just a list of all the drugs. Thank you very much.
I'd like to welcome back to the podium Dr. Bandos to speak to us about accessing IVF technologies in 2022.
Thank you once again. I'm just going to talk about our experience in Greece. how people access IVF. We know that in the era of globalization, cross-border movement is an inevitable fact, and IVF seems to be the leading service towards this. And spearheaded and attracting couples from abroad seems to be assisted reproduction, as couples will readily seek otherwise solutions to their reproductive issues, contributing to what we say about cross-border care. We now seem to witness also a woman aged over 40 being worldwide the most rapidly growing age category, having children. It's not surprising that the patient populations in IVF centers are aging in parallel, further driven by the fact that young and uncomplicated IVF patients now conceive rapidly, while older and more difficult patients require more attempts and accumulate. It's now possible for women of any age to give birth to children, taking into account, of course, the legalities of each country. Loss of ovarian reserve and poor performance with stimulation protocols, however, make these women the most difficult to treat, and one of the ways to treat them is PRP that Dr. Lola just mentioned. Many couples seek otherwise solutions to reproductive issues that cannot be solved in their countries of residence. The reasons for this is IVF failures in their own countries and or legal restrictions. These restrictions vary between countries. In some countries, surrogacy is forbidden. In others, sperm donation is allowed, but also oocyte donation is not. In others, like Australia, only known donors are used, with access of children born to donor identification files, while in Greece, and in accordance to the recent law, gamete donation is allowed both unknown and known, according to the wishes of the couples. The age limit in Greece has gone up to 54 years of age, and the law now is more liberal in many other aspects. And one may ask why IVF in Greece? Expertise, financial reasons, 4 to 5 times lower cost than the United States, more liberal legislation in Greece in comparison to other countries, and also a favorable holiday destination. For the progress done in IVF to create a destination for medical tourism, the constituents of success seem to be scientific research, good clinical practice, and business. Elaborating on each of these, for example, our recent research work on the rejuvenation of the ovary using autologous platelet-rich plasma injection in menopausal women gave the opportunity for older-aged women to extend their fertility potential. This was published in the New Scientist, and through this coverage, Greece was in the headlines of the English press, and as a result, we were overwhelmed by English women seeking PRP. On the clinical practice, we have commitment to improve quality and efficiency of IVF, as indications now tend to cover every possible cause of infertility. And among our achievements is our early application of blastocyst biopsy, which led to many successes. 17 years ago, we applied the first blastocyst biopsy for the diagnosis of beta thalassemia. This led to the first published report on such live birth. Furthermore, we applied for the first time in Greece pre-implantation genetic testing with simultaneous analysis of histocompatibility in 2005 in order to save a child suffering from chronic granulomatosis disease. And this was published as the world's first. It drew a lot of attention. In Greece, it was realized that IVF technology can also save lives and heal sick children from fertile couples. Were selected in a randomized multinational proof of principle trial from ASHRA in 11, and in collaboration with Alan Trounston from Monash Uni over 15 years ago, for the first time we investigated and identified a genetic profile of embryos associated with implantation and success of IVF. The results of this was published in Human Reproduction, drawing significant media attention with over 92 media citations around the world, including this Reuters report. So why am I showing you this? Because scientific inquiry in a clinical application is an all too important tool to gain the required trust in order to attract couples both domestic and abroad. The last of the constituents necessary for the promotion of cross-border care is the business aspect, where agreements and partnerships between health professionals from different countries facilitate cross-border movements. And of course, great importance are education programs. How do we promote cross-border IVF access? It seems that the most successful way of promotion is still word of mouth, and this has a direct relationship with the positive results of IVF unit. Other ways is to promote is the announcement of new scientific achievements, research, clinical applications, world's first, advertising of medical services, international publications, and personal testimonies of couples. So following this, I will give you some examples. CNN report on the birth of a healthy child after pre-implantation genetic diagnosis for a couple living in northern Greece who carried the mutated gene for Leber congenital amaurosis, which causes blindness, or who already had 2 blind children. Major impact on couples. Decisions seem to be treated elsewhere seems to come from personal statements, like this one from the famous comedian Mary Kustas, upon collaboration with Dr. Lologis, or the famous star Tanya Zaeta, who revealed her twin pregnancy. As you can see from this front page article in the Sydney Morning Herald, the success carries lots of sentimental value, as well as this full-page Romanian article on a success story from a couple from Romania with Parthenon on the background. Other examples of our successes can be seen in these children from the United States in a recent conference organized by the Central Union of Municipalities of Greece, KEDE, and the Federation of the Hellenic Societies of New York. The newspaper of the expatriates in Melbourne, New World, Neos Cosmos, entitled Comprehensive Greek Perspective, refers to a case of a patient from Australia who after 2 liver transplants and over a decade of failed attempts, finally managed to have her children. She had her first child a few years ago. Now she's pregnant again, followed by Dr. Nicolologis. Or even the recent case of a grandmother surrogate who gave birth to a grandchild at the age of 67 and was reported in international press as the heroic grandmother. Of paramount importance is proper education for health professionals in the field of infertility. So a first for Greece was the affiliation in 2013 of the University of Athens with the Genesis private clinic in providing educational opportunity on reproduction by e-learning program. The aim to enhance knowledge, to further stimulate research, provide work experience and employment opportunities for new professionals. Moreover, the opportunities arising from these activities can be summarized in these pictures showing the inauguration of a new fertility center in Bucharest 6 years ago, and it's already the #1 in Romania. Or the signing of an agreement with Anhui University in China for the mutual development of IVF centers. The goal of our country is to claim a respectable share in international medical tourism. To achieve this goal, we need further to promote our country. The Greek diaspora has the power to act as a catalyst. Priority is the strengthening of the relations of the diaspora by aiming at the communities abroad and bringing doctors closer in touch. By bringing together all Greek medical societies around the world, we can exchange information regarding medical centers of excellence in their own countries and elsewhere, where the doctors reside, help couples obtain the best possible medical advice and treatment in any of these countries. The expatriates need to know the current medical options, successes, ease of communication, social networking due to language, for the management of health problems, the direct benefits, legal, procedural, and the possibility of combining tourism at their home country or elsewhere where Greek medical societies thrive. By linking the Greek medical societies, we do make all these possible. Our physicians abroad should be aware of the provision of health services in Greece and elsewhere, at least as good as the country they reside in. The certification systems and the great innovations in clinical laboratory medicine do involve Greek doctors, as for example, renowned necrologists in Australia, and this information has to be shared in our medical societies both in Greece and abroad. We should exploit historical sites in Greece as Homeric Ithaca for symbolic reasons, where medical tourism seeks its roots, as Ulysses once did seek in his homeland. Cross-border phenomenon is now well entrenched. This can even be more augmented by enhancing partnerships between countries and interlinking Greek medical societies. So what needs to be further done? Raise public awareness, recognition of medical options in countries according to excellence in specific fields, recognition of tourism attractions, and recognizing the creative opportunity in joint operation and performance. So the proposal for joint action between medical societies could be to organize scientific social meetings for the diaspora in major world cities with participation of church, embassies, prominent members of the diaspora, relevant ministries, patient successors willing to share experience. We are among a few countries to have Greek medical associations in major capitals around the world. In other words, we have a world network of Greek physicians ready to provide reliable synergies and beneficial cooperation, and why not business perspectives. Making a difference, it's all about recognizing creative opportunity, explaining that now exists, explaining the benefits, challenging long-held dogma about the poor performance potential of Greece, as we know in the past, that frustrated generations of Greeks in the diaspora. And it's a step that can turn an idea into a reality. Thank you very much.
Thank you very much, Dr. Pandos. How's everyone feeling? Can we power through 4 more? Because then we can finish. The ball starts. I think if we do 10 minutes, alrighty. Then it gives me great pleasure then to invite Associate Professor Juniper Dagos to the lectern. Thank you, and looking forward to this one.
So thanks very much for asking me to speak. I will power through my slides. I hope you can hear me. Basically, that's a little organoid of a kidney. It's not just a pretty picture. That's at 24 days. So there is a lot of work going on in trying to create organs, but we're not there yet. So what can we do in the interim? How do you press that way? Perfect. I'm not going to acknowledge country. Why chronic kidney disease? Well, basically, it's a killer. It's asymptomatic in a large proportion of patients. It causes our patients morbidity. It actually costs a truckload of money. And if you look at the international prevalence, about 10 to 13% of patients have chronic kidney disease, or the population, I should say, in the world. This is Australian data, 1 in 10 Australians, but you can extrapolate it. So we know that it's underdiagnosed. It's not actually found. And despite my attempts and my colleagues to actually inform people about chronic kidney disease, you know, it's still disappointing to see that even when it's presented here today, that kidney disease didn't get a mention in the chronic disease diseases slide that was put up in the lifestyle section. So it is unfortunate, but despite our best attempts, not many people recognise it. We've got Australian data. About 25% of general practices will actually acknowledge that patients have chronic kidney disease. You trawl through the data, you look at the GFR, the ACR, and 25% of the time it's picked up. The patients don't know about it by the time they get to me, which is way too late. So I think there's a lot of opportunities here for improvement. And you may say, well, why did we bother about it? Well, we know diabetes is a big killer, and Spiros did an excellent job of actually saying, you know, diabetes is a growing epidemic, just like obesity is. And chronic kidney disease, yeah, about 36% of patients, it's due to diabetic kidney disease. However, that actually in an entity in itself is actually changing, and there's been a lot of developments over the last few years. So what was pure diabetic nephropathy is now more, there's about a 30% cohort that probably have microvascular disease rather than true diabetic glomerulosclerosis. But you can see that there are other causes, and the glomerulonephritis are really prominent here. And we know there are risk factors. There are, if you can remember this is the most important part of the speech. When you do your risk profile for your patients that you see, any risk factors for cardiovascular disease, exactly the same for CKD. So as I said, it's asymptomatic, but it should not be forgotten. Things that we can modify, lifestyle factors, which I'm not going to talk about today, medications that we've got that we can give which are not used to the extent that they should be, and things we can't alter, such as our genetics, etc. So when it comes to CKD, and this is the algorithm, and I'm sorry that it's actually in this colour scheme, for some reason it's changed it on this slide, but if you actually look at the different things that we look for, you have to understand that CKD is made with a diagnosis of 2 parameters and over a 3-month period. So I'm simplifying this. It's called the eGFR, which is an estimate of your glomerular filtration rate, and your urinary albumin-creatinine ratio. Why were those 2 things picked? Because they're strong, independent predictors for progression of kidney disease, end-stage renal failure, and death. So they've combined them, they've produced an algorithm, and the areas that are in blue are actually the red areas. The bits in the middle, so it's red, yellow, and green, and unfortunately it's not displayed there as it should be. There it is, that's a better representation, so it's done something really weird here today. So, as I said, we've become more aware that when you have chronic kidney disease, you have cardiovascular disease. And in fact, our patients with chronic kidney disease have an escalated profile of cardiovascular disease. We have severe calcification because there are changes in the actual walls of the vessels where the cells become osteoblasts, the myocytes. So it's actually a very difficult entity to treat. And, you know, I asked George Promos, who gave the talk this morning, what about the TAVI patients? Have they done any? And looking at the kidney, the CKD categories, and he didn't have any information because they're really avoided by doctors because they have poor outcomes. Cardiorenal syndrome is really something that's come to have a lot of traction over the last 5 or so years. I'm not going to go through the details, but it's interesting, and I think if you haven't heard of it, please look at it. So the only proven treatment we had for the last 20 years as a nephrologist, and I've got John Katsoulis who will speak after me, is the ACE inhibitor angiotensin receptor blocker group. 20 years drought, that's all we had. And despite that, even in the US, only about 1/3 of the practitioners give ACE inhibitors or angiotensin receptor blockers for chronic kidney disease, even though it's a proven therapy for delaying the progression of CKD. And you can see here from the renal and IDNT studies that were done in diabetic patients that indeed there was a reduction in the risk of progressing with end-stage renal failure by about 20% in the IDNT and a similar sort of percentage, about 17% in the renal study. And ACE inhibitors and angiotensin receptor blockers work on the efferent arteriole. I'm just putting the schema there, I'm not going to go through physiology. And then a plethora of kidney trials occurred, and they've all gone by the wayside because they found that actually these studies weren't actually beneficial to patients. In fact, they harmed them. So drug companies didn't want to know about us for a lot of years. Recently, this class of agents, which was originally a drug that Spiros used for his diabetic patients, came to the fore. And sodium glucose transport inhibitors are sort of the new kid on the block over the last sort of, if you like, few years. And I can tell you they've got a number of different effects. They affect the body, the way your energy metabolism is dealt with. And there are receptors in various organs and also in cancer cells. And when you look at this timeline, it's taken a long time. And the FDA originally looked at these drugs and said, you know what, we don't care about the fact that it just lowers the glucose. Show us some hard evidence. So mortality was looked at and the cardiovascular outcome trials came out, and this has occurred over a period of time from 2005 to 2020, multiple trials looking at cardiovascular endpoints. And they found in those studies that, guess what? There was something going on. There was a signal with the kidneys. So although they were improving the mortality of patients with cardiovascular disease, there was a signal that the kidneys were actually potentially benefiting. And I'm proud to say that the first study that was created for the SGLT2 inhibitors in CKD was from the George Institute in New South Wales, where our nephrology colleagues created the Credence trial. And this was a study done in approximately 4,500 patients with type 2 diabetes and chronic kidney disease. And they followed these patients over a period of an average of 2.4 years. First time ever that you had a nephrology trial prematurely terminated due to efficacy, ever, in all the literature. right? Now, look at the lines, they cross over. So there was like a standing ovation for this, a significant improvement in patients' primary outcome, which was kidney failure, serum creatinine doubling, kidney or cardiovascular deaths. This is like groundbreaking stuff. And when they looked at these parameters, they actually looked at all these different parameters. As you can see, the forest plot is quite indicative. It favours the drug, which was in this case canagliflozin. Now, the company tried to get it on PBS. They weren't successful. They walked. Along came DAPA-CKD, which was the evolution of this data. So people wanted to know in the nephrological community and in the wider community, okay, these drugs seem to have a role in diabetic kidney disease. What about patients with chronic kidney disease that don't have diabetes? This was another company. They used the drug dapagliflozin, which was basically another group of individuals, 4,500 again, multi-centre study, placebo, randomised controlled trial, 10 milligrams of DAPA a day versus placebo. Followed them again. Guess what? Had to be prematurely terminated because the Data Safety Monitoring Board said it's efficacious. You're helping these patients. You can't continue. I'm sorry, Tom, but this is important data, so I'm going to keep going. Primary and secondary outcomes, as you can see, splaying of the graphs, 39% reduction in the primary outcome. All secondary outcomes, all-cause mortality, the kidney outcome, cardiovascular death and heart failure hospitalisation, significant improvements by 30%. Met all its primary and secondary outcomes. Safety profile, fantastic. It didn't matter if you sliced or diced it versus diabetics versus non-diabetics. Diabetics on the left, on your left and my right, and the non-diabetics on the other side, the effect was still there. And whether you had established cardiovascular disease or not, it didn't matter. So all these parameters were looked at, including the EGFR categories and the degree of albuminuria. And you can see from the forest plot, everything favours the drug because it's on the left of the line. So now it's got PBS listing in this country. It's got a streamlined code, thank God, and it's joined the diabetes indication in this country as well as the heart failure code for reduced ejection fraction. Watch out because the preserved ejection fraction will come soon because the data's come out in the last few years. And in fact, it's a very exciting time for medicine. Really exciting time. Now, this is the groundbreaking trial that's come, the third trial, again a kidney trial, looking at empagliflozin in chronic kidney disease patients, published in the New England Journal this month, and basically, again, prematurely terminated due to efficacy. Now, this cohort looked at a lower level of EGFR, even patients without microalbuminuria, and they basically found that the drug was still efficacious. This is the design. Primary outcome was cardiovascular death and progression of end-stage renal failure, and there were a number of secondary outcomes. Now, when you look at it, this is the primary outcome component, and from your side on the left, you can see the kidney disease progression. The graph's displayed, hazard ratio of 0.72. On the side here, 0.84, the hazard ratio for cardiovascular death, not many events. Only 27% of the cohort here had established cardiovascular disease at the time that they were put into the trial, as opposed to the previous study, which had 37% of patients with established CVD. And we know if you've got established CVD that you have a higher rate of having events. The efficacy results are pictorially represented here, and unlike the DAPA-CKD study, all-cause mortality was not reduced here, and they didn't have a reduction in heart failure hospitalisation. So there is something slightly different going on, and people are now analysing the various subgroups of the data. But as you can see from this, which shows the colours, I don't know why this slide come up with the colours, but it did. The beauty of it is the three different trials have looked at the red zone because that's where the money is in terms of trying to help our patients. Lancet meta-analysis published a week ago looked at all these studies, the cardiovascular outcome trials, all the CKD studies, over 90,000 patients, and they basically came up with all these gorgeous forest plots which show that, yes, these drugs, in fact, are helping our patients. They're helping them not die, they're helping reduce heart failure hospitalisations, they're helping the progression of kidney disease, they're actually very beneficial with no side effects of any concern. The only thing that they didn't find was that the all-cause mortality wasn't reduced, as opposed to what happened in the DAPA-CKD study. Now, all meta-analyses have limitations, and you can imagine, the signals are strong when it comes to the outcomes. So it's really important to highlight that. So I can't stop here because I need to tell you it's not just the SGLT2 inhibitors that have been shown to be beneficial in chronic kidney disease. This is, if you like, we've gone from years of hyperfiltration being the only sort of pathogenesis of CKD to looking, as Professor Apostolopoulos said, multiple pathways. I could show you pathways that would make your mind blow because everyone has been discovering new pathways, new receptors, new opportunities to develop medication to actually help our patients. And in diabetic kidney disease, that's where it starts first and then it goes into the other areas. So MRAs, or mineralocorticoid antagonists, and Spiractin was the one we've had for many years, and Anna Chrysostomou and myself, we did the first study that was sort of published, a small RCT at the Royal Melbourne Hospital many years ago, and it's the first, you can't see it, but it's the first study up there, which showed a significant reduction in albuminuria. However, we didn't have data about death, kidney failure, or any cardiovascular events until we actually started looking. So these non-selective MRAs, which is what I'm talking about with Spiractin, there are side effects. And if you give them, men can get gynecomastia, women say their breasts grow as well. Hyperkalemia is a big problem. Finerenone is one of these new selective non-steroidal MRAs, and it's been developed and used in trials with diabetic patients. And it has significant antifibrotic and anti-inflammatory effects. And I've just put some of the cells there in the kidney as well as in the heart. So this is actually the drug that we're talking about. You can't see the studies that are put up there, but there are studies that have been done preceding the Fidelio and the Figaro studies, and this is the Fidelity pooled analysis that was published this year, again looking at all the parameters and in fact substantiating the claim that again they had a reduction in cardiovascular death. Now what I need to tell you is these studies are done on standard of care that's already there. ACE and ARBs, so you're adding therapies to these patients. And I think that's a really important point. And we know that there's a trial at the moment which we're all participating in called the FIND CKD study because that was in a diabetic population. This is a non-diabetic population. So this will take a few years for this data to come out. And finally, endothelin antagonists, which are another pathway that have been targeted, and there are ongoing studies with this, and endothelin's very much involved in CVD as well as in kidney disease. And this is the SONA trial that happened in diabetic CKD that showed a significant reduction in albuminuria and safety of the drug. And now there's this drug called atrasentan that's been developed by a Canadian group, and there's studies looking at various forms of glomerulonephritis as well as CKD. And finally, it's my last slide, GLP-1 receptor agonist, because I'm asked all the time, well, okay, you've got diabetic kidney disease, you're using an SGLT2 inhibitor, finerenone, which is not PBS listed yet, they've tried but haven't got it. What about GLP-1 receptor agonists? Well, the data is not here. All we've got is that it reduces albuminuria, macroalbuminuria, and it reduces your progression from micro to macroalbuminuria. So as far as end-stage renal failure progression and cardiovascular death, there is no data for this. So finally, SGLT2 inhibitors on top of an ACE and ARB, finerenone when we get it, if the FIND CKD is positive. Yes, in diabetics, already the Fidelio data's out, and watch the space for endothelin antagonists. Thank you.
Thank you very much, and sorry we couldn't give that talk the time that it deserved. We'll move on to the management of hypertension with Dr. John Katsoulis, who was actually my consultant when I was an intern, first year out. Thanks, George.
Thank you. Where's our screen? Okay. Right here, thank you. Jeannie, thank you very much for that. You mentioned MRAs, so I'm going to fly through this because that's one of the 2 points. Hypertension, I'm going on WHO data, but you can just look up any country, big problem. Even in the US, basically 1 in 3 patients, or 1 in 3 adults are now said to be hypertensive merely by moving the goalposts for the latest guidelines. So there's a number of guidelines, and these are just a handful. and there's been a lot said about the differences and why 140 over 90, 130 over 90, etc., etc. But I think we need to look at commonalities with all these guidelines. Everyone agrees that blood pressure has to be measured accurately. Out-of-office blood pressures are here to stay. That's the standard. We all know the problems about office blood pressures. There are various methods, manual, the machine ones, which use oscillometry, and I'll talk about another at the end. We've talked about pharmacological changes. Again, cardiovascular disease risk is intimately tied in with chronic kidney disease. So this is the second plug apparently for the day for CKD. Drug therapy, everyone agrees, needs to be at blood pressures of 140 over 90, and despite the disagreements between each of the guidelines, I think lower targets according to specific needs can be sought out. And again, we need to treat all the other cardiovascular risk factors. Many physiological pathways, renin-angiotensin, aldosterone system, and I'll mention a bit more about aldosterone. Aldosterone levels can be elevated, even rising within normal levels to as our BMI rises. Endothelial cell dysfunction, lots of vascular reactivity. We see that in chronic kidney disease. It's a very pro-inflammatory state, a very pro-thrombotic state, a pro-atherogenic state, lots of metastatic calcification. So we're really buffing around at the edges very often when we see these patients too late. And white coat hypertension, that we all know, is a very real phenomenon. Now, I'll move to home blood pressure monitoring. There's undisputed data now. It does correlate with cardiovascular events. It can help in the diagnosis of white coat hypertension, and does correlate with quite a few end organ defects, especially proteinuria, albuminuria, which in nephrology we use as a marker of established damage, which we need to try and limit. And again, people who don't overdo home blood pressure measurements, but do it quite regularly, seem to be better, have blood pressure control because of compliance. Now, I follow a nephrologist from Scripps, and I've pinched his couple of his summary things, but these are several meta-analyses that show the benefits of blood pressure control. So it will reduce incidence of heart failure, stroke, coronary artery disease. It apparently, and I think we all agree that blood pressure control in end-stage renal disease, it's yet one of these many, many, many trials that have been negative. So we had this 20-year gap between IDNT and Renal until now. Ideal blood pressures of about 130 over 130 millimeters of mercury systolic. Moving to another one, even for people without cardiovascular disease and higher blood pressure, again, there are clear benefits in another further meta-analysis. And a third one, even though the numbers may differ, again, benefits in death, stroke, and all other cardiovascular events. Now, aldosterone levels, they can be high as high as 10% of hypertensives. We find that they're elevated, and we're not really talking about Conn syndromes levels, that type of thing, but they're definitely elevated, and we do see them in about 1 in 5 of resistant hypertension. Not everyone has hyperkalemia, maybe 1 in 3, maybe less, and there are other associations such as with sleep apnea, association with obesity that I've mentioned. And so what I would advocate is a greater use of aldosterone to renin ratio as a screening marker. Now, you've got to be aware of volume, so dehydration, thiazides may actually skew the results. But the way I look at ARR is that even if you're on something which may raise your renin, should you get a significant aldosterone to renin ratio, I think of it as a rule in to investigate further for hypertension, whether that's an adrenal imaging or the like. And the benefits of the MRAs have been overlooked, which was a good seg into from what Jeannie said. So again, other lifestyle things, very quickly, diet, weight loss, salt restriction. Potassium can actually lower your blood pressure, and of course we all are aware of the hyperkalemia effects in chronic kidney disease, but it is a vasodilator. It can produce diuresis, probably because it just releases more sodium into the urine, and has other anti-inflammatory effects that might be urinoprotective. Alcohol and exercise. Now, drug effectiveness. Slides are a bit small, but in one sense, you might think this is disappointing. You use monotherapy, you usually will get about an average of 7 millimeters mercury reduction in systolic blood pressure, maybe 10. You add a second one, the effect is less. You add a third one, the effect is less. Adding an MRA has a much more dramatic effect, and I'm not suggesting it's first line, but can be second, third line for appropriate patients. Another 10 millimeters mercury reduction. Just several days ago, a phase 2 trial, and I had to really look up the name. I can't see it here. Baxdrostat. That actually works differently. That actually inhibits aldosterone synthase. Now, aldosterone synthase is very homologous, extremely homologous to 11-beta hydroxylase, which of course is used in the pathway to produce cortisol, but it seems to be very selective to this without affecting cortisol levels, and that needs a phase 3 study to look at the effects. Diuretics, combination therapies, the timing even, a lot of us are preferring more nocturnal timing for antihypertensives. Again, hard data still to come by, but it's getting there. Now, just to look, with COVID and with telehealth and everything like that, office versus ambulatory blood pressures and the whole dichotomy, but also what is another method? So the endocrinologists do not have the monopoly on blood sort of monitoring, so we've got one, several devices, but this is one case I was peripherally involved in, which is an obstetric patient who had bad hypertension with lots of considerations about even PHEOs and the like. But when the whole confluence of telehealth, the pandemic, electronic health records, having devices, the connectivity, can produce a subject like this. And this is a thing, an Israeli invention. It's a patch and a sensor. The patch, the sensor is reusable. The patch goes on for about 24 hours, and it transmits the data by Bluetooth. And it uses a technique called photoplethysmography, which has been around 80 years odd. And it uses light of various wavelengths. So different wavelengths, they'll penetrate the skin, maybe 3 millimeters, in some cases 1 millimeter in the near infrared spectrum. And they measure two things. They measure the pulsativity, from which an analysis can be done beyond that. And they also measure a blood flow. So the signal that comes back is a big jumble of data that is influenced by pulsatility for the blood and the blood volume. And various signals analyses have been put forward to actually try to make some sense of this. So I'll just get my... So if we have a look at the curve here, it won't project on this, sorry. The first curve here, this gradient here, seems to be, this TT seems to be very, very correlative to blood pressure. And if you integrate that, and you get all these different curves, and this area here seems to be also integrating. This can also be matched up with ECG, ballistocardiograms, where this is actually your skin pulsations when, so you can actually, you don't need a touch technique, and various other PPGs, whether it's proximal or distal, and again matched up to a phonocardiogram as well. So putting this all together, that shows the pulsation time and the transit time, just the difference according to the ECG. And putting it all together, it can give you various curves. And what the signal analysis will do is it will use various filters. And the Chebyshev filter happens to be a good one here. I thought the other one, the Butterworth filter, was very familiar. So I looked up my digital amplifier, and guess what? That's what it uses as a low-pass filter to go to the subwoofer. But it's actually not good for this one, because you want a smoother one to spread the sound on, but you want a better one here to get the dichotic notch, which then is used as the basis for the measurements. So you come up with stages like this, where you've got your acceleration times and your transit times, and then the whole algorithm then works out your blood pressure. How effective is this? So this is a study that came out maybe 3 or 4 months ago. Now this was partially funded by the makers of this one, so there's this proviso there, but it seems to be very good with fantastic p-values for both males and females, and there's other data for skin colour and ethnicities, etc. in that. So It does use proprietary algorithms, but it's yet another technique. A couple of people at the Austin are using this. I don't recall the name, George is in here, but a couple of the cardiologists are beginning to study this, but it is another way of actually getting more real-time measurements and gets over some of the problems with the cuff measurements and possible inaccuracies there. Thank you.
Thank you very much. Have we got Professor Veragas' slides ready? We do, okay. Next, can I please invite Professor George Veragas, Head of Dermatology, Royal Melbourne Hospital, for his talk on changing dermatology and new medicines. Thank you.
Thank you, and thanks to the organisers. Thank you, Marinas. I'm very proud to be here amongst all the speakers and our colleagues from Greece. I'll go quickly. I'm talking about dermatology, what's happened in the last 20 years. I've been in it for 40 years, and it's just an amazing change. What we've had in the past, if I can have a microphone, we've had changes in the first 20 years. The topicals changed, UV light came in, and immunosuppression came into our practices. And surgery was changing with microscopic surgery. But what I want to say, what's happened this century is the biologics, number one. They have changed our patients. Their life has changed, their mornings have changed, their depression has changed. It's a real life changer. Chronic inflammatory disease is in our practices, and it's what you're talking about with kidney and diabetes and cancer, and it all starts with inflammation. So the biologics, was it pharmaceuticals? No, it was research and basic bench work. And I want to highlight the T-cell and B-cell discoverer. Jacques Miller, who works in the WEHI, was in the UK. He discovered the thymus was a functional organ. Prior to that, it wasn't. And then he had to go to NIH and prove it to their labs twice. He has not had the Nobel Prize, but he's received the Albert Lasker Award, which is 50% of people do get the Nobel Prize. A major step. We wouldn't be talking about T and B cells without his work. The next person I want to talk about briefly is the hybridoma, the monoclonals. Everything with AB comes from the work done in Cambridge. And this is the work done by Milstein and others. And it was to create this fused cell between a B lymphocyte and a tumour or a myeloma cell. And it created this and made the antibody. And you could select that out. The published paper that Milstein did that got him the award was in '75. But Milstein did another paper prior with Richard Cotton. And that was the first original paper. Richard Cotton came from Australia. He's an ag scientist. And he went back to Australia in '73, '74, and he didn't follow up the last 2 years. And he did wonderful things here. I've met him, and he saw the value of the biologics, because I met him on a tram one day, and he said, "George, how's it going with your biologics and Crohn's disease and rheumatoid?" He saw it happen. He died in 2015. An amazing, humble person. Did wonderful things in Victoria. So these two people, we wouldn't be here talking about our antibodies and our T cells, B cells without them. Let me tell you, psoriasis has changed. We understand it better. We have these monoclonals that we use, and the major ones that are doing really well are the anti-23s and anti-17s. They are changing people's lives. We can almost predict 90% to 100% clearance within about a few weeks to months. And their injections now every 3 months or every 2 months. So it's an amazing change. But we do have the comorbidities, and that's why we're treating psoriasis as well, and we understand them better. And these lead to other things, including their depression. That was a paper here that I had to bring in. I've got conflict here because it's a rheumatology group, all Greek, and they looked at the TNF blockers having an improvement in the aorta and the comorbidities, and that's been proven before with others. So we are improving their other health as well as we give the biologics and keep their skin clear. What about eczema? That's the next one off the block. We understand it better now. Chronic inflammatory disease, very costly, equal to diabetes, depression, bullying at school. The two cytokines that are major here are IL-4 and IL-13. And yes, we have a blocker for that, the dupilumab, and that is changing the world of atopic dermatitis in the last 18 months here in Australia. Been around in America for 5 years. Wonderful changes as well. We're treating their rhinitis and asthma if they have it, but their rhinitis get better because it's the same pathway. So that's been fantastic in eczema, changed our lives. I'm really happy I'm here giving my patients that because it's a chronic disease and we're having great results. They're just some scores and some results here. There are some little issues that if you block it too much, you might get a swing the other way and you might get some seronegative arthritis. So we have to watch. Rare, but it does happen. This is the balancing homeostatic effect of our immune system. So monoclonals, yes, I can't leave without telling you they were first used in cancer from melanoma. So another monoclonal effect. And the side effects are there with our skin diseases for autoimmune disease. Just to add on the AI in computers, pivotal work done by Peter Sawyer in Queensland, yes, collecting an AI probably photographs in melanoma. Just further, what's happening in skin tumours in the last 20 years? Well, we can treat superficial BCCs, in situ SCC and solar keratosis without a biopsy and just topical cream. And biopsy if it doesn't go away. That's my practice. And basically it's fantastic results in 80% of people. And here's one even with, I don't give it for melanoma, but it is given in some situations with lentigo maligna. And they're saying that the regeneration of the skin is actually getting better DNA repair with this molecule, which hits the toll receptor 7. And then hemangioma, an astute doctor in France watched a baby with cardiomyopathy given propranolol, and the hemangioma went away separately. And so that started the practice of topical and oral hemangioma in children in children, which has changed the world, as well as vascular anomalies. That's changed too. So going on a bit more, the second topic is the steroid going to be replaced? I believe it is. And I believe we're going to see the side effects of steroids that we've learnt as dermatologists, and you have yours as well in other specialties. They're going to go because there is a molecule, the JAK inhibitor, that will work across all organs, is anti-inflammatory, and can have a lot of effects without the diabetic risk, etc. And these JAKs, there's 4 major JAKs, 3 are everywhere, play a role in inflammation. The JAK3 is the one that causes polycythemia in mutations and myelofibrosis and platelet abnormalities. The table below shows all the cytokines and hormones the JAK receptor, the JAK intracellular receptor molecule plays a role in, so it's very ubiquitous. It's going to be incredible when we're using them, because here it is at the base of the receptor of a cytokine or a hormone, and the inhibitors are competitive that they're designing, and they stop the STAT pathway phosphorylating, and they reduce the cytokine production or hormone production. So that's what a steroid will do, to turn off protein synthesis, but this is specific. And we're going to see STATs come into being. Well, let's talk about STATs. It's a pseudokinase with a kinase given this double effect, and who discovered it? An Australian. Andrew Wilkes was working in the Ludwig in 1989, just opposite me, and he published this paper and called it just another kinase. And then it became the Janus kinase because it has 2 sides, one face looking one way, one face looking behind. Like today, we're looking behind and we're looking forward. January, Janus kinase. So it's called the Janus kinase inhibitors. And they're 2nd generation ones now. You can see here They're working in dermatology, in trials, and released already for atopy, alopecia areata coming, probably other autoimmune disease with the type 2, vitiligo topically and psoriasis topically. But look at the other organs, the other inflammatory organs. I've even put down renal here, yes, and I can see some papers coming through, respiratory as well as gastro-rheumatology and probably even endocrinology. You'll be using a JAK inhibitor of some sorts. So JAK inhibitors are here. We're seeing wonderful results in eczema. We see these patients in trials growing hair back that are absent for years. You can grow the hair back. It's not a scar. And vitiligo as well, bringing back the colour, and that's not even with UV light. So we're working there. Gene therapy, yes, that's happening in some diseases. This is a crippling disease in children where they scar because they lack an adhesion molecule. They end up dying in their 30s and 40s. They're the funerals I go to. And squamous cell carcinoma. Gene therapy has been muted with it for a while, but this paper came out recently where they engineered a herpes virus to carry the collagen receptor 7, the collagen 7 molecule, and you can change back the skin because that's what's missing in that particular recessive disease. So it's been a wonderful time. It's been fantastic to see, but it comes from understanding pathology and immunology and chemistry. But we might be actually changing the way we think of medicine by looking at cytokine pathways. That's been muted. We should be probably not thinking of organ specialties. This is a serious disease that we are trying to conquer with all these issues with it. Many specialists involved, bowel specialists and obesity, and I think we will be changing the organ specialties to be an inflammatory stream specialty eventually, and not separate ourselves. We're trying to do this in care at the Royal Melbourne. We call it the 3 III, so we put this patient in the centre, the doctors around the patient. And I think I'll stop there. Thank you for listening to me.
That was very informative and almost logically intuitive. May I please invite Professor Tom Katsimbos, who was also one of my consultants when I was an intern and resident at the Alfred, for his talk on what's new in respiratory medicine. Thank you.
Yeah, I think so. No, I think I will. Hi, everybody. I think I'm the last talk. Is that right?
You are. Lucky last.
So I've only got 10 slides. I've only got 10 slides because being the last person, I thought I should make it fairly quick, and so I'll honour that. Thanks for the opportunity. It's actually nicely turned out for me because when I was at the Royal Melbourne, George was a senior consultant for me, and both Genia and John and maybe some others were junior residents. So it was a long time ago, and I spent 12 years there, but I've been at the Alfred for 30 years, and I've had a wonderful exposure to many things. So what I've decided to do is 10 slides and focus on the idea of how much things change but don't change, and talk about certainty, uncertainty, and just give you a snapshot using the respiratory system, if you like, in terms of its anatomy, the airways, the interstitium, the vascular tree, then where that goes in terms of when we can't do any more, the issue of lung transplantation, and then what we transplant for, particularly some genetic diseases, and then the problem of lung cancer. And you can see that there'll be touch points for just about everything else that was talked about. Okay, so the first uncertainty was 3 years ago we had COVID-19, and there were a lot of things we didn't know about. It was a new coronavirus, and I won't spend a lot of time on it, other than to say that we had to make decisions not knowing a lot. And in that space of needing to make decisions, we went from the simple things to the not so simple things to the very not simple things at all, such as creating vaccines, creating diagnostic platforms that then gave us the virus diagnostics that we needed, and then the therapeutics. I won't spend each of these slides as a talk in itself. I just want to give you the gist of what I want to say. COVID-19 isn't one disease. Initially, it was a very different virus to what we had now. But what I'd like you to think about is all those big trials were done with that coronavirus, not the more recent coronaviruses. The coronavirus that we first saw, the initial native strain, and particularly the alpha strain after that, we had a lot of pathology in younger people as well as older people, but younger people, a lot of thrombotic disease in the lungs. The lung disease wasn't just a pneumonia. It didn't seem to be a disease that went from the upper airway down the epithelium into the lung. It was a disease that went from the upper airway, and because there was so little immune control, it became systemic quickly, and then the body had to deal with ways how to block something without having prior memory of it at all. And what that meant was the clotting system was very activated. And that's a very old system, very old, one of the oldest innate systems. Sponges have it. If a sponge gets infected, it walls off that part of the sponge. It hasn't got a circulation. It walls it off, ditches it out. The adaptive immune system, the later innate immune system and the later adaptive immune system is much, much more evolved. So the point I want to make is the trials for all these drugs were in the setting of a virus that was a lot more pathogenic. And so what we have now is Omicron, which is nowhere near as pathogenic, but does spread a lot, causes infections, and because of the way our immune system sees the world, essentially the upper airway, we hardly ever get sterilizing immunity. That's why the innate immune system is so important. That's also why, as soon as we had all the situation with a lot of people not, separating from others and properly separating, wearing masks and the social distancing measures, a lot of other viruses went down in terms of how frequent they were in the population generally, but also in our respiratory patients. But when those measures came back, then the viruses started circulating and with a real backlash. And the reason for the backlash was the local immunity had been lost, the local innate immunity. We'd seen these viruses before, but we don't create sterilizing immunity to them. And that's an important point. And it's particularly important for our respiratory patients who are chronically immunosuppressed. So I won't talk about the various pathologic understanding of the early coronaviruses, but I will say now the disease is very, very different. So one of the things I often get called about is, okay, someone's COVID positive, they've got a lung infiltrate, do I give him the sort of drugs we were giving earlier, high-dose dexamethasone, JAK inhibitors? And the answer is no, because most of the time it's a virus infection up here. It's not a viral pneumonia. And what it's done is it's precipitated a heart failure problem or a secondary bacterial pneumonia problem. And if you give the JAK inhibitor, even though it's very specific, for the immune system, it will create an immunosuppressed patient that then has another problem. And it's an important point. Airways disease. I just want to focus on two things here. The first thing is COVID was a natural experiment. If you looked around the world when everyone was really ramping down their societies because of what was happening, the level of pollution had dropped dramatically. Also, the number of viruses that were circulating had dropped dramatically. And so we had an opportunity to see these effects. You can't see something unless there's variation. So that allowed us to understand without the background air pollution or the background viral hits, what was happening to our respiratory patients in particular. The second point I want to make is we've gone over the years, maybe over the last 30 years, from a situation of lumping airways diseases together, whether it was COPD and asthma or whatever you like to call it, to splitting them. And there's a good reason for that. The reason is the more chronic airways diseases that don't have a strong inflammatory component as such, but are very driven by the exposure, then the thing we need to do for them is change the exposure, or change whether it's cigarette smoking or pollution or whatever. But the ones that have a very strong biological inflammation, what we've got to do, what worked for us were the steroids, just like in dermatology. And what we've done now is gotten a lot smarter in terms of targeting the particular pathway that will help us, whether it's Th2 asthma, anti-IgE, whatever it is, targeting it. And this was a lot of the work I did in Montreal when I was there for a couple of years. The next thing I want to talk about is interstitial lung disease. And it's very important to think about how we use language and why we categorize things. It's to do something with that information. And this is one of my favourite philosophers, William James, an American pragmatic philosopher. Every way of classifying a thing is but a way of handling it for some particular purpose. The art of being wise is the art of knowing what to overlook. So, interstitial lung disease. There's a lot of things that will cause interstitial inflammatory lung disease. And I'd like you to think of them in terms of a whole lot of things that we breathe in, allergens, things we don't know about, toxins, and things that the body produces, whether it's autoimmune disease or other toxins, and the lung sees because it sees the whole circulation. The first step is in trying to identify that, because it is a big move to stop that. Having passed that step, the second step is to work out whether there's chronic progression. And so we go to the lumping thing, because the evidence shows, irrespective of the cause, the chronic progression needs to be managed in and of itself, in its own right. And it's very similar to the chronic kidney disease with the markers of microalbuminuria and the EGFR falling, telling you there's damage that begets damage. And it's always a powerful thing to think about this, but nothing predicts for damage as much as the damage that you see. So the interstitial lung diseases over the last 30 years, they've gone from a splitting to a lumping scenario. Us focusing predominantly on what is progressing and then upping the ante in terms of what we can do for it. The third thing I'd like to talk about is pulmonary vascular disease. We have to think about it in terms of lumping and splitting, because the most common pulmonary vascular diseases we see are clots, secondary lung disease, secondary to lung disease as such, or secondary to heart disease. But the rare ones that are idiopathic in younger females predominantly, they have specific causes, and identifying them allows us to go to the specific biologicals, but they are rare. But if you diagnose it, it makes a big difference. The other reason to identify this is because if pulmonary vascular disease complicates any other lung disease, it becomes a huge problem. And as I said, identifying the specific lung vascular disease that has immunopathologic or metabolic drivers allows us to manage that, and I won't go any more into this. I just want to mention that the lung disease that involves pulmonary vascular disease, once we get that and it's a young person and there's no other, if you like, comorbidities outside of the chest, really very often our only option is lung transplantation. I started the offering in 1922, and for the last 30 years, I've seen an incredible change in the program. The early disease was all the young patients from the children's, where they didn't have a home really, an adult home, and it's one of the things that saved the Alfred in the mid-90s. So the cystic fibrosis children that all of a sudden were living later, they needed a home. The congenital heart disease patients that needed a lung transplant in those days needed a home, the Alfred. So that's how it started. And over the years, it's changed dramatically. And what I want to focus on here is the last 5 years, where you can see the numbers were continuing to go up until COVID. But more specifically, what made up what we did. And you can see this, you can't see it very well, but the septic lung disease is essentially cystic fibrosis. We hardly transplant anybody at the moment. We will. And the reason is because there are people that had significant lung disease before we started these magical new drugs, which I'll talk about next. The other ones that have improved a lot are the pulmonary vascular disease patients, where we have new treatments for those. The ones we're doing the most now are the older COPDs, because we haven't got any specific treatments. So who's the best candidate? The younger person with lung disease and only lung disease that hasn't got another option, essentially. The problem, of course, is post-transplant, the survival rates are good and have gotten better over the years, but they're not that great. So 50%, 5 to 10 year survival rates, more to the 10 if it's a great centre, more to the 5 if it's not a great centre. And there's a lot of immunology in that. And one of the most powerful things to think about is we do not do what the kidney transplant guys do. We do not match our HLA match our patients, and we still get this sort of outcome. So it's always useful to think about, wow, you don't match and you get these sort of outcomes. Of course, we have broad immunosuppression and we have the infection risk. So that's another story in and of itself. What have I learnt doing lung transplants for that time? It's all about the uncertainty. There are no protocols. There are no randomized controlled trials. The way you think of through a problem is very important. There is no average patient for that reason. Variation is a problem, but it's also an opportunity. It tells you something about what's going on in that particular person. Information is power, and the way you scenario plan and imagine and incorporate that with your discussions with the patient is everything in terms of what sort of relationship you have and where you may go with it in terms of the options. There are always two risks, doing too much and too little, and that's the right sort of way to keep checking where you're at. Cystic fibrosis is the genetic disease I mentioned. It's an incredibly common abnormality to have the CFTR gene abnormality. 1 in 25 Caucasians, and you have to ask yourself why. 1 in 25 have the Delta 508. All through Europe they have them. In Greece as well, in Turkey, everywhere, but it's a different one. And what's fascinating over the years is that we've learnt that this abnormality, this CFTR abnormality, a chloride channel, is in fact not only just a chloride channel, it's a stabilizer. It's a stabilizer of the cell membrane. And when you don't have specific immunity, having an abnormality at that level allows you to quickly become pro-inflammatory, which is a little bit like the upper airway stuff I was talking to you about. So there's a benefit, particularly for chronic diseases, that you can't get rid of. So that's why it tends to coexist and was amplified in the parts of Europe where there was a lot of tuberculosis. And there are a few other sort of associations. It's a disease that affects many parts of the body, and we've worked out ways to improve it improve our management over the years without going to the core. But once the gene was identified, we were able to go to the core. And now we have these CFTR modulator drugs that have changed the landscape completely. We started using them about 3 or 4 years ago, and they've done two things that are dramatic. The first thing is we started using them on compassionate use grounds when people were on a transplant list with 30% lung function. We've hardly transplanted any of those from 3 or 4 years ago, which is an amazing thing when you think of what we were comparing the life expectancy post-transplant. The second thing is they all hardly ever get an infection. They get an infection, but it hardly destabilizes them. Before they just get one and it'd go to the chest, they'd have almost an pneumonia immediately. And what's interesting is they've stabilized clearly the cell membrane in terms of what the innate immunity does. But more importantly, these are the survivors that we're seeing in the adult situation. And so the survivors have got other compensatory mechanisms that are still at play. And so when you improve it, they're super normal. They're quite impressive. We thought we'd get, with COVID, they'd have the worst COVID infections. They don't. Transplants do. Different problem. 2 more slides. So I started with infection, I went through physiology, and now I'd like to talk about, and it sort of touches on what we've already talked about, reimagining lung cancer. And what we've learned, and I think Professor Apostolopoulos talked about this, essentially we only see lung cancer once it's escaped the immune system. It's already done it. But it does it sometimes in ways that we can do something about. So if it escapes the immune system in a way because it hides from it or it blocks a key part of the immune system, as we heard, then we have checkpoint inhibitors that have an incredible use for us. And so now lung cancer is not only about doing the standard treatment things that we always did, but combining it with the precision aspect of medicine in terms of what's the abnormality here that if we've got a small molecule drug for, and have we got an immune checkpoint inhibitor possibility. Are we there yet? Of course we're not. There's a lot of, everything I talked to you about that happened in the last 30 years will happen again in the next 30 years. It'll in a different form, but in some form. And I think it's really important to think about the fact that science is a wonderful thing in terms of grasping a problem, controlling the variable so you can get to a better position. but it's always framed by the humanities and how we ask the question, which question we ask and how we ask it. And I think our Western and Eastern traditions help us with that, and particularly the Eastern tradition because of the breathing aspect in terms of its meditative approach to well-being. And I think with that comment, I go to my last slide, which is, and the planet needs to breathe too. That's self-explanatory. I won't go on with that.
You already know this, but you have given the late, great Don Esmore a heavenly Christmas present regarding stabilising the CTFR chloride channels. That's the one thing that I remember him saying when I was the Alpha Transplant Registrar. He goes, if you could just do that, if you could just stabilise that bloody channel, it'd be fine. And lo and behold, after he's passed away, it's happened. So, got a bit of a chill then. Thank you very, very much, everyone. You've cut that? Okay, it's been cut. On behalf of the presidents that are not here, thank you. And because the recording is stopped, I can say I'm sorry. Thank you very much. I really appreciate your efforts. I really appreciate your presentations. I'm sorry I couldn't give them the respect they really deserved. We honestly had an amazing set of presentations for the second half of today. I thought it was going to be the crescendo of the meeting. Thank you. And see you at the ball.